Good morning and welcome, everyone. Thank you very much for joining us for our 44th annual Midwest Pediatric Cardiology Society meeting and our very first ever virtual session. We've certainly all seen the world change significantly over the past year since our meeting last year in Kansas City. And we as a board of the Midwest Pediatric Cardiology Society were faced with a choice when it became clear we could not have our in-person meeting this year. Ultimately, the board of the Midwest Pediatric Cardiology Society decided our mission of education and dedication to the trainees was too important to cancel this meeting. It was not an easy task to move to an all-virtual meeting on short notice. So my first task is to thank the people that made that possible. The Midwest Pediatric Cardiology Society board members have been incredibly gracious with their time in organizing this meeting, reviewing and grading abstracts, and promoting the meeting. I need to particularly thank Hart University and in particular Terry Faulkner, who have been very generous with their support in allowing us to use their presentation platform and their experience in hosting webinars to pull off this session. Their support has allowed us to provide free registration for today's meeting. And if you haven't heard of Hart University, it is a free online learning center for pediatric and adult congenital training for all level of care providers. I'd also like to thank Allie Barnes and Dana McBride, who have worked behind the scenes to help put this program together. Before I hand things over for our presentations, just a few notes about how the virtual format will work. For today's sessions, we will have 24 oral presentations today, grouped into 4 sessions. During the breaks and over the lunch break, we will have some of the top-rated posters highlighted. They'll be available to view during the session, so stay connected. And all of the posters will be available to view on our Midwest Pediatric Cardiology Society website at MWPCS. Our website has been newly redesigned and you can find a lot of information on it. We would ask that you consider joining the Midwest Pediatric Cardiology Society. Your support helps fund this meeting and the trainee travel and abstract awards. The website also has important information for trainees on the categorical and advanced fellowship training programs available through the Midwest, so we can keep our best fellows here with us in the Midwest. As far as the other ground rules, you'll be able to post questions for the presenters in the Q&A box at the bottom of the Zoom screen. We will review those and read them to the presenters at the end of each session. And at the end of each presentation, you'll be able to vote on the abstract, and your voting will help determine the awards given after the meeting is over. With that, we will turn over to our presentations. Our first session is going to be the cardiac surgery session. And our first presenter is going to be Dr. Joseph Nellis, who is a resident in surgery at Duke University, and he's going to be presenting left anterior mini incision for congenital pulmonary artery and valvular anomalies. Go ahead, Joseph.
So first I want to say, thank you to the Midwest Pediatric Cardiology Society for inviting me to speak today. So I'm going to make it back to Iowa City, where I went to medical school and did my early training, although happy to be here virtually. And today I'll be talking about our experience here at Duke using a left anterior mini incision for congenital pulmonary arterial as well as valvular anomaly repairs. Maybe. There we go. For a little bit of background, minimally invasive approaches have largely helped transform adult cardiac surgery over the past 20 to 25 years, providing shorter post-operative lengths of stays, improved postoperative pain, as well as cosmetic outcomes. Although in congenital cardiac surgery, these advancements have been slow to kind of materialize for a number of reasons. First, anatomical constraints. Obviously, pediatric patients, particularly neonates, have a much smaller working space, making minimally invasive approaches difficult. There's a lack of FDA-approved support to help with some of these minimally invasive exposures that we'd otherwise have in adult, including percutaneous devices. And often with kids, there's a need for multiple repairs at once, making minimally invasive incisions difficult, which often allow you to focus on one area rather than multiple areas. And also, more importantly, historically, the focus on these kids has been survival, with little, I guess, forethought of thinking about when we have to come back for redo as an adult, what that would mean from a surgical approach, or from a cosmetic standpoint, or from a length of stay standpoint. Survival trumped all those historically. And now, as more adults are surviving and outnumbering a number of pediatric patients with congenital cardiac anomalies, these issues come to the forefront, and minimally invasive approaches become more important, and there's emphasis now being placed on them. Options do exist surgically for isolated septal defects and PDA closures. And then more recently, we've actually seen the rise of percutaneous interventions, particularly with valvular repairs. Although for kids who don't necessarily meet some of these requirements, or they're not allowed to proceed forward with some of these repairs, they're often still left with the median sternotomy for operative exposure. That led us to think, that we could probably end up doing some of these repairs through a mini incision or a mini thoracotomy. We kind of stay away from the idea of mini thoracotomy, given the thought of a large incision, and this is going to be a 5-centimeter incision that we've been utilizing through the left third intercostal space for repairs involving the right ventricular outflow tract as well as the main PA. So over that time, we've been working with our cardiologists to identify patients who would be good candidates for this exposure. Those candidates would be first and foremost patients who are not percutaneous candidates, patients who need a single intervention done, and who might have had a history of prior surgeries with difficulties from a surgical site infection standpoint, or diabetes in our adult population. When we see them in our clinic preoperatively, from a surgical standpoint, we review imaging with these patients, which everyone's going to be getting either a CT or MRI previously, as well as an echo with bubble study to identify any septal defects. And we discuss the risks associated with this procedure, which would be conversion to a median sternotomy, which they're seeing us at this time, median sternotomy would be the standard of care, as well as the risk of air emboli, even though all these patients would have negative bubble studies. From a surgical approach standpoint, all patients are cannulated for bypass peripherally through the femoral artery and vein. The femoral artery is cannulated via a sew-on Dacron graft. We then proceed through a third intercostal incision, 5 centimeters in size, dissect down to the pericardium while preserving the lima. And then once pericardium is appreciated, we go on bypass to decompress the heart and open up the surgical field. In a lot of these patients that are reoperative, the heart is actually paradoxically rotated, bringing the RVOT and main pulmonary artery into view on that just left parasternal area. In this case, we can see this is a patient history tetralogy of flow having a pulmonary valve replaced via this approach. In this case, we've learned that pulmonary valves, to decrease incidence of perivalvular leak, sewing or securing the valve on the RVOT side of the sewing ring is the best approach. Post-operatively, or once the repair is done, a single chest tube is placed in the mediastinum there, and the arterial cannulation site is repaired with a patch to decrease the incidence of stenosis down the road. Although pulmonary valve replacement after tetralogy flow has been our most common case for using this LAMI, we have also used it for a number of other cases. Two cases of note here were converted to one, a median sternotomy in a patient with 3 prior median sternotomies and an existing sternal incongruency that led to difficult dissection and hard approach, as well as another patient who had dextrocardia, was converted to a hemisternotomy intraoperatively due to difficulty in reaching the target anatomy. From our early experience, we appreciated that, our early results have similar results to the median sternotomy, particularly when comparing them to patients with tetralogy flow for repeat or redo pulmonary valve replacement. As you can see here in the top, noted a couple of surgical lessons learned, knowing that given a small view, working with perfusion as well as getting a clear bloodless field using drop suction for this. As I mentioned before, securing the valve on the RVOT side to decrease incidence of perivalvular leak, and then patch repairing the femoral artery. We also use bioprosthetic valves that are expandable for all these cases to allow for future expansion of these up as the children grow or as needed. Of note, on our median and interquartile range values listed here, operative time and bypass times are similar to those done through median sternotomy in our own institutional experience, as well as other single institution experiences reported in the literature, and noted to have 1 night in the ICU and 4 nights in the hospital on a median, which compared to our own institution and others is the same or better. And then at follow-up, there's been no incidences of phrenic nerve injury or musculoskeletal impairment. And then more importantly, for patients who have not had a prior median sternotomy, for patients who have not had a prior median sternotomy, the final incision's very small relative to what we'd anticipate from a traditional approach. From this, our experience, we've also learned that the ideal candidate is, as we said before, not someone who would otherwise qualify for a percutaneous approach, someone who only needs a single repair, ideally has not had a prior median sternotomy, although it's not a contraindication, someone with a lower body habitus to allow for easier angulation access to the anatomy of interest, and then someone who would, otherwise not want to undergo sternal precautions or 6 weeks of no upper body lifting. This has been a point that a lot of patients have said, I'd rather not have sternal precautions, and making this approach a little bit more appealing. Limitations, it's still, I think, given the operation, you're going to have a very similar operative time and bypass time. Although as we proceed forward in our learning curve, we anticipate this to go down as we become more familiar with this approach. So with that, I can turn it over.
Thank you. That was a great presentation. I'll just remind the audience they can post questions in the Q&A. We have one question. Have you seen any differences in infection or other morbidity related to this approach?
No, we include that in the kind of conversations on patient selection because it's something that just makes sense to us, that if we may have a smaller incision, we have a lower risk of surgical site infection. For the patients who have undergone this operation, we haven't noted any surgical site infections or concerns for infection. And also from a musculoskeletal standpoint, not having to disarticulate or shingle any ribs also doesn't precede or kind of predispose these patients to any of those complications as well.
And then maybe just a couple other quick questions. Is this just as feasible and possible in females as it is in males? Yeah,
right now it's about 50-50 as far as our experience goes with males and females. Although we don't see any anatomical constraints that make it more difficult in females.
Okay. And are there complete, you mentioned the ideal candidate, but are there complete contraindications that you found preoperatively that would exclude even considering this incision?
At this time, no. We have a low N value, I'd say, with 19 operations. And so I'm sure we're going to find some of those patients over time. Early on, our experience with patients with BMIs greater than 35, particularly when we've used a similar approach on the right side for anomalous coronaries. We're kind of continually seeing that larger BMIs make it more difficult. So we're really stressing with these patients that conversion is a possibility. Down the road, I anticipate we'll find out some of these things that the risk of conversion is so high, we probably won't offer this approach, but for right now, we don't know.
Excellent. Thank you very much. I'll just remind the audience they can continue to vote for the presentation. We'll leave that open for a few more minutes, a few more seconds. We will move on to our next presenter. Our next presenter is Erica Schmitz. She is a medical student at St. Louis University, who will be speaking to us on infection prophylaxis in congenital heart surgery, a comparison of two regimens. Go ahead, Erica.
Good morning. Thank you, Dr. Hill. My name is Erica, as stated, and I am here to talk to you today about the research that myself and my three partners in crimes, Dr. Armbrecht-Fiore and Dr. Huddleston, have been compiling over the past year related to infection prophylaxis, specifically comparing two different regimens. In terms of disclosures, I do have to tell you that this presentation today is getting me out of an 8 a.m. respiratory physiology exam. But despite what my student account might show, I actually have no financial interest to disclose today. So just starting with a 30,000-foot view, infection is a significant cause of morbidity and mortality in pediatric cardiothoracic surgery. And when we think about some of the factors that really put this patient population at an increased risk of infection, we think about things such as just the management that goes into the complex congenital heart defects that they often have, as well as due to the patient age and then oftentimes comorbid syndromes that include immunological compromise. These patients do have immature or abnormal immune systems. The estimated incidence of postoperative surgical site infection is 3 to 8%. And when we really look at the etiology of what causes these infections, we see that roughly 2/3 of those infections are gram-positive organisms, 25% are gram-negative, and roughly 8 to 10% are going to be culture-negative or polymicrobial. Despite the implications of a surgical site infection, as well as just the management that goes into that and the susceptibility of this population, a regimen of standardized duration for antibiotic prophylactic use in pediatric cardiothoracic surgery actually does not exist. And so this is problematic for a couple of reasons. And what we see is the existing regimens that we have are based on either a historical context or an institutional or even a personal preference by the surgeon. And these regimens do not exist or do not reflect what we understand about pharmacokinetics or physiology. They do not account for patient-specific risk factors that we may need to consider, especially given an era of very personalized medicine and increasing genetic analysis. And they also don't account for the necessary adjustments that we may need to make in some patients who have beta-lactam allergies, MRSA colonization, or ECMO use. The commonly utilized regimens that we do see amongst institutions have durations commonly of 48 hours post-operation or until the discontinuation of chest tubes and catheters and lines. And oftentimes when we really compare the timeframes there, they do end up being very comparable. Despite this, there is very limited research that exists regarding regimens of shorter duration. And so when considering why shorter duration regimens might be beneficial or what the relevance would be, we can reflect on these principles of antibiotic stewardship that have been proposed by the CDC over several years that really emphasize our role as clinicians to minimize the inappropriate use of antibiotics, as well as reduce overall antibiotic resistance. And this has been campaigned through their core elements for antibiotic stewardship, which are shown here. So taking this to my home institute, Cardinal Glennon Children's Hospital, January 2016 is where kind of the humble beginnings of this study started. And for me, I was sitting in organic chemistry class learning about the structure of benzene. But at Cardinal Glennon, they were in the process of instituting 2 prophylactic regimens with a duration based on surgeon preference, with surgeon A using antibiotics postoperatively for 24 hours and surgeon B basing that duration on the duration of chest tube insertion. And so outside of that duration difference, everything that these 2 surgeons were doing prophylactically was uniformly applied to all patients. And so when we kind of stepped back and looked at the way that our institution was performing surgery and postoperative prophylaxis, we recognized the opportunity to examine these 2 different groups, what the incidence of infection might be postoperatively, and then use that information to help guide us towards establishing an evidence-based protocol for a standardized duration of prophylactic use. So this led us to designing a retrospective analysis of all of the pediatric cardiothoracic surgery cases at Cardinal Glennon from January 2016, when these regimens began, to April of 2020. And this led us to identifying 2 cohorts with random allocation of patients to either Surgeon A, making them Group A for 24-hour duration of prophylactic use, and Surgeon B, Group B, the duration of chest tube insertion for postoperative antibiotics. So we retrospectively collected the demographics, operative and postoperative variables, and then looked for the incidence of infection, defining that by CDC criteria. Our hypothesis being that there would be no difference in the incidence of postoperative surgical site infection between these 2 groups based on that duration of antibiotic use alone. So in that time frame from January 2016 to April 2020, this led to analysis of 1,131 initial cases. Group A, again, having that fixed duration of 24-hour antibiotic use. Group B having a variable administration time period. Group A originally had 581 cases, B having 550, and we applied essentially 2 different exclusion criteria. The first being that we eliminated any cases which did not involve the insertion of a chest tube. And then we also applied a procedural criterion which eliminated any procedure which was not cardiothoracic surgery. So for example, a pectus excavatum surgery. And then we also eliminated ECMO decannulations. The reason for that being if a patient we counted a patient who had an ECMO cannulation, but we did not count their decannulation surgery, just so that we would not count them twice if they did end up developing an infection from that particular procedure. So when all of this was said and done, we ended up having 392 cases in Group A, 435 cases in Group B, which were then analyzed statistically. One of the first things that we did with our patient cohorts was to look at the demographics and identify, just to characterize our patients, but also to ensure that the populations were similar. And so we specifically looked at gender, age, and weight, and saw that there was no statistically significant difference in those demographic variables between our 2 cohorts. Specifically, our age was between 6 and 8 months between the 2 groups, and the number of neonatal cases that we had were about 20% in both groups. We additionally looked at operative and postoperative variables, specifically defining those and looking more intensely at those, of which higher durations or longer periods would be associated with a potentially greater incidence of infection or just a more complicated postoperative experience. And when we analyzed cardiopulmonary bypass, ICU days, and ventilation hours, we didn't see a statistically significant difference in those variables. We saw that about 70% of our cases were involving cardiopulmonary bypass. When we looked at operation duration, probably the p-value that we've all been staring at since I pulled up this slide, we did find a significant difference. And really when we analyzed this kind of finding, we decided that it would warrant additional investigation into the possible operations that were performed to kind of see where this duration was coming from, should we find a difference in the incidence of infection between our 2 groups. The results of our analysis found 21 cases of postoperative surgical site infection between both Group A and Group B for an overall incidence of 2.5%. Specifically, we see that 9 of those cases were in Group A, 12 of those cases were in Group B, and that result was not statistically significant. So we did not actually see that there was a significant difference in the occurrence of infection between these 2 groups. Looking at more specifically to characterize the infections, we saw that the majority of the cases, 78% in Group A, 92% in Group B, were superficial skin infections, a minority of those being deep sternal infections. We again looked at the age and weight of our patients and saw that there was no statistical significance in difference there, although the age and weight were lower than our main cohorts, which would be expected just to increase the likelihood of infection in that group. Additionally, we did look at the true difference in time period, since that was what we were also interested in. And we saw that the antibiotic duration, as we would expect, that median time period was 24 hours in Group A. Group B actually had a median duration of 72 hours. So it was pretty substantial in terms of the difference in time periods for application of prophylaxis. In our 2 infection cohorts, we also looked at those same operative and postoperative variables, and we didn't find any statistically significant differences between those variables in the groups. We saw that about between half and 2/3 of our patients were bypass who did develop postoperative infections, and we did see that their length of time in the ICU and the ventilation hours were longer, primarily concluded to be due to just the management of their postoperative infection. We also additionally looked at delayed sternal closure in ECMO cases, just as those are two additional variables that could potentially change a patient's postoperative experience and potentially increase the likelihood of infection. And we actually saw that that was a minority of our patients here. We also analyzed the etiology of the infections that we looked at and saw that we had these agents here, in 8 agents that were most commonly cause of the infections. In group A, we saw that gram-positives made up about 56% of those infections, with about a quarter being methicillin-sensitive Staph aureus and a 22% being coagulase-negative Staphylococcus. Gram-negative organisms were 33%, with that main agent being Pseudomonas aeruginosa, and then polymicrobial infections were 11%. And we saw that this was very comparable to the etiological layout in group B, where about 67% of those were gram-positive infections, and a greater majority being methicillin-sensitive Staph aureus, 33% there. Additionally, we had 25% gram-negative, with the main agent again being Pseudomonas aeruginosa, and then 8% were polymicrobial in group B. So in conclusion, we can accept our null hypothesis from the results we've demonstrated today. There was no significant difference in the incidence of postoperative surgical site infection based on the duration of prophylactic antibiotic use. And so with this information, we would recommend adopting a standardized protocol of 24-hour duration for postoperative antibiotic use, just to, again, reinforce and promote those principles of antibiotic stewardship and maximize our role as clinicians to reduce the development of antimicrobial resistance in what is a very susceptible population. Future directions with this research, we've identified that we can go back and really look at those delayed sternal closure or ECMO patients and kind of view those as subpopulations that, because of the difference in their postoperative course, as potential groups who may benefit from a slightly different timeline of prophylactic duration in discontinuation as compared to a patient without either of those interventions. And so with that, I thank you for the opportunity to present today, and we'll open the virtual floor for questions.
That was outstanding. Thank you. I think one of the clearest signs that we don't really know we're doing something well is that there's significant variation between providers and between centers, and I think that certainly applies to the use of postoperative antibiotics. We will take any questions if you put them in the Q&A box. While we're waiting for that, can I ask a clarifying question? The groups were randomized, correct?
Yes, randomly allocated to the surgeons, yes.
Was that based on any factors for randomization, or just completely randomized to surgeons?
Completely randomized, yes. We didn't have any factors that we used to allocate.
Okay. And then what, obviously this is a difficult subject to study because the incidence of your outcome is fairly small, so you have to study a large population. What steps are you planning to use to take this more national?
Well, so based on the information that we have, I think that we could definitely apply this on a larger scale within our facility alone, looking at a few more variables in terms of really getting into, I think we could look more in depth at the particular procedures and then forming more subpopulations, potentially expanding this to other facilities, sharing this research even across St. Louis to start with. And then as we gather more information and collect from larger patient populations, potentially spreading this regionally and then hopefully nationally if our results continue to show that a 24-hour duration would be equally as efficient in managing postoperative infections.
That's great. I think this certainly fits within some of the collaboratives that are out there that are designed to standardize care and define best practices. So this seems like something that would be very good for a PC4, a Pediatric Cardiac Critical Care Consortium project, where they could get you better data on the regimens and then track that over time. We have a few more questions in the chat box, so we'll try and get to those. Did you assess the risk for infection or the distribution of groups on the complexity of surgery or the distribution of cyanotic heart disease?
So we actually did not, just based on the time period we had between finishing this initial analysis, we actually did not look in depth at the procedures. I think that's definitely another additional future direction that we can take this. Just given that the analysis would be relatively complex. You might have a patient, for example, if a patient has requires a VSD closure, they might not only need a VSD closure. So it would require very specific, really getting into the nitty-gritty of how we would define procedures, as well as looking at patients who do have multiple procedures to really analyze that on a deeper level. That's definitely a future direction that I would like to take this. And so that's something that we will be doing, but did not have done for this particular presentation today of the results of just incidence of infection.
Great. And one final question, which I think is very interesting, is once you had the results, did you get any pushback or opposition from the surgery team who maybe wanted a longer duration of antibiotics, or did they accept the results and were happy with the 24 hours?
So we actually, we did not have any pushback. They were actually very glad to hear that the results, just comparing the two antibiotic prophylaxis that we have, that there wasn't an incidence of, or there wasn't a difference in the incidence, and they were very willing to adjust and reconsider the more traditional track that we see in a lot of institutions in the name of the antibiotic stewardship, but also just seeing that you know, we can really do a lot in minimizing the duration by, in our two surgeons alone, the difference was 48 hours. And so we didn't really experience any pushback. However, that was kind of also where we formulated some of our future directions in looking at ECMO patients as well as delayed sternal closure, that those particular populations might warrant additional investigation just based on the complexity of their postoperative course. And so that would be probably the only thing that we would consider in terms of really adjusting that further. But for the most part, no, it was well accepted.
Excellent, thank you.
Thank
We'll move
you.
to our next presentation. Our next presenter is Shari Madhusesina. Shari is going to be, or is a medical student at Medical College of Wisconsin and worked through Children's Wisconsin on her project entitled Valve-Sparing Aortic Root Reconstruction in Children and Young Adults.
Thank you very much for having me. Today I'm talking I did this summer on valve-sparing aortic root replacement in children and young adults. Before I get started, I just want to give a brief explanation on what valve-sparing replacement is in the next few slides. So the valve-sparing procedure is a cardiac surgery in which the aortic root, so the part closest to the heart, is reconstructed while the patient's valve is kept intact. The surgery is starting to become a substitute for composite root replacement, in which an artificial graft are used to replace the aorta. One of the reasons why it's a good alternative is because it has fewer risks and less of a need for anticoagulation. Even though the surgery is so useful, we don't really have much information on how well the procedure works in patients with bicuspid aortic valves. And so the surgeons at Children's Wisconsin are performing the valve-sparing procedure with bicuspid aortic valves experiencing moderate and severe insufficiency so that we can observe the outcomes in these patients as well. Okay, so in terms of how the procedure is done, we start off with our heart, which has a dilated aortic root and an asymmetrical bicuspid. And then figure 2, the opened up and the coronary arteries are harvested. And then our sinus of Valsalva graft is sized, and this is usually a 30 millimeter graft, but varies from patient to patient. The valve tissue and the commissures are then suspended within the graft, and we've got a total of 9 different sutures that are lined up. And then in figure 5, the sinus of Valsalva graft is slid down over the valve and the appropriate heights are established. All the sutures are then pulled through, and since this is an asymmetrical bicuspid valve, our third commissure is lower than the others, and this gets kept where it is. And the whole thing then gets secured using a hemostatic suture line. And then our left coronary artery gets sewn back on. And our right and distal coronary arteries get sewn back on. And the distal anastomosis to the remaining aorta is also completed. And then we've got our completed heart. Sorry, I believe there's a slight lag, but yeah, here we're complete. In the next slide, I've got a video of valve-sparing aortic root replacement on a patient with the bicuspid aortic valve. Let's see if we can get that loaded. Okay, so here we're suspending the third commissure. And then we've got a saline test being done, and this is before the hemostatic suture line is placed. You can see that it's an asymmetrical bicuspid valve. Essentially what happens next is that the hemostatic suture line is placed, and we can see after that that it's a fully functioning heart. And yeah, we can see that the surgery works well. Let's see if I can go to the next slide. Oh, there we go. Okay. So for the purposes of my research this summer, it was to analyze from patients who underwent the valve-sparing procedure and to essentially see whether there was a difference in how durable and safe the procedure is in patients with bicuspid versus tricuspid aortic valves. So to identify the patients who had this procedure done at Children's Wisconsin in the recent past. We had 47 such patients between 2003 and 2019, and we started constructing a database of clinical information about these patients by looking through the patient charts on Epic. Echocardiogram data was really important for our study because we needed to know how well our patients' aortic roots were functioning. And so to improve the accuracy of the results, we had 2 different people collect this information, and that was one of our cardiologists at Children's Wisconsin, and the other was me. Through the collection of all this data, we were aiming to look at things like how many patients died due to complications from this procedure, how many needed to be operated on again in subsequent years, and how many patients' valves experienced higher levels of insufficiency. So again, we had 47 patients who underwent the valve-sparing aortic root replacement. Oops. Let's go back. 18 patients had a bicuspid valve and 29 had a tricuspid valve. And we were looking at patients between the ages of 7 and 48 with the mean age of 20. Don't know if I can get to the next slide. Okay, there we go. So this is data on the age groups of our patients broken up into whether they had a tricuspid or a bicuspid valve. Yeah. So we had a total of 47 patients with 29 tricuspid and 18 bicuspid valves. More than half of our patients were between the ages of 10 and 18, although a majority of the rest were adults younger children as well. A large majority of our patients' aortic roots were reconstructed using a sinus of Valsalva Dacron graft, while 3 were reconstructed with a straight Dacron graft. All right. Now let's go back. Aortic valve repair was performed at the time of the root replacement on 3 out of our 18 bicuspid valve patients and none of our tricuspid patients. And aortic root repair was basically when actual sutures were placed on the valve and there wasn't just an incision made. And this data did show a statistically significant difference.
Our next presenter is going to be Hank Worth. Hank is a resident here at Cincinnati Children's Hospital, and he will be speaking to us on his project entitled Increasing Use of the Right Ventricle to Pulmonary Artery Shunt for Stage 1 Palliation, a report from the NPC QIC.
All right, it's nice to meet everybody. As he said, my name is Hank, and I'm here to talk about our study. Let's see if we can get the control going here. So we have no conflicts of interest to disclose. So stage 1 palliation of hypoplastic left heart syndrome and related functional single ventricle heart defects typically has 3 options. These include the Norwood operation with the modified Blalock-Taussig shunt or the BT shunt, the Norwood operation with the RV PAS or right ventricle to pulmonary artery shunt. It's also called the SANO, and the hybrid procedure. While outcomes are getting better, stage 1 palliation is still one of the highest risk congenital heart disease surgeries. Stage 1 and post-stage 1 morbidity and mortality have been linked to multiple preoperative risk factors. These include patient-specific variables like birth weight, as well as center-specific variables like surgical volume. One question that has received a lot of attention is the contribution of shunt type to these disparities in post-stage 1 outcomes. And many studies have looked at this question before, but most of them have been small, single site, and retrospective in design. The single ventricle reconstruction trial, however, was a prospective, multi-center, and randomized trial that was launched to follow and compare outcomes in patients who underwent a Norwood with a BT shunt versus a Norwood with an RV PAS. Enrolled 549 patients, with initial recruitment occurring in the 2006 to 2008 timeframe. The schematic that we have here represents the 3 main outcomes of the SVR trial at each of the 1, 3, and 6-year follow-up visits or appointments. You can see in row 1 that the transplant-free survival initially favors the RV PAS, but that this advantage wanes over time. In row 2, you can see that there's initially no difference in right ventricular function, then a change to favor the BT shunt, and then a change back to no difference. And finally, in row 3, you can see that the RV PAS consistently has increased frequency of reintervention. So overall, what I want you to get out of this schematic is that simply that the data from the SVR trial continues to evolve over time as the cohorts continue to age. And so one follow-up question then is, how has surgical practice changed over this time period? And is it changing to account for findings from the SVR trial? This question became our primary aim, to assess the change in the type of stage 1 palliation performed over time from pre-SVR trial to present. We outlined a secondary aim to assess associations between patient and center-dependent variables and the type of stage 1 palliation that's performed. And finally, we also wanted to compare outcomes between the 2 shunt types using our own data set. So we conducted a secondary analysis of the National Pediatric Cardiology Quality Improvement Collaborative Database, or the NPC QIC. This is the first multi-center quality improvement collaborative in pediatric cardiology. It was established in 2008 and collects data from over 60 pediatric cardiology care centers. its database is divided into a phase 1 and phase 2. Phase 1 includes patients who were discharged from the hospital after stage 1 palliation, but it does not include those who were admitted for the entirety of the interstage period or those that died while admitted. Phase 2 included all patients who were expected to require stage 1 palliation. Did the PowerPoint disappear by any chance on everybody? There we go, okay. So overall, we identified 3,500 children who met our inclusion criteria of undergoing a stage 1 with either a NOROD with a BT shunt, a NOROD with an RVPAS, or a hybrid procedure between 2009 and 2019. We collected our data via automatic extraction, followed by manual review to unify the phase 1 and phase 2 databases into a combined single data set. So we collected several covariates related to patient-specific data, surgical center data, and data on outcomes, and those are listed here. And moving to the results of our study, for our first aim, again, we assessed the change in type of stage 1 palliation performed over time. We found a statistically significant increase in the use of RVPAS and decrease in the use of BT shunt over time with a p-value of 0.02. Starting in 2009, just to kind of go over the beginning and the end of this chart here, in 2009, we saw that about 37% of all Norwoods were conducted with a BT shunt and about 53% with an RVPAS. By 2019, this had changed so that BT shunts were down to about 28% and RVPAS were up to about 62%. And then the hybrid here we can see is essentially unchanged, around 9 to 10%. Looking at our second aim, we assess the associations between patient and center-specific variables and the type of stage 1 palliation that was performed. In our univariate analysis, we found statistically significant differences between type of stage 1 palliation that was performed and mean gestational age, HLHS subtype, or anatomic subtype, and surgical center volume. We did not find significant associations between the type of stage 1 performed and other extracted covariates that we collected, and these include things like birth weight, sex, ethnicity, race, genetic anomalies, or the presence of an extracardiac organ system abnormality, and so those aren't listed on this chart right here. In our multivariate analysis, we use multivariable logistic regression models with RVPAS as the referent category. We excluded hybrids from this analysis because they are typically performed in a different population of higher risk surgical candidates. We found that compared to the RVPAS, the BT shunt was more likely to be utilized in surgical centers with an increased volume with an odds ratio of 1.2, and in patients who are male with an odds ratio of 1.3. And conversely, we found that the BT shunt was less likely to be utilized in patients with one or more extracardiac organ system abnormality with an odds ratio of 0.67. And for our third aim, we wanted to assess the association between outcomes and the type of shunt that was received. Here we compared outcomes between the BT shunt and the RVPAS. Once again, we excluded the hybrid group from analysis. We found that the use of the BT shunt was associated with longer post-stage 1 length of stay and increased interstage mortality or transplant rate. We also noted that the BT shunt was associated with an increased post-stage 1 discharge weight. We found non-significant associations between shunt type and duration of mechanical ventilation after stage 1, number of interstage readmissions, and not listed here, interstage cardiac arrest events, interstage ECMO requirement, and overall number of interstage adverse events. So before we get to the summary, just a couple limitations. This was a retrospective study, and though it's large and variable powered, it does remain associative. Secondly, the MPCQIC is a large and robust database, and it definitely has a wealth of data available for mining. However, there are inconsistencies between the phase 1 and phase 2 databases, and that did require manual review in order to combine them and let them serve as a foundation for our own project. And finally, we do wish that we could have included the hybrid procedure in our analysis, particularly on those that compared outcomes. However, literature does suggest that any inclusion of the hybrids in a statistical analysis should account for their higher preoperative risk. Let's get, sorry, one more slide or two more. Here we go. So in summary, in our evaluation of 3,500 children who underwent stage 1 palliation for single ventricle heart disease and related functional defects between 2009 and 2019, we found an increasing utilization of RVPAS over this time period. We found an increased likelihood of the MBTS or the BT shunt being used in higher volume centers, in males, or in patients without extracardiac organ system abnormalities. We found that the BT shunt use was associated with longer post-stage 1 admissions and increased interstage mortality and transplant rates. The results of our study imply that the SVR trial is indeed informing surgical practice nationwide, as we see an increasing use of the RVPAS. It implies that surgical center volume does influence shunt selection, with higher volume centers favoring BT shunts. Likewise, patient-specific risk factors also influence shunt selection, with patients who have extracardiac organ system anomalies more frequently receiving the RVPAS. And finally, it confirms that the RVPAS has a favorable short-term outcome profile for morbidity and mortality compared to the BT shunt. And that's all I have for you guys. I want to acknowledge my mentors here who helped put the project together, as well as the MPC QIC research and data team. And I can take any questions.
Thank you, Hank. Great talk. It wouldn't be fair for me to ask any of my own questions to Hank, as I helped him on this project. So if there are any questions, please post them in the questions and answer. And don't forget, you can post those questions at any time during the presentation. You don't have to wait till the end. We'll be able to see them and assess them throughout the presentation. And then please continue to vote for the quality of the presentations. Those will be taken into consideration when we decide on awards following the session today. We do have a question. Based on this, are there any situations in HLHS infants where BT shunts should still be considered? Tough question, Hank.
Yeah, I think it's a tough question. I think where our data speaks the most about that is essentially surgical center volume and kind of we didn't specifically assess for surgeon specific volume, but certainly for hospital volume. And so for some reason or other, it does seem that they continue, or centers with larger volume continue to do BT shunts a little bit more often, whether that's because of experience and kind of comfort in the experience. I think that's probably one thing that's probably most at play. As far as a specific patient-specific criteria, I can't see anything that would make me think from our data that that they should more often receive the BT shunt than another one.
I think there was a follow-up to the SVR trial, a subsequent analysis by Tweddle et al. That showed better outcomes when there's aortic atresia with the RV to PA shunt, and potentially better outcomes with aortic stenosis with the BT shunt. So I know that's become his sort of decision point, is the presence or absence of antegrade aortic valve flow. But I think everyone has certainly interpreted interpreted the SVR slightly differently.
I saw Dr. Al-Sayed had a question. I believe we did not collect post-randomization ventricular function data on the two groups, only because I think that was very difficult to pull out of the MPC QIC database. But
yeah, I'll just repeat his question. Have you noticed any difference in ventricular function between the two groups? And I'll just say, based on the database, that was a factor that got added later in phase 1. So many of the patients are missing that data. And while we have it, we did not include it because so many patients were missing it. All right, great job, Hank. We'll move on to our next presentation. Our next speaker is Jonathan Lyles. Jonathan is a medical student from the Medical College of Wisconsin who worked at Children's Wisconsin on his project, an institutional review of complex tracheal reconstructions performed on cardiopulmonary bypass.
Hello, I'm Jonathan Lyles, and I'm reporting on the research I did this last summer, a retrospective study on complex tracheal reconstructions. And all these are performed on cardiopulmonary bypass. So between June 2004 and December 2019, there were 36 separate procedures done in 33 patients. And this method of tracheal reconstruction using cardiopulmonary bypass has proven essential in the treatment of a variety of complex tracheal anomalies in children. These include long segment tracheal and bronchial stenosis and a variety of extreme congenital tracheal abnormalities, including extremely long segment tracheal stenosis, tracheal duplication, Christmas tree trachea, and complete tracheal agenesis. And I'll go more into depth about these different morphologies and the surgery we did to correct them. So we collected data preoperatively, at discharge, and at last life follow-up. And we had a lot of different things we measured, but two of the main ones were level of respiratory support and clinical respiratory status. And you can see here that we rated the patient as their highest level of, for level of respiratory support, no support, bronchodilators, supplemental O2, and so on. And that's a scale of, if you have no support, that's ranked as a 0, bronchodilators 1, and so on. And you can see also in clinical respiratory status, we did the same thing, starting at no symptoms, coughing or wheezing, occasional respiratory emissions, multiple 2 or more respiratory emissions within previous 6 months, acute life-threatening events, and mechanical ventilation. And this is a summary of all the different procedures we did. You can see that slide tracheoplasty, which is a very common method of alleviating tracheal stenosis and tracheomalacia. It's a very common one, and it's the method we use the most often. But there's a couple other ones that are useful in very specific morphologies, and quite a few of these are novel procedures created by our institution for these very unique congenital conditions. I'll start with the long segment slide tracheoplasty. So you can see here that this patient has an abnormal trachea. It actually looks like this is a bronchial sui, which is it's a bronchus that branches off prior to the carina. You can actually see the carina is down here. Although this is very stenotic, this is actually the true trachea branching off and having the carina. And you have this bronchial sui, which is looks much more healthy, but is actually not supposed to be there and is abnormal. And they almost always go off to the right side, and they aerate the upper portion of the lung. In this patient, what we did initially was we harvested this lower bronchus down here, then made an incision up, and we were able to sew those together in a way that made it shorter, but was able to widen it to alleviate the breathing issues that this patient had. And actually in this patient, we didn't have quite enough material coming from here, so we also had a rib graft that we put on to complete it. And this is the final part of this surgery is what it looked like. And later on, we created a novel technique to deal with bronchial sui. And this is actually the same patient from the first graft come back. And although this was a stable setup, we thought that this patient could do better if we did this novel procedure side-to-side tracheal reconstruction. which involves making a medial incision on the true trachea, going up to where it separates from the bronchial suey, then down the medial side of the bronchial suey, and sewing those together to form one large trachea. And you can actually see here that looking down at the trachea, you get this very interesting trifurcated carina, where it's going off this way, and down this way. But this this procedure makes these bronchial sueys much more stable than they were before, and makes it a much more usable airway. And one of the more rare versions of side-to-side tracheal reconstructions are whenever there's a bilateral bronchial suey. It's relatively straightforward compared to the other side-to-side, is you just do the, on this side, the lateral incision down to the medial bronchial suey, and then you sew them together like before. This is just showing that we use a saline solution to ensure that there's no leakage. And then you do the same with the other side. And this actually comes up with a very interesting quadricated carina, but this is a much better airway that is far more functional for these patients. The esophagocarinoplasty is a very novel procedure, and it is done in response to a patient that has complete tracheal agenesis. So you can see here that we have the esophagus going down the stomach, and instead of an actual trachea, we have just a tracheal esophageal fistula, which is not a very stable airway, and this requires very early on, incredibly early on intervention. So what we'll do is we'll put an endotracheal tube, staple off the stomach, and separate the stomach, and realign the cuts, or cut off the tracheoesophageal fistula, and resection the esophagus in order to give a much better connection between the esophagus and the carina. And we have this graft which allows the esophagus to be widened and to take on the form of trachea. Since the trachea has its ridges that keep it open, it makes it a much better airway, and the esophagus doesn't have this. So we simulate this with this graft that's sutured out, opening up the neotrachea. Then we sew it on, and this ends up with an esophagus turned into a neotrachea that allows the patient to breathe through it. And actually, the first patient that we did this on, we've done this only on 2 patients. The first patient, it's been a number of years, and they were actually able to take out the graft, and the esophagus has adapted to be a more firm airway that isn't going to collapse on itself. What we have here is a Christmas tree trachea, also known as anterior posterior trachea. And it's fairly similar to the bilateral bronchial suey that we saw earlier. But you can see one difference is, this is actually the true trachea. Again, it's stenotic. You'd think that this was just the outgrowth, but the true carina is on this. And you can see that instead of having it branch off prior to the carina, there is a complete trachea that is branching off and then aerating the upper lungs. So it is a different morphology than the bilateral bronchial suey. What we do here is we start off by harvesting the true trachea at its connection to the posterior trachea. And we'll make 2 upside down wide cuts, one on the anterior aspect of the posterior trachea and one on the posterior aspect of the anterior trachea. And this allows us to sew these together into forming one trachea that's wider with a single carina leading down to the lungs. And we've only performed one of these so far. It's a very novel procedure. So the results were very promising. Our median follow-up was 3.38 years out. We found a significant decrease in mean level of respiratory support required at discharge and last life follow-up compared to preoperatively, and significant improvement found in mean clinical respiratory status at discharge and at last life follow-up compared to preoperatively. And the freedom from CPAP, BiPAP, or greater support was 70% at last life follow-up up out to 13 years. So you can see that in the graph. Using those rankings of level of respiratory support that I explained at the very beginning, preoperatively the average was at 3. And you see that there is a very significant decrease, statistically significant, for at discharge, and it stays in the same range for last life follow-up. And using a similar graph on clinical respiratory status, you can see that there's a statistically significant improvement that stays in the same range from discharge to last life follow-up. And this shows the freedom from CPAP or BiPAP. And the way that this graph works, which I didn't understand it the first time I saw it, but whenever we no longer have data for a patient, this marks the point. So if a patient had their surgery 1 year ago, at 1 year, we don't have any more data for them. So there's this mark. So as we get out here, we're actually assessing less patients because many of them have not had that amount of time from surgery. But you can see that the freedom from having CPAP, BiPAP, or greater support was around 70%, like past a certain date. And that's very good. And it doesn't get worse after that point, which means that not only these surgeries provide support in the short term, in the long term, these patients aren't going to be having more issues related to trachea. And this is a survival from mortality. And you see that a year out, these patients have no deaths. So after the surgery, this is a stable trachea that can provide good aeration for these patients. So the conclusions show that this data shows immediate improvements in the respiratory needs and status of patients following surgery. These results do not appear to diminish over time from discharge to last life follow-up. Are there any questions?
Excellent presentation. Thank you, Jonathan. While we wait for some questions in the Q&A box, do you have data on what the postoperative course is like for these patients? How long are they in the hospital? How long are they intubated and mechanically ventilated?
Yeah, we do have that data. We didn't put it into this, but yeah, we did all that data, and that actually would have been good to put in, but we didn't, just for brevity's sake. But yeah, there was a fairly wide range of the amount of time that they would stay in the hospital, and for future reference, yeah, I probably will put that in there just to give a more full picture.
Yeah, I think that would be very helpful. We have a couple questions in the chat or in the Q&A. Did any of these patients have concomitant congenital heart disease? And if so, how did those patients do?
That was actually very common. There's a couple different conditions that are heart conditions, especially that these patients have. And we haven't analyzed how they did versus how like the general population, but there's a very strong connection with congenital heart disease, and that should be the next route of inquiry that we go into.
Excellent. We'll move on to the next presentation then. Thank you, Jonathan. Our next presenter is Nicholas Brockman. Nicholas is a medical student from Creighton Medical School in Omaha, Nebraska, and he is presenting his project, Leaflet Extension Use in the Pediatric Aortic Valve Repair, a Retrospective Study. Thank you, Nick.
Right. Hello, everybody. Thank you, Dr. Hill, for the introduction. And thank you, Midwest Pediatric Cardiology Society, for having me here to speak today. As mentioned, my name is Nick Brockman. I've been working on this project titled Leaflet Extension Use in Pediatric Aortic Valve Repair with Dr. Yetman, Dr. Hamill, and Dr. Danford of Children's Hospital and Medical Center in Omaha. So let's start with some important background info that's helpful for understanding the utility of this project. In pediatric populations, there are limited durable treatment options available for children with aortic or neo-aortic insufficiency. Additionally, there are some issues with the treatment options, options such as aortic valve replacement, including limited number of available valve sizes, mismatch between patients and prostheses, children outgrowing their previous prostheses, and complications related to anticoagulation post-surgery. Aortic valve repair is a treatment option that has emerged as a possible alternative to aortic valve replacement. In 2016, Dr. Hickey and the Toronto group assessed a cohort of pediatric patients who underwent aortic valve intervention for aortic insufficiency and compared the outcomes in those undergoing aortic valve repair. Of the 46, 39 of those had leaflet extensions. Aortic valve replacement with either mechanical or bioprosthetic valve, and the Ross procedure. The three patient groups were of similar age as shown in this slide. Freedom from surgical reoperation was 64%, 51%, and 100% at 6 years post-surgery for aortic valve repairs, replacement, and Ross procedures respectively. While 1/3 of children who underwent a repair required repeat surgery within 5 years, on average, aortic valve repair offered a delay to repeat valve replacement of about 5 to 7 years, with no patient factors that reliably predicted repairs that would fail early. Notably, repair was also associated with a trend toward increased annulus size relative to the Ross or the valve replacement at 6 years. So in this project, our aim was to assess the outcome of patients undergoing aortic valve repair with leaflet extensions at Children's Hospital and Medical Center in Omaha. We also sought to assess the mechanisms of failure, the time to failure, and to determine if there were any predictors of early valve failure that we could find. So looking at the patients in our series, we were able to analyze 44 patients who underwent aortic valve repair with 63 leaflet extension procedures within the last 15 years. The slide says 2010 to 2020 because that is the data that we had in EPIC, but we went back into paper charts from as early as 2005 to get some more data. 60% of the procedures coincided with additional surgical procedures performed at the same time. The average age of our patients at repair was 9.5 years old, with the initial repair occurring at an average of 8.8 years. Of our 44 patients, 14 required more than one valve repair, while 4 underwent greater than 2 aortic valve repairs. Thus, our total procedures is 63 when there are only 43 patients. Of note, 48% of our patients had a prior balloon valvuloplasty. The underlying cardiac conditions in our cohort included 28 patients with bicuspid aortic valves, truncus arteriosus in 5, single ventricle or some other complex congenital heart disease in 7, and rheumatic heart disease in 4. There are 4 surgical materials used primarily to reconstruct the aortic valve leaflets in our series. Autologous pericardium was used in a quarter. Oh, sorry. My slides got mixed up a little. So this slide is showing that the surgical indication. So there were 40 procedures where the indication was aortic insufficiency, 3 where aortic stenosis was the indication, and 20 where it was combined stenosis and insufficiency. Okay. So this one is showing the materials that I started to talk about. The autologous pericardium was used in a quarter of the surgeries. Core matrix, which is a decellularized porcine small intestinal submucosal matrix, was used in the majority, 43%. CardioCell, which is a pericardial scaffold from bovine pericardium, used in 22%, and PhotoFix was used in a few, and that's a decellularized bovine pericardium treated with photooxidation to increase collagen cross-linking. And then the final 3 procedures used Gore-Tex, bovine pericardium, and the Tyke acellular xenograft, respectively. So in looking at outcomes, 94 of our patients were discharged with a repaired valve. 7 patients had immediate valve failure either in the OR or prior to discharge, and either underwent a repeat repair or an alternative procedure if valve repair was not thought to be feasible. The vast majority of our patients had no or mild aortic insufficiency at the time of discharge, and the peak aortic gradient at the time of discharge was low, with an average peak gradient of 20 millimeters of mercury. This slide represents time to moderate valvular dysfunction or death in those patients who died prior to the onset of moderate dysfunction. The mean time to moderate dysfunction or death was 34 months, as seen there. And then this slide demonstrates that the median time to subsequent aortic valve repair was 48 months. So in our study, there were 5 patient deaths and 1 patient heart transplant in patients with varying ages and underlying anatomy. Of note, endocarditis was implicated in 3 of these. The first patient listed 25 months after their valve repair. The third patient listed 18 months after their valve repair. And the final patient listed on this table 2 months after their 4th repair. So in looking at predictors of mortality, endocarditis occurred in 13% of the patients or 11% of the procedures and was not surprisingly a predictor of mortality as shown here. In addition, moderate or greater aortic insufficiency at discharge was also found to be another predictor of mortality. So in focusing on whether there were any predictors of valve failure, underlying cardiac disease, age, surgical indication, prior balloon valvuloplasty, and type of surgical material used were not related to time to moderate dysfunction, time to repeat surgery, or death that we could find. On multivariate analysis, endocarditis was the sole predictor of time to any event, including death or subsequent surgery, with a hazard ratio of 3.0. So just to briefly highlight some of our patients can do quite well after the aortic leaflet extension procedure. We've demonstrated here the top, there's 11 listed, but the top 8 patients from our series have no evidence of valvular dysfunction at up to over 9 years. And then there was 1 patient listed, number 9 on this table, who got 14 years out of her repair before going on to have a biologic valve replacement. So these are some of the successes that we've seen with leaflet extension procedures at our hospital. In conclusion, complex aortic valve repairs with leaflet extensions can be performed in children with aortic valve dysfunction with good immediate term results. Overall, though, longevity of the valves is low. While endocarditis and at least moderate aortic insufficiency at discharge were shown to be predictors of mortality, unfortunately, there were no preoperative or intraoperative predictors of early valve dysfunction that we were able to determine. The incidence of aortic valve endocarditis in this series, though, was high and compares unfavorably to that reported in the literature for other aortic valve procedures. And so what does this mean? We can't really make any recommendations regarding which surgical material to use and that sort of thing, but if we're looking at endocarditis, maybe that means that standard prophylaxis needs to be extended in patients with these aortic valve repair surgeries with leaflet extensions. So with that, this concludes my presentation. Thank you so much for your attention, and I will accept questions.
Excellent talk, Nick. Thank you. I think A lot of us have the experience of fool's gold with leaflet extension. It can look really great in the operating room, and then very shortly after looks much worse. We do have one question that's been posed. We'll buy some time for some others, but is there standard preoperative imaging that you use at your center before attempting a leaflet extension or an aortic valve repair?
So I am not sure what the process was before deciding whether to do the repairs. This was a retrospective study, but we did look at echocardiograms beforehand and assessed the insufficiency via the Doppler echocardiogram, but I don't have that data on me right now.
That's great, thanks. I think some of the more recent data has suggested better results when you can create enough leaflet height. So how to best assess leaflet height is somewhat debated. So maybe an interesting thing to look at for your manuscript. We have one other question popping up. For those who ended up getting endocarditis, was it known if they had a risk procedure prior to the endocarditis? Or if they had prophylaxis prior to what is anticipated to be a risk procedure?
So I'm unfamiliar with the term risk procedure.
Procedure that we would usually use prophylactic antibiotics for in
yes.
patients like dental visits.
Yes, so the endocarditis patients who died, 2 of them were being treated for endocarditis at that time, and 1 was following a dental visit.
Excellent, thank you. Well, thank you, Nick.
Thank you very much.
We are going to jump back to our previous presentation that was unfortunately interrupted. So we will jump back to Shari Mudhasisina in the middle of her presentation, which is entitled Valve-Sparing Aortic Root Reconstruction in Children and Young Adults. And I think we'll pick up hopefully where she left off.
Yeah, sorry about that. I was having some technological difficulties, but hopefully I can get through and share with you guys some of my results. All right, so aortic valve repair was performed at the time of the root replacement on 3 out of our 18 bicuspid valve patients and none of our tricuspid patients. And aortic valve repair was basically when actual sutures were placed on the valve and there wasn't just an incision made. And this data did show a statistically significant difference. See if I can get to my next slide here. All right. So on the y-axis of this graph, 0 indicates no insufficiency, 1 indicates trivial insufficiency, and greater than 1.8 indicates mild insufficiency. So we can see that before the operation, on average, patients had a slightly higher valvular insufficiency, which decreased a little immediately after the operation, and stayed this way at the time of discharge, and then increased again a little bit at the time of follow-up. It was interesting to note that we found no significant difference in the amount of reintervention the patients with bicuspid valves underwent versus the tricuspid valves. So it seems like there isn't much difference as to how well the 2 procedures performed, as we can see in this graph. So there was no drop-off, and it seemed like over time, bicuspid valves performed just as well as tricuspid valves. But then we also found from our freedom curves that bicuspid valves were experiencing slightly higher levels of insufficiency over a period of time than tricuspid valves. And that can be seen here. So patients with bicuspid valves in the blue had a greater likelihood of experiencing more than mild insufficiency than a patient with tricuspid valves during our 16-year period. And this difference was approaching statistical significance, so not quite there yet, but I think if we had a few more patients, we'd be able to know more about this data. On most recent follow-up, there were only 4 patients with aortic valve insufficiency that was greater than mild, and all 4 of these patients were bicuspid valved patients. And that can be seen here. So very few of our patients had bicuspid valves, but the ones that did, or very few of our patients had greater than mild insufficiency, excuse me, but the ones that did had a bicuspid aortic valve. And this was statistically significant. And so in conclusion, none of our patients required aortic valve replacement at the time of the procedure, and there was only 1 late death. Valve-sparing aortic root replacement is becoming the standard surgical procedure for aneurysmal dilatation of the aortic root in teenagers and young adults with a tricuspid aortic valve in order to avoid the need for anticoagulation. Our single institution analysis of midterm results with the valve-sparing procedure in the context of a bicuspid aortic valve demonstrates that it is feasible with relatively stable valve function and low morbidity. And valve-sparing aortic root replacement in young adults with bicuspid aortic valves is safe and results in valve function and morbidity comparable to tricuspid valves, both at Children's Wisconsin and in the best published literature with valve-sparing procedure data in young adults with tricuspid aortic valves at midterm follow-up. I think that in the future, it would be really interesting to study the outcomes of bicuspid valve aortic root replacement at other institutions as well, and with a larger number of patients to confirm some of the results that we have here. I think that extending the follow-up of our existing series of patients to perform a long-term analysis of the durability of the procedure would probably be really useful as well. And so a huge thank you to my mentor, Dr. Michael Mitchell, for all of his help with this project, and to the rest of the team at Children's Wisconsin as well. I'd also like to thank my fellow late medical student, Amy Lai, whose work this is a continuation of, and Nick Peterson for administrative support from the Herma Heart Institute. So with that, does anybody have any questions?
Great job. Apologize again for the technical issues for the audience and for you. We do have some questions here.
Mm-hmm.
Did any of these patients that underwent the valve-sparing aortic root replacement have connective tissue disease, and if so, what percent?
Yeah, they did have, so they had multiple genetic disorders. So we had some patients with Marfan syndrome and some patients with Louis-Dietz syndrome. And a lot of our patients had aneurysmal problems that were corrected. And I don't have the exact percentage with me. I think I can put that in my presentation for the future. But yeah, that was significant. So good question.
Great. And then for the determination of aortic regurgitation, was that based on report at the time, or did you go back and independently measure and evaluate those studies?
That was based on report at the time. Okay. So what was present in the data that we collected through chart review, that was, yeah, report at the time.
Okay. And one final question, and I apologize, it's a tough one for you as a medical student, but do you think your data suggests that the timing for valve-sparing aortic root replacement should be different than the timing for a composite root replacement? In other words, should we be doing them earlier to try and spare valve function?
I think I would definitely have to give that question some thought, and it's a very good question. Yeah, I think I definitely have to get back to you guys on that question.
Fair enough. As I said, tough question.
Mm-hmm.
We will take a break Reminder that during the break, we will have some of our highlighted posters available for viewing. Each will be playing for 5 minutes, and we are just about on schedule, so we restart at 20 after the hour. So 10:20 Central, 11:20 Eastern. Thank you. Welcome back, everybody. We will restart with our second session. Second session is on imaging. Just as a reminder, during these presentations, you can post Q&A questions for the speakers in the Q&A box located at the bottom of the Zoom menu. The highlighted posters that you just saw and all of the highlighted posters are available on the website at mwpcs.org. The other posters, the non-highlighted posters, will be available soon. So check out the website for additional presentations. Our first speaker in our second session is Anthony Zhang, and his presentation, or excuse me, he's a medical student from the University of Iowa, and his presentation is Diagnostic Utility of Non-Contrast Three-Dimensional Steady-State Free Precession MRI, or MRA, compared to conventional contrast MRA in pediatric and adult patients for aortic and pulmonary artery dimensions. Go for it, Anthony.
Hi, again, my name is Anthony Zhang, and I'm excited to be able to present this data comparing 3D SSFP and gadolinium-based contrast MRA sequences for evaluating cardiac vasculature. So some quick background. As you all know, cardiac MRA is a very important diagnostic utility we have today for evaluating aortic and pulmonary artery anatomy. The quality of imaging in this procedure is further enhanced by the administration of a contrast agent, and what's most commonly used today is a gadolinium-based contrast agent, usually by IV. These gadolinium-based contrast agents are widely considered safe to the general population and only contraindicated in 2 cases. The first being pregnancy, where it has been linked to an increased risk for stillbirths and neonatal deaths, and also in the patient population with renal dysfunction, where there has been a strong association with a condition called nephrogenic systemic fibrosis. So even so, in the normal patient population, without any sort of renal, hepatic, nor blood-brain barrier impairment, studies have also strongly associated a gadolinium deposition pattern with residual deposits being found in skin, liver, bone, and brain tissue. These deposits last on the time frame of months to years, and most notable in the literature seems to be a focus on some T1 hyperintensities found in the brain tissue around the regions of the dentate nucleus and the globus pallidus regions. Further correlated is a PET study that was done that showed a reduction in metabolic activity measured by fluorodeoxyglucose uptake with respective reductions of uptake in 16 and 27% respectively. Even so, there has been no negative clinical symptomology that has been found, and the long-term effects of these deposits is still very poorly understood. Additionally, the usage of these contrast agents brings the common hazards as with any IV delivery, which ranges from common injection site pain to the possibility of an anaphylactic reaction. Finally, within our study population, these concerns are magnified because with these patients that have congenital heart diseases or connective tissue disorders that require lifelong regular evaluation, this repeated annual imaging brings about repeated exposure and possible additive effects of the deposition beyond what is commonly found. So here are some images that we had taken, all from the same patient, showing some of the gadolinium contrast-based MRA scans with the 3 SSFP sequence scans. And these are some of the locations that we had measured. And so within our study, we're comparing this gold standard of the gadolinium-based cardiac MRA to the 3D SSFP cardiac MRA sequence. The 3D SSFP sequence most significantly doesn't require administration of any sort of contrast agent. And also intrinsic to it includes both respiratory navigators and ECG gating, which allows free breathing during the scan, which is nice for our pediatric patients and those with respiratory decline. And with our study, we were also looking, we were mainly looking at the comparability of the image sets by looking at vessel measurements and overall image quality. So we identified 156 patients with sequential 3D SSFP and gadolinium-based cardiac MRA scans. The patients were originally referred image per referral for evaluation of a connective tissue disease, suspected valvular disease, or being followed long-term for surveillance of a congenital heart disease. And the gadolinium-based contrast agent that we used in each case was Gadavist. And the image measurements that we did were measured at 5 locations. First was the aortic sinuses of Valsalva. Second, the mid-descending aorta. Third, the proximal aortic arch. Fourth, the mid-descending aorta. And fifth, at the MPA. So the exact position of these aortic measurements was determined per established guidelines by a task force from 2010. And at the aortic sinuses, the measurements were taken from the midpoint of each cusp to the opposite commissure. And at each of the other measurement locations, 2 orthogonal measurements were taken. These measurements were taken by a set of 5 experienced physicians that were using a double oblique multiplanar reconstruction technique to generate a cut plane perpendicular to the course of the vessel. And each of these measurements at each of the locations was used to generate an average vessel diameter for the 2 separate sequences. So we analyzed the differences between the measured vessel diameters for the 2 sequences with a two-tailed paired student's t-test to determine if the measurements were significantly different from 0. Additionally, we constructed bland Altman plots for each of the vessel locations, and further, a concordance correlation coefficient was calculated using these average vessel measurements to compare the 2 sequences. So of the 5 locations that were measured, we found under the student's t-test, the mean differences in measurement was statistically different from 0 only for the MPA. And the concordance correlation coefficient that we calculated, which is trying to quantify the agreement between 2 sets of measurements of the same variable, in our case would be the vessel diameter. For all the locations, it was moderate to substantial, with 1 being perfect correlation and 0 being indicating no correlation whatsoever. So we were able to successfully acquire measurements in the majority of the identified patients in most of the identified locations. We tried to minimize our exclusion criteria to exclude pretty much only the image sequences that had distortions or anatomy that made some measurements of those anatomic locations impossible. For example, patients with a Fontan procedure, we didn't really have a main pulmonary artery measurement, or sometimes just the range of the imaging sequence failed to capture all the structures that we were looking for. Further, the image readers were able to identify a generally superior image quality with the SSFP sequences based off of a Likert scoring, and particularly noted an ability to distinguish some of the smaller vasculature, such as specifically the coronary arteries, as a result of that added ECG gating that's intrinsic to the 3D SSFP sequence. So overall, we saw that 3D SSFP was able to show a comparable measurement to the gadolinium-based contrast MRI in the aortic vasculature, while there was that variance within the pulmonary artery measurements. We think that it's possible that this variance within the pulmonary arteries was contributed to by the fact that oftentimes in patients with congenital heart defects, there's an increase in variability in the diameter along the length of their pulmonary vessels. And additionally, we had comparatively poor guidelines as far as a discrete location for the measurements of the main pulmonary artery. SSFP also does offer additional benefits, including that removal of any potential side effects from gadolinium or IV administration, along with having that ECG gating and respiratory navigation intrinsic to it, which offers free breathing, which is helpful for the children and any sort of respiratory impaired, along with a better visualization of small vessels, such as the coronaries. So in conclusion, we still have that gadolinium-based cardiac MRA as the gold standard, but we do believe that 3D SSFP MRA with that ECG gating and respiratory navigation should be considered in place of contrast MRA when you have that repeated longitudinal monitoring of conditions. And for the 5 measured locations, which was all the aortic sampled locations specifically, we were able to confirm with 95% confidence that the measurements were equally represented. And again, 3D SSFP does offer external benefits, including removing those potential side effects from gadolinium exposure or IV usage, along with a generally superior image quality for some of those small vessels, specifically the coronaries, and the fact that you no longer have to do a breath hold during the image acquisition. And we do believe that this study does help establish a short-term alternative, while some larger studies can be planned or be concluded that are looking more at the long-term effects of this sort of additive gadolinium deposition pattern that has been found. Here are my references, and I'd appreciate any questions, and thank you for your time.
Thank you, Anthony. Great presentation. I think certainly a very appropriate study at this time, given the findings you presented early. There's a lot of hesitation for repeated gadolinium administration, so excellent. One question for clarification. You mentioned 5 physicians who measured. Were those physicians, was each image and patient only measured once, or were there multiple physicians who measured each patient?
So for the majority of these measurements, it was 1 physician to 1 patient.
Okay. Have you considered doing correlation, both inter-rater and inter-rater reliability for these measurements?
So I was able to find in current existing literature, there are a couple smaller studies, usually on the range of 20 to 50 patients, that did try to, that did more of focused on having multiple readers for each of those patients in each of those scans. And they were able to demonstrate a very good inter-observer correlation between the measurements. And I believe even one of the studies had 2 inexperienced readers doing some of the measurements, and those also showed very good inter-observer correlation with the experienced physicians.
Excellent. And we have one other question in our question box. Would your plan be to do an initial study with gadolinium in these patients and then follow their growth with the 3D SSFP?
Yes, that does seem to be a good way to do it. Especially because pretty much adding an adding an SSFP sequence onto an already planned gadolinium-based contrast MRA sequence is hardly an add-on. You don't really, it doesn't take that much additional time, and the bulk of the time is already invested at that point.
Excellent.
And yes, so yeah, there was an inter-rater correlation that was done on a smaller subset of the patients that we did.
Excellent. Thank you, Anthony. We'll move to our next presentation. Our next presentation is by Sam Breyer. Sam is a pediatric resident here at Cincinnati Children's Hospital, and his presentation is entitled Relation of Magnetic Resonance Elastography to Fontan Failure in a Cohort of Pediatric and Adult Patients. Take it away, Sam.
Hi, everybody. Thanks for joining us today, and thank you to the organizing committee who helped put this together today. My name is Sam. I'm a second-year pediatrics resident at Cincinnati Children's Hospital Medical Center. Sorry here. This work was supported with funds from the Academic Research Committee grant at Cincinnati Children's Hospital Medical Center. The Fontan procedure is the final stage in palliation in correcting a number of single ventricle congenital heart defects. This operation has changed the lives of patients with this congenital heart disease, leading to longer-term survival and improved quality of life. As survival improves for these patients and they age into adulthood, the focus is shifted to predictors of long-term clinical outcomes. However, as these patients age, they may also develop systolic and diastolic dysfunction, arrhythmias, AV valve regurg, all of which can lead to higher central venous pressures and lower cardiac output, and Fontan-associated liver disease results, which manifests as a congestive hepatopathy with different degrees of fibrosis, radiographic evidence of portal hypertension, and liver neoplasms. FALD, due to the intrinsically altered hemodynamics in the Fontan circulation, is universal in this patient population. The incidence of carcinoma in this population is about 1.3%, which is 260 times higher than the general population. And early detection of liver disease in patients with Fontan circulation has been associated with better outcomes. For this reason, the American Heart Association suggests MRE screening every 1 to 3 years for patients with Fontan circulation. Magnetic resonance elastography is supposed to provide a quantitative assessment of liver stiffness. However, in the Fontan population, liver stiffness is confounded by congestion, which makes it a poorer correlate with fibrosis. So thinking about the two pathophysiological mechanisms of increased liver stiffness, it reflects both congestion and fibrosis. You can see in this 2019 JACC imaging study that in heart failure patients, increased liver stiffness reflects increased right-sided filling pressures and thus congestion, and can help predict outcomes. The blue line on this Kaplan-Meier curve shows a combination of elevated liver stiffness and high BNP. And as you can see, these patients had the shortest cumulative event-free survival of patients in this study. We also know that elevated liver stiffness is a nice correlate to fibrosis. And as you can see in this hepatitis C population, as the stage of fibrosis increases, the mean liver stiffness also increases. So just a note on magnetic resonance elastography. You can see here some cross-sectional imaging of an abdomen with an illustration of a mechanical driver superimposed on top. And you can see the mechanical driver producing shear waves through the liver. In a normal liver, which you see on the right-hand side of the screen, the shear waves are small and produce a short wavelength and are translated into an elastogram, which manifests as cooler kind of purple blue colors. Now, as you increase the liver stiffness, such as in this image here, this is a patient with Fontan physiology, has a mildly increased liver stiffness to 3 kilopascals. You can see that the resultant elastogram has some green and yellow, which indicates elevated liver stiffness. And as we increase liver stiffness again to somebody with severely increased liver stiffness, this is another post-Fontan patient, liver stiffness is 7 kilopascals. The wavelengths are thus larger, representing a stiffer liver, and you see the reddish, orangish color there in the elastogram. And so kind of the overarching question in our group is, when we look at these two Fontan patients, one with only moderately increased stiffness and one with severely increased liver stiffness, how do they differ in terms of their kind of clinical presentation and their outcomes? And so previous work from this group has shown that magnetic resonance elastography derived liver stiffness is associated with hemodynamics, liver function, and clinical outcomes in adult patients with Fontan circulation. And this measure can serve as a biomarker reflecting the health of the liver in patients with Fontan physiology. Now, importantly, this study only included adult patients. And so in this project, we sought to expand into a cohort that included both pediatric and adult patients. And so our research question was, does magnetic resonance elastography derived liver stiffness correlate to clinical outcomes, cardiac function, and radiologic evidence of portal hypertension in the cohort of adult and pediatric patients with Fontan physiology? The methods for this study: this was a single-center retrospective review of adult and pediatric patients who underwent magnetic resonance elastography as an outpatient between 2011 and 2020. Baseline echo reports were reviewed, and significant AV valve regurgitation was defined as moderate or severe. Abdominal imaging data were also reviewed, and radiologic evidence of portal hypertension was defined as splenomegaly, varices, or ascites. And Fontan failure was a composite clinical outcome defined as death, transplantation, VAD placement, or heart failure symptoms requiring escalation of diuretics in the outpatient setting. This is our demographic data. As you can see, 128 total patients met our inclusion criteria, 69 of which were adults and 59 were children. Again, that age cutoff was 21 years. By definition, the adults were older than the children, but the average age in our population was 22.6. The adults were 22.8 years, pediatric patients 15.5. Our adult patients had a significantly elevated BMI when compared to our pediatric population. That's 25.4 versus 22.6. Commensurate with the increase in age in our adult population, the Fontan to MRE interval was elevated in the adult patients to 21.1 years compared to our pediatric population of 11 years. Interestingly though, the mean liver stiffness in our adult population was 4.26 kilopascals compared to 4.4 kilopascals in the pediatric population, and there was no significant difference between those two groups. In terms of Fontan failure, that composite clinical outcome, there were 30 total in our 128 patient cohort, 16 of whom were adults and 14 of whom were children. Here's a table including the hemodynamic, clinical, and cardiac function outcomes. And so looking at the left-hand side of the table, you can see that in the adult population, those patients with Fontan failure, portal hypertension, and AV valve regurg all had significantly elevated liver stiffnesses when compared to those adult patients without Fontan failure, portal hypertension, or AV valve regurgitation. Moving to the right-hand side of the slide, you can see that there was no significant difference between the pediatric population in terms of patients who had Fontan failure, portal hypertension, and AV valve regurgitation, and those who did not have those findings. Looking at this data graphically, you can see this is a graph for liver stiffness versus portal hypertension. The adult population is on the left-hand side and the pediatric population on the right. And while there is a significant difference between the adult population, there's a significant degree of overlap, as you can see in this box and whisker plot. In the pediatric population, there was no significant difference between the mean liver stiffness and in the patients that did have portal hypertension, radiologic evidence of portal hypertension, and those that did not. Moving to liver stiffness versus AV valve regurgitation, similar story here. Mean liver stiffness in adult patients with AV valve regurgitation was 4.7 versus 4.2 without. That was a significant difference to 0.02. In the pediatric population, 4.3 and 4.3 were the mean difference, or were the mean liver stiffness readings in that two groups. No significant difference noted there. In terms of our composite clinical outcome of Fontan failure, again, those adult patients that experienced Fontan failure did have a significantly higher liver stiffness than those that did not, 4.9 kilopascals to 4.2. That was significant to a p-value of 0.03, whereas in our pediatric population, there was no significant difference between pediatric patients with and without Fontan failure. Average kilopascals were 4.4 in both, and again, no significant difference. And so what this study suggests is that the association between MRE-derived liver stiffness and portal hypertension, AV valve regurgitation, and Fontan failure in adult patients is substantiated. However, it also suggests that there was no such association found in the pediatric population. So this could be due to kind of the two pathophysiologic mechanisms of elevated liver stiffness that we discussed earlier. And in the pediatric population, elevated liver stiffness may simply reflect congestion to a greater degree than fibrosis. And children with elevated liver stiffness may simply be asymptomatic. Alternatively, in our population, only sicker children are referred for liver screening in a special multidisciplinary Fontan clinic. And so they may represent a more sick population. And in this population of pediatric patients, morbidity and mortality may be due to multi-system involvement and can be attributable to renal failure, heart failure, or arrhythmias, and less likely due to Fontan-associated liver disease, which takes time to develop. Some limitations of our study were that it was a single-center retrospective design, and that we only had a small number of Fontan failure patients. We also didn't evaluate the value of serial assessments of liver stiffness over time. Likewise, we didn't look at how medications and interventions might change liver stiffness throughout time. And there were very few patients that had a liver biopsy, so we weren't able to correlate histopathological findings with magnetic resonance elastography-derived findings. So in conclusion, magnetic resonance elastography-derived liver stiffness is associated with altered hemodynamics, AV valve regurgitation, and liver function and clinical outcomes in adult patients with Fontan circulation. However, no such association was found in the pediatric population, likely due to less severe liver fibrosis in this subset of patients. Further work is necessary into the pathophysiology of Fontan-associated liver disease in the pediatric population to help further elucidate these findings. I'd like to thank my mentor, Dr. Tariq Al-Saeed, a pediatric cardiologist at Cincinnati Children's Hospital Medical Center, all of the co-authors that provided valuable feedback in the preparation of the abstract for this presentation, and my Cincinnati Children's residency program here at Cincinnati Children's. Thank you to all of you, and I'd be happy to take questions at this time.
Thank you, Sam. Great presentation. Very well presented. I think you answered one of the questions already, and that was that these were not routine screenings. They were ones that were sent usually for some reason. The other question that's in the chat box is, did any of your adult patients have a history of hepatitis C or other hepatitis infection?
That's a great question that I didn't actually look into for this project. We looked at a number of comorbidities, but hepatitis C or other hepatitis co-infections was not one that I included in this analysis, but thank you for that question.
And then I'll ask a question, and we'll allow some help if you can't answer the question. So if your mentor wants to type the answer in the chat box, it may be important that hepatic congestion is variable in pediatric patients. Do you think we should be routinely screening pediatric patients for liver elastography? And if so, when do you think we should start that?
Yeah, it's a great question, and I think Tariq will have a much more founded answer than I have. So I'll let him go ahead and chime in if he's in the chat here.
We'll give him a minute, and just as a reminder, the audience can vote on the presentation with the ongoing poll. Please do that. We'll use the responses to help determine the awards for the presenters at the end of the meeting. Again, another reminder to the audience as people continue to join. If you have questions, use the question and answer Q&A box at the bottom. That can be typed anytime during the presentation, and we'll go over them at the end of the presentation. It looks like Tariq has responded. Great question. Our current suggestion is to start at the age of 8 years for routine screening. Thank you. All right, thank you, Sam.
Thanks, Garrick.
Our next presenter is Caitlin Ring. Caitlin is an undergraduate student at the University of Wisconsin in Madison, and her presentation is titled Care Management of Non-Emergent Echocardiographic Diagnosis in Newborns. Take it away, Caitlin.
Sorry about this. Using my boyfriend's setup, so you guys might not be able to see me exactly. He's much taller than me, so my name is Caitlin Ring, and I'm an undergraduate at UW-Madison in the Department of Agriculture and Sciences. My mentor is Dr. John Hokeson, and his colleague, PhD Zhao Zhang, were my mentors in this project. And we did a survey regarding the care management of non-emergent echocardiographic diagnosis in newborns. So we have no financial relationships that are relevant to this study. Oops. Okay. So as many of you probably know, echocardiograph is commonly used in the normal newborn nursery to assess cardiac structure and function. Echocardiograms in asymptomatic newborns often reveal non-critical abnormalities. Our goal was to assess providers' practice patterns with regard to these non-critical echocardiograph findings in the normal newborn nursery. We sent out an anonymous email survey sent to the members of the American Academy of Pediatrics section of Cardiology and Cardiac Surgery, and then also PediaHeart, which is an online community. We surveyed them on the care recommendations for 10 non-critical echocardiograph findings in the context of an asymptomatic full-term newborn, an asymptomatic premature infant of 34 weeks gestation, and an asymptomatic full-term newborn with trisomy 21. And we gave them some care options that we ranked by in a hierarchy by their perceived severity, and this included normal newborn care, repeated echocardiograph without planned cardiology follow-up, outpatient cardiology follow-up without echocardiograph, an outpatient cardiology follow-up with echocardiograph, and an inpatient cardiology consultation before discharge. And we analyzed the demographics of a total of 137 usable respondents, finding that they were well diverse throughout the regions of the United States, and they were also well diverse in surgical volume and years of experience. We found that such demographics did not have a significant effect on the practitioner's recommendation of care. So in this first graph is the care recommendations of the first 5 non-critical echocardiograph findings that we asked the practitioners about for an asymptomatic full-term newborn. In blue, we have normal newborn care. In red, we have repeated echocardiograph without planned cardiology follow-up. In yellow, we have outpatient cardiology follow-up without echocardiograph. In green, we have outpatient cardiology follow-up with an echocardiograph. And in orange, we have inpatient cardiology consultation before discharge. And then on this next slide, this is the additional 5 non-critical echocardiograph findings that we asked about. And again, we have the same normal newborn care, repeated echocardiograph without planned cardiology follow-up, outpatient cardiology follow-up with echocardiograph, outpatient cardiology follow-up with echocardiograph, and inpatient cardiology consultation before discharge. And on this graph, we have again the same 5 non-critical echocardiograph findings, and this is for an asymptomatic late preterm newborn of a 34-week gestation. This is the additional 5 non-critical echocardiograph findings for the late preterm newborn. And in this graph, this is the first set of the 5 non-critical echocardiograph findings for an asymptomatic full-term newborn with trisomy 21. And again, we have the same normal newborn care in blue, repeat echocardiograph without planned cardiology follow-up in red, outpatient cardiology follow-up without echocardiograph in yellow. In green, we have outpatient cardiology follow-up with echocardiograph. And in orange, we have our inpatient cardiology consultation before discharge. And these are the additional 5 non-critical echocardiograph findings for the newborn with trisomy 21. So analyzing these results, we found that 34% of practitioners would change their recommendation for a 34-week premature infant when compared to a full-term infant, and they would change, and 47% of them would change their recommendation of care for infants born with trisomy 21. So with the exception of a patent foramen ovale and a trivial mitral valve regurgitation, most practitioners feel that additional evaluations are appropriate. Respondents were more likely to recommend further evaluation for an asymptomatic late preterm infant of 34 weeks gestation or a newborn with trisomy 21. There we go. So we'd like to thank the members of the American Academy of Pediatrics section of Cardiology and Cardiac Surgery for participating in this project, and then also thank you to Vivian Thorne for her assistance in managing the survey. So then that's it, and if there's any questions, I or my mentor can help answer them.
Great presentation, thank you very much. Did you ask questions or have any information about the resources available, as in how easy it was to follow up with a pediatric cardiologist versus get a pediatric echo in the survey?
So I don't think we followed up with any questions about that, as I'm assuming that would probably differ possibly from facility to facility. I don't have much clinical experience as I'm still an undergrad, so my mentor, Dr. Hoganson, might be able to answer that a little bit more.
Sure, if he wants to post in the chat box. Thinking might be that it could influence your recommendation for follow-up if it's a large travel distance for the patient to reach cardiologist.
Yeah.
Dr. Hokinson just posted, we did not address the issue of resource availability. Thank you. All right, excellent job. We will give a few more seconds for the polling. It looks like some more responses are still coming in. And then we will move to our next presentation. Our next talk is given by Chelani Delapola. Chelani is a fellow at Children's Wisconsin, and her presentation is Limitations of Predicting Postoperative Left Atrioventricular Valve Regurgitation by Transesophageal Echo. Thank you, Dr. Delapola.
Thank you, Dr. Hill, and good morning, everyone. I'm Chelani, and today I'm happy to be presenting our research on the limitations of predicting postoperative left atrioventricular valve regurgitation by transesophageal echocardiography. Definitive treatment of atrioventricular septal defects, or AV septal defects, is surgical repair, and the goal of surgical repair is to achieve two competent atrioventricular valves, or AV valves. Reports of surgical management over the past 30 years have certainly indicated a steady decline in perioperative mortality and certainly morbidity. However, left AV valve regurgitation remains a critical hemodynamic complication in patients surviving repair and the most common cause for reoperation, with a reported incidence of 8 to 19% cited in the literature. The creation then of a competent left AV valve is a cornerstone in successful surgical repair. With that being said, it is definitely a commonly held observation that after repair of AV septal defects, echocardiographically determined left AV valve function changes from the postoperative transesophageal echocardiogram to the discharge transthoracic echocardiogram. Stenosis usually stays the same or improves, but regurgitation stays the same or progresses to a higher grade. And at present, that relationship between left AV valve regurgitation seen on post-repair TEE and discharge transthoracic echo has not been well defined, and knowledge of it could go on to influence intraoperative decision-making. Our hypothesis, as such, was that post-repair TEE assessment of left AV valve competence after AV septal defect repairs does not reliably predict left AV valve regurgitation seen on the discharge transthoracic echo. To assess this relationship, we undertook a retrospective study of a large cohort of AV septal defect patients who underwent repair from November of 2012 through December of 2018 at our tertiary care hospital here in Milwaukee. There's a total cohort of 96 patients. Inclusion criteria included all AV septal defect diagnoses who were then grouped into two separate groups: complete and partial defects on the basis of physiology, with transitional AV septal defects included in the partial group due to the restrictive or no ventricular level shunt. Prior palliative procedures were also included, and all patients had to have had a post-repair TEE and a discharge transthoracic echo prior to leaving the hospital. Patients with associated cardiovascular and non-cardiovascular lesions were included, with exceptions that would alter the basic physiology and natural history of those patients. So exclusion criteria were those who underwent single ventricle palliation and those with a diagnosis of more complex AV septal defects, such as those with associated TET physiology, transposition, or total anomalous pulmonary venous return. Data collected included patient demographics, clinical characteristics, preoperative left AV valve anomalies, surgical procedure, and outcomes. And TEE was performed in all patients just after weaning from cardiopulmonary bypass and prior to chest closure. Follow-up transthoracic echo was performed just prior to hospital discharge. And the median interval between TEE and follow-up TTE was 6 days in our study. Left AV valve regurgitation was assessed according to standard qualitative methods using guidelines established by ASE, and certain qualitative and even semi-quantitative methods we used to grade regurgitation included color flow, jet area, left atrial size, vena contracta width, and pulmonary vein flow. Consideration was given into grading regurgitation into severities designed to identify major changes in AV valve regurgitation that could significantly affect clinical outcome. So as such, regurgitation was graded as either mild or less, or moderate or greater. Mild or less being hemodynamically insignificant regurgitation, and moderate or more being hemodynamically significant regurgitation. Echo evaluation was performed by a core group of pediatric cardiologists, and statistical blinding techniques were performed. Testing for inter-observer variability was done, where a new assessment of regurgitation was made on TEE and transthoracic studies. And this gave us a weighted kappa of 0.89 or 89% agreement, which represents an excellent strength of agreement according to the FLICE classification. And after further review, discrepancy, when it existed, was between mild and moderate grades of left AV valve regurgitation, but never between mild and severe. So at the time of surgery, there were 65 complete AV septal defect patients with a median age of 5 months and weight of 5.6 kilos, and 31 partial AV septal defect patients with a median age of 27 months and a weight of 11.9 kilos. The majority of our patients had Down syndrome, and the preoperative left AV valve regurgitation grade was also noted, with 62.5% of patients having mild or less, and 37.5% of patients having moderate or greater. And again, the median time between the two echo studies was 6 days. In terms of surgical technique, the 2-patch technique and modified 1-patch technique were the most commonly performed repairs and determined based on surgeon preference. Complete cleft closure was undertaken 90% of the time, and again at the discretion of the surgeon. And left AV valve anomalies were recorded, and attention was paid to whether there were closely spaced papillary muscles, dominant papillary muscle, single papillary muscle, double orifice mitral valve, etc. So the median length of stay was 8 days. And there were no deaths in our study. Reoperation was required for left AV valve regurgitation in 2 patients prior to hospital discharge. And in terms of post-repair left AV valve regurgitation, it should be noted that none of our 96 patients left the OR with severe left AV valve regurgitation. And post-repair TEE revealed less than moderate regurgitation in 86 patients and moderate or greater in 10. And then the discharge echo revealed less than moderate regurgitation in 67 patients, with moderate or more in 29. So overall, there was a discrepancy in left AV valve regurgitation at discharge in 24% of patients, with the vast majority of those patients, that is 21 out of the 23 who showed discrepancy, demonstrating progression to a higher grade of regurgitation. The 2 patients who underwent reoperation before discharge was due to hemodynamically significant severe regurgitation. One had mild left AV valve regurgitation on post-repair TEE, and the other had moderate. There were 0 deaths, again, prior to hospital discharge. So we looked at certain demographic, preoperative, and surgical variables as predictors for discrepancy. And in univariate analysis, significant predictors for discrepancy were younger age and lower weight at the time of repair. A difference was apparent with a preoperative grade of regurgitation. However, it did not quite achieve statistical significance with a P of 0.06. So there were limitations of our study. First of all, loading conditions in the OR are different, and as a result, TEE assessment of left AV valve regurgitation is often underestimated. And this is often attributed to the effects of anesthesia and inotropes on the systemic vascular resistance, or the contractile state of the myocardium after cardioplegia administration. And then left AV valve regurgitation itself is a qualitative assessment, and even semi-quantitative assessments like vena contracta width, for example, tend to fall apart in congenital mitral valve disease due to the multiple eccentric jets. And so as such, it's qualitative assessments that are relied and preferred in pediatrics. But with this, in terms of variability is concerned, however, our study had excellent level of agreement in our qualitative assessments of left AV valve regurgitation. And our study, lastly, is limited due to the retrospective nature with a short median follow-up time. So in conclusion, discrepancy between left AV valve regurgitation on post-repair TEE and discharge echo was present nearly a quarter of the time after AV septal defect repairs. And the reason for this is not so clear. Nonetheless, caution should be used when interpreting the quality of left AV valve repair by post-repair TEE assessment alone. And in the absence of another explanation, surgeons should be hesitant to accept anything more than mild left AV valve regurgitation on post-repair TEE. This important finding with implications for intraoperative decision-making should prompt further investigations, and we are currently analyzing other variables that might account for differences between the post-repair echo and the discharge echo outside of just loading conditions in the OR. Factors like preoperative left AV valve anomalies and surgical techniques will require further analysis. And lastly, we know that the left AV valve is the most strained of all valves. The left AV valve leaflets sustain pressures upwards of 120 millimeters mercury, the highest pressures of all the valves. And so therefore it is plausible that elevated blood pressure early during the healing after the repair could promote worsening of left AV valve regurgitation, resulting in more distortion to the valve. So needless to say though, more analysis is on the horizon, but it seems clear that certain limitations exist when it comes to the predictive capability of TEE in predicting postoperative left AV valve regurgitation after AV septal defect repairs. So thank you for your attention, and I would like to thank my team and give a special shout out to my mentors, Dr. Woods and Dr. Goot. With that, I am welcome to taking any questions.
Excellent presentation. I think those of us that do TEEs have certainly struggled with the change from the TEE in the operating room to discharge. And I think your first limitation may not be a limitation of the study, but more of an explanation of why we see significant changes. I do have a couple questions. So my first is, you had 2 patients that required reoperation. Do you have surgical information for those patients about what the findings were? Were they things like torn sutures, or were the findings really non-explanatory?
That's a good question. We do have intraoperative reports available on those 2 patients specifically that we could certainly look. I don't know off the top of my head what those were. The 2 patients that required reoperation for hemodynamically significant regurgitation, again, it's not a big sample size, but I think it is clinically important because with a median hospital stay of 6 days, 2 requiring reoperation for that is certainly not clinically insignificant. And again, there's not much we could make out of that. The 2 that had reoperations, one had a post-repair TEE assessment of mild regurgitation, the other being moderate. Both of them had a preoperative regurgitation grade of mild or less. So I think at minimum, the 2 that we have that went on to require reoperation just kind of reinforces the observation that TEE is not a perfect assessment of the adequacy of left AV valve repair. And so that kind of begs towards our implications of, are there modifiable factors then that could go on to improve outcomes of left AV valve function?
Excellent. And we have one other question in the Q&A box. Do you think this could be an issue for other valves, such as the tricuspid aortic valve after repair, or is this unique to left AV valves or mitral valves, or is it just worse in left AV valves, mitral valves?
That's not something our study looked at. We just looked at the left AV valve, and it in particular being the most common need for reintervention in this particular congenital heart defect, and also it being the only the valve that sustains the highest amount of pressure.
All right.
I would suspect that perhaps it is unique in that sense because of that reason.
Yeah, certainly could be worse because of that reason. All right, great presentation. We'll move on to our next presenter. Next up is Kurt Bjorkman. Kurt is a fellow at the University of Iowa and Steed Family Children's Hospital. His presentation is titled "A New Use for One of Cardiology's Greatest Tools, Novel Method of Tracheal Imaging in Pediatric Echocardiography to Determine Aortic Arch-Sidedness and Rule Out Double Aortic Arch and Pulmonary Artery Sling."
Okay, excellent. Good afternoon, everyone. Good morning, depending on what time zone you're in. Again, I'm Kurt Bjorkman from the University of Iowa, second year fellow in pediatric cardiology. So as mentioned, today we're going to talk a little bit about using echo and can we use it to look at the trachea. Again, this is taking something we use every day, knowledge we already have, but seeing if we can put these together in a new way to get better at how we diagnose arch anatomy and then hopefully also help us to provide better care for our patients. So you may ask, Kurt, why does this matter? So starting out, a couple things that you may already know about the aortic arch, and some things maybe you don't, that arch anomalies can cause compression of the esophagus or the airway. We know that in cases of right aortic arch with mirror image branching, up to 98% of these patients will have concurrent other congenital heart disease. We know that arch-sidedness may influence surgical incision site, placement of cardiopulmonary bypass cannulation, and even interventional approach. For certain interventions such as endovascular treatment with carotid stent, we know that arch anomalies can increase the technical difficulty of these procedures and also increase the risk of neurologic complications. And it's been found that if we can correctly identify arch anomalies in these patients, that we can help avoid potential complications in this. So from here, I just want to start with a little bit about what arch anatomy is, how we define left versus right aortic arches. So in this schematic borrowed from Bravo et al., I just want to highlight what a left aortic arch looks like too. So here, coursing from anterior to posterior, you can see the transverse arch coursing over the left main stem bronchus to the left side of the trachea. This makes it a left aortic arch. Conversely, the right aortic arch with mirror image branching courses to the right side of the trachea over the right main stem bronchus. A double aortic arch would have transverse arch coursing both to the left and the right of that bronchus. And then also, of course, we can have these arches with aberrant subclavian arteries. And so how do we currently look at the aortic arch? So this image here probably looks very familiar to many of you, the classic candy cane arch view. Just pointing out some things that we can see. We can see in the anterior mediastinum and isthmus, we can see the left innominate vein coursing in front of the head and neck vessels. Coursing behind the ascending aorta, we see the right pulmonary artery. We can also see the relationship to the right and left atrium. As I put this into motion, also labeling here in this view, seeing what we believe is the right innominate artery, the left carotid, and the left subclavian artery. We can put color on this image. We can see that it's clearly unobstructed. With all of this information, though, nothing tells us the sidedness of this arch. There's nothing to say that this is definitively a left or a right aortic arch. Technically, the argument could be made that if one of these branches was a separate origin of a vertebral artery, this could even be a double aortic arch that we are missing in this view. So which brings us, how do we diagnose arch-sidedness? Which is this view here, where we currently sweep superiorly through the ascending aorta, looking for the direction of branching of the first head and neck vessel. Here what you're seeing is this branch comes up and splits, coursing to the patient's right shoulder, the left of your screen, making arch-sidedness contralateral to the direction of this branching. So if it's branching to the right shoulder, then that makes this a left aortic arch. As you can imagine, if you've ever held an echo probe, this can be pretty tricky and has some limitations. So limitations of this, as mentioned, it can be pretty difficult, especially in critically ill patients, especially in those who are very small, like we see in our young neonates, and those who are intubated and have difficulty with neck flexion. We can miss double aortic arch with this method. This is challenged significantly by patients who have aberrant subclavian arteries, as again, we're looking for the branching of that first head and neck vessel, and if the subclavian artery is aberrant, makes that not possible. And actually, a recent publication found that up to 28% of patients with arch anomalies needed advanced imaging to fully delineate their arch anatomy. So I said that we were going to take knowledge that we already have today and see if we could apply it with what we know of anatomy to get better at diagnosing arch-sidedness. And this brings us to the fetal world. In fetal echo, they're able to look at a fluid-filled trachea to clearly decide on arch-sidedness, with the arch coursing to the left or right of that trachea that they see is fluid-filled in fetal life. So here in normal, you can see an arch and a duct coursing to the left side of this trachea, marked here, both echogenic and fluid-filled, making this a left aortic arch. This method allows our fetal echocardiographists to look at right aortic arch coursing to the right side of the trachea, a double aortic arch, and even holds up with aberrant left subclavian or aberrant right subclavian arteries. Which then brings us to our question. Can we use tracheal imaging during standard echocardiography to consistently diagnose aortic arch-sidedness and possibly also use it to rule out double aortic arches and pulmonary artery slings? So I want to use this image on the right side of your screen here to describe a little bit of the views that we are obtaining. So starting out in the suprasternal notch view or high right parasternal sagittal view, you can imagine having your probe in a vertical sagittal orientation, focusing on this blue SVC. And imagine if you swept from that SVC from right chest through midline to the left chest, that you could imagine seeing SVC trachea, if possible to image, and then an arch to see a left aortic arch. You could also imagine that if you turned your probe 90 degrees and came down on the chest a little bit, and you were still able to visualize the trachea, that you could see the branching of the pulmonary arteries around that echogenic trachea to definitively rule out pulmonary artery sling. And that's exactly what we attempted to do here. Just to give you another idea of what this would look like. So here, standard left arch, if you're sweeping from patients right to left or left to right on your screen, you would see trachea, then arch, making this a left aortic arch. Here, you could see arch, then trachea is a right aortic arch, or again, sweeping from left to right on your screen, right to left on the patient, arch, trachea, arch would be a double aortic arch. So our hypothesis for this was that we believed we could do a tracheal sweep, classically see the trachea, and use this as part of standard echo protocol to diagnose arch-sidedness and also rule out other anomalies as mentioned. So what did this look like? So we'll start out here first. What we did a prospective study from December 1st through early March when the COVID shutdown happened of all patients in our children's hospital less than 18 years of age who had a CT or MRI of their chest to serve as gold standard for aortic arch anatomy. These images, then we obtained echo images both in 2D and color without any additional images, just these 4 pictures, both of that right to left sagittal echo sweep from the suprasternal or high right parasternal notch view, and then a parasternal short axis view of the PA bifurcation straddling the trachea. After that, we had independent review of all images from our advanced imaging team of 2 different advanced imagers looking at the advanced imaging and our echo images as well. And so what did that look like? So starting out here, I just want to show you this sweep as we're coming from patients right to left through. As it starts over, you'll start to see blue flow through an SVC. As I'm sweeping to the patient's left, the tracheal rings come through into view in classic view, and then a widely patent left aortic arch. So again, SVC trachea arch, making this a left aortic arch. Again in another patient, same thing again. SVC trachea and then arch makes this a left aortic arch, and you are able to clearly see the echogenic rings of the trachea in this picture. And so I've shown you a couple of normal left aortic arch. The question then would be, can we see something different? So in this patient, what you'll see here in 2D, a patent arch, then followed through by echogenic rings of the trachea, making this a right arch. With color, again, arch coming first, and then trachea, right arch. And yet another example. There we go. SVC, arch, trachea, right arch. And then I mentioned we did one other view. So here I just want you to focus. You can see this beautifully echogenic trachea here, midline, being straddled by the pulmonary arteries, definitively ruling out a pulmonary artery sling. So who did we scan? So our cohort, we were lucky enough to get 100 consecutive patients in this time period that were evenly split between male and female. They covered the full spectrum of pediatric age ranges and sizes from newborns through those almost at their 18th birthday, from little babies, again, to quite large adolescents. And about half of them had a previous cardiac diagnosis, half of them did not. I should mention that their scans, some of them were cardiac scans, but many of them were CTs of the chest for other non-cardiac reasons. The scans themselves, so about 86% of them were done on an outpatient setting. The rest were done on patients who were in the inpatient. Some of these, actually many of them were in the ICU. Some of them were intubated for this, with the ET tube serving as even a brighter echogenic landmark for our study. 88% of them were completed by a sonographer with less than 1 year of experience. 6% of them were reported as being challenging. Notably, only 2% of the patients in this study had concurrent sedation or anesthesia on board, and 4% of our patients had a right aortic arch. So what did we find? So we were able to successfully image the aortotracheal relationship in 97% of our scans. They gave us a confidence interval of 94 to 100% and a p-value less than 0.05. We found that the pulmonary artery to trachea relationship was a bit more difficult to image, having success in 91%. But after excluding patients who had prior surgery on their pulmonary arteries, so that would be patients who had PA-plasty or those with prior LeCompte maneuver, our success level there was also 97%, confidence interval 93 to 100%, and a p-value less than 0.05. And notably, anytime we were able to see the aortic arch, we were 100% in making the correct diagnosis of arch-sidedness, as well as the absence of double aortic arch or pulmonary artery sling. So again, we were able to see the trachea and its relationship to the aorta 97% of the time, and the relationship of the trachea to the pulmonary arteries after exclusions 97% of the time. And in every one of those patients, we made the correct diagnosis with this method. So with that, where were we limited? So of course, echo is not always perfect, and there are certain times we were limited by acoustic windows. The patients in which we weren't successful, so one was the largest patient we scanned, just had difficult windows with body habitus. Another patient had a progressive mediastinal mass that made windows difficult as well. And then another with chronic lung disease, chronic trach dependence with difficult acoustic windows for echocardiography. So finally, in conclusion, tracheal sweep offers a reliable and easy method in patients of various sizes and levels of acuity to define aortic arch sidedness, to rule out double aortic arch and pulmonary artery sling. And we believe this also complements the existing ASC protocol. So my references here. And then also I just need to say thank you to our advanced imaging team members who read this, Dr. Ravi Ashwat, Dr. Bajoy Thitaliath, and then our sonographer crew who was nice enough to dress up as Paw Patrol for Halloween with me and taught me a lot of what I know about echo and helped get some of these scans.
All right, great talk. Thank you very much. While we're awaiting other questions in the Q&A box, would you feel comfortable sending a patient to the operating room for repair of a vascular ring or a double aortic arch with echo alone, or would you perform CT as well?
Yeah, I guess that's a tough question for me to answer because I wouldn't be the one holding the knife or the scalpel. I definitely think you can be confident in our diagnosis of arch-sidedness with this from what we've seen. You know, and I guess I would defer to surgeons' preference and how much they want to know on that, but I do believe we were able to definitively show sidedness with this method. And again, I believe this is to serve as a complement to existing protocols as well. And so this just gives us an extra tool in what we're already doing to show sidedness that hopefully will help us out in some of those challenging cases.
Yeah, personally, I'd agree. I think it can serve as a tool, but I don't know that it's as definitive to show the ring or the double aortic arch as we might hope. So, yeah, I think knowing all the information before they go to the OR.
Not use them.
Great presentation. Well, we got no other questions in the Q&A box, so we will move on.
Thank you.
Our final presenter for this session is Nina Morgan. Dr. Morgan is a resident at Children's Wisconsin in Milwaukee, and her presentation is entitled Serial Evaluation of Single Ventricle Function Using Deformation Imaging Predicts Adverse Outcomes in Patients with Fontan Circulation.
Thank you, Dr. Hill, and good afternoon, good morning to everyone. My name is Nina Morgan. I'm a third-year pediatric resident at Children's Wisconsin Medical College of Wisconsin, and I want to thank everyone for this opportunity today to present a research study entitled Serial Evaluation of Single Ventricle Function Using Deformation Imaging Predicts Adverse Outcomes in Patients with Fontan Circulation. I have no relevant disclosures. Despite improvements in survival, single ventricle dysfunction is common and is an important risk factor for adverse outcomes, including heart failure and death after the Fontan operation. However, standard quantitative echocardiographic assessment of ventricular function, for example with ejection fraction, is challenging this population due to variations in single ventricle chamber geometry and morphology. Therefore, most standard echo protocols primarily rely on qualitative assessment of single ventricle function, which can have poor inter-observer agreement. There is now increasing data on the utility of two-dimensional speckle tracking strain imaging as a more accurate method to quantify single ventricle function in patients with Fontan circulation. 2D speckle tracking strain measures changes in myocardial deformation or change in myocardial fiber length. There are now several research studies that have demonstrated that strain imaging is an accurate and reproducible assessment of single ventricle function. These studies demonstrate a number of abnormalities in strain measurements in patients with Fontan circulation, including reduced global circumferential strain and global longitudinal strain, as well as patterns of regional deformation abnormalities within the single ventricle myocardium. While strain imaging for Fontan patients has mostly been used for research purposes, since 2014, we incorporated global circumferential strain and global longitudinal strain into our standard clinical Fontan imaging protocol. In 2017, we published our experience with this new Fontan echo protocol and demonstrated that the measurements, including strain imaging, can be efficiently performed real-time with excellent inter-observer reliability. While this was an important step in improving our echo assessment for these patients, there is no clear data about the clinical utility of these quantitative measurements in demonstrating the longitudinal changes in single ventricle function over time, and about the relationship of these echo measurements with long-term cardiovascular outcomes for patients with Fontan circulation. Therefore, our study aims were to determine the changes in single ventricle deformation over time in patients with Fontan circulation, and to determine the relationship between baseline and serial changes in single ventricle deformation with risk for adverse cardiovascular outcomes. To accomplish these aims, we included patients that were at least 1 year post-op from their Fontan operation and had at least one transthoracic echo after the year 2014, when we introduced our revised Fontan echo protocol that incorporated strain imaging. Once we identified our patient cohort, we extracted global longitudinal strain and global circumferential strain measurements. We then performed a retrospective chart review to obtain data regarding patient demographics and clinical outcomes. This slide briefly explains how we incorporated strain imaging into our clinical Fontan echo protocol. During an echo study, the sonographer obtains high frame rate images with the goal of 70 to 120 frames per second with Siemens SC2000, which has their vendor-specific strain software package on the ultrasound machine itself. Following completion of the study, the sonographer performs the strain imaging on the ultrasound machine prior to starting the next study. The global circumferential strain is performed from the peristernal short axis at the level of the papillary muscles, and the global longitudinal strain is performed from the apical four-chamber view. The cardiologist reading the echo reviews the tracings and strain measurements, can make edits as needed, and then decides to incorporate the measurements in the echo report if suitable. The primary clinical outcomes of interest was any occurrence of a new diagnosis of heart failure, need for heart transplant, or death during the follow-up period after the baseline or initial echocardiogram. This slide shows the baseline demographics for the study cohort. A total of 286 patients were included in this study. The age at time of the baseline or initial echo within the study period after 2014 was 12.4 years. The time from Fontan operation to the baseline echo study was 8.9 years. The majority of patients, 58%, had single ventricle of right or indeterminate morphology, while 42% had single left ventricle morphology. The far majority of patients in the study had an extracardiac conduit Fontan connection, while only 16% had lateral tunnel connection and 1% with atriopulmonary Fontan. Finally, 13% of patients reached any of the primary adverse outcomes of either new diagnosis of heart failure, heart transplant, or death during the study period after the baseline echo study. This slide demonstrates the global circumferential and global longitudinal strain measurements for the entire study cohort. So just to orient everyone, on the y-axis here is strain measurements. It's important to note that higher or less negative values of strain are consistent with decreased deformation or ventricular function. Meanwhile, lower or less negative values of strain are consistent with better deformation or ventricular function. So looking first at the left-hand side of the slide, we can see that the mean circumferential strain for the entire study cohort was minus 16.1, but with a significant difference based on ventricular morphology. Patients with morphologic single right ventricle had significantly higher or worse strain compared to those with morphologic left ventricle. And then similarly, we can move on to the right-hand side looking at longitudinal strain. The mean for the whole cohort, was minus 15.1, but again, with a significant difference based on single ventricle morphology. Those patients with morphologic right ventricle had significantly higher or worse strain compared to those with morphologic left ventricle. And these results were still significant after adjusting for time and age after Fontaine operation. This slide shows the relationship of baseline strain values and risk for adverse outcomes. It shows that patients that had heart failure, transplant, or death after the initial echo had significantly higher or worse ventricular function in both circumferential strain and longitudinal strain. And then we can see, looking at the exact values, that the strain value for circumferential strain was about -11, and the longitudinal strain was about -13 for those patients that reached these adverse cardiovascular events. We then analyzed the serial changes in ventricular deformation over time. Overall, 213 or 75% of patients had more than one echo performed during the study period, and so had serial measurements of global circumferential and or longitudinal strain. The median number of studies for the cohort was 3, with a range of 2 to 7. And the median follow-up time after the baseline echo was 3 years, with a range of 1 to 6 years. These graphs demonstrate the change in circumferential and longitudinal strain over time. We found that during this relatively short study period, there was no significant change in circumferential or longitudinal strain for the cohort, regardless of ventricular morphology. For example, when we looked at the circumferential strain for the morphologic right ventricle, which is this solid black line here, the average is around -15, and we do not see a significant pattern of change over time, as demonstrated by a relatively horizontal line. Similarly, looking at the circumferential strain for the morphologic LV, which is this red hash line, we see that the value is lower at -20, but still is significantly, has a significant no significant pattern of change with this relatively horizontal line. And then we can see, moving on to the right-hand side of the slide, the longitudinal strain for both morphologic RV and LV have similar patterns with relatively horizontal lines. We then tried to compare the change in strain for patients based on clinical outcomes. We found that there was no significant difference in the change in either circumferential or longitudinal strain in patients that had heart failure, transplant, or death compared to those that did not reach these outcomes. This was a result of analyzing the data as continuous variables, but then when we analyzed the data as categorical, we did find some significant results that are going to be demonstrated on the next slide. This slide demonstrates the serial changes of global longitudinal strain compared to clinical outcomes. We found that patients that had a rapid decline in longitudinal strain of greater than or equal to 1% per year, which indicates worsening deformation over time. Excuse me. When we looked at longitudinal strain, patients that had worsening deformation of greater than 1% per year in the longitudinal strain, 19.6% of these patients reached the outcome of heart failure, transplant, or death, compared to only 8.3% of patients that had a slower decline in longitudinal strain. And this difference was statistically significant. This study had several limitations, including that it was a retrospective study at a single center. As a tertiary care center, we are subject to referral bias. In addition, not every patient had all of the strain measurements for both circumferential and longitudinal strain with each echo, as the reading cardiologist had the option of not including the values in the report if they felt the tracings were not accurate. And so there is some incomplete data. Finally, there was a relatively short follow-up period of only 3 years, thus making it difficult to assess for the association of strain measurements with adverse outcomes that may have not yet time to develop. However, despite these limitations, we feel our study shows that higher baseline global circumferential strain and global longitudinal strain are associated with morphologic right ventricle and higher risk for adverse outcomes in patients with Fontaine circulation. We found no clear pattern of change in single ventricle strain over time in the intermediate follow-up period. We do know that further studies are needed to understand the relationship between serial changes in single ventricle strain and risk for adverse clinical outcomes after the Fontaine operation. Thank you for your time, and I'm more than happy to answer any questions if anyone has any.
That was excellent. Thank you. Your talk did generate quite a bit of interest and some questions. First few questions are actually just sort of clarification of your study. So what was your definition of heart failure? And then do you have counts by each individual part of the composite score. So how many had heart failure, how many had death, and how many had transplant?
Yeah, so just to answer the second question quickly, I believe those were listed on the demographic slide, which I don't know if I kept control to go back to my slide. I don't have those in my notes, but on my demographic slide, it had the breakdown of all those patients, and the number was not mutually exclusive for all the patients that developed those separate adverse outcomes. And then our definition of heart failure was escalation of diuretics in the outpatient setting was at least one of the definitions. I'm not sure what other definitions we used.
Okay. And then did you include or exclude patients with significant AV valve regurgitation?
That was not one of our exclusion criteria, no.
Excellent. And then did you correlate strain with other measures like EF with invasive hemodynamics, exercise outcomes?
That's a great question, and that's something that we're looking for future studies to incorporate all that, but we did not look at ejection fraction to correlate with the strain measurements, and we did not use any exercise physiology in our study to correlate with that. We strictly looked at strain measurements from the echo reports with our clinical outcomes.
All right, and then have you considered, so I'll just read the full question. It appears that GLS and GCS was evaluated for systemic LV and RV together. Have you considered looking at whether GLS or GCS was correlated with poor clinical outcomes individually in the systemic RV and LV groups? It seems strain values were separated for RV and LV initially, but then grouped together for the outcomes portion.
What I think I understand the question is if we looked at the strain measurements, both longitudinal and circumferential strain, come to each ventricle separately, if I understand that correctly.
As far as outcomes go, yes.
Yes, we did. So kind of how each of the analyses was done was with the entire cohort, both the morphologic LV and RV together, and then we separated based on morphology, the further analyses. And I believe I did have a slide at the very end, the second to last, that showed that we had no significant change, no significant data in patients that reach heart transplant or death based on morphology.
Excellent. Great job answering the questions as well.
Oh, thank you.
We will break for lunch. We are on schedule, so we will reconvene at 1:30, so 1:30 Eastern, 12:30 Central. Again, just a reminder, during the break, the highlighted posters will be playing. If you go to the MWPCS website and up at the top, go to the abstract drop-down. You can view the highlighted posters as one of the tabs under that drop-down. The other posters we are trying to get posted, but we've had a little bit of a delay. But hopefully those should be available shortly today or maybe this weekend. We will see you back at 1:30. Welcome back, everybody. Hope you had a good lunch break. And I think we're ready to get started with our next session, which is a little bit of a hodgepodge of different topics. This is our cardiology potpourri. We have some fetal talks, some cath talks, and some heart failure and transplant talks. So our first presenter is Dr. Kristen Schneider. Dr. Schneider is a fellow here at Cincinnati Children's Hospital, and she will be speaking to us about late gestational fetal growth in infants undergoing stage 1 palliation for single ventricle heart disease. Go ahead, Kristen.
Thank you very much, Dr. Hill, and I'd like to thank the organizers for inviting me to speak today. As he mentioned, I'll be speaking about fetal growth in late gestation for infants with single ventricle congenital heart disease undergoing stage 1 palliation. There has been some prior work. Oh, let's see, I don't think I can quite, there we go. Some prior work that's demonstrated that fetuses with congenital heart disease are more likely to have decreased growth velocity and growth failure throughout pregnancy, but particularly in late gestation. These two graphs are from a study by Dr. Puri and her colleagues that looked at fetal growth for infants with a variety of congenital heart disease lesions in this top graph here, and then focusing in on fetuses with just single ventricle lesions. And as you can see, starting at about 32 weeks gestation, most of the congenital heart lesions are either below 0 or nearing 0 for a weight Z-score compared to normal healthy infants at similar gestation or fetuses at similar gestation, and they continue to decline throughout the remainder of pregnancy. This declining fetal growth can sometimes result in infants being delivered once they reach term, with that flagging growth being interpreted as a sign of potential fetal trouble should the pregnancy continue. This may result in these infants being perhaps delivered a little bit earlier than they would have if spontaneous labor had occurred, as is suggested by this data here from an analysis of data from the Consortium of Safe Labor that looked at live-born infants greater than 34 weeks gestation and found a difference in planned C-section among women who had a prenatal diagnosis of a fetal cardiac anomaly versus women who had a postnatal diagnosis. We know that delivery timing for infants with a prenatal diagnosis of congenital heart disease, particularly single ventricle lesions, is a balancing act between the risk of low birth weight and fetal demise, and delivery planning so that delivery occurs at an ideal time and location when postnatal resources the infant may need are available. And we know that some of the outcomes from these early decisions surrounding birth and the initial surgery are risk factors for long-term mortality, particularly in that first year of life and when mortality is the highest. This data from the SVR trial highlights some of those known mortality risk factors, some of which are clinical risk factors associated with the operative and post-operative characteristics of the patient, and some of which are factors intrinsic to the patient, such as their genetics, which are fixed, and then birth weight, which is fixed once the infant's born, but we may be able to optimize that birth weight if there are modifications we can make to delivery timing that are safe for both the mother and the infant. We also know from a delivery timing perspective that the outcomes for all term infants, meaning babies delivered at 37 weeks gestation or greater, are not equal. This 2014 analysis of data from the Society of Thoracic Surgeons database looked at about 4,700 neonates with congenital heart disease who had neonatal surgery. So not just single ventricle lesions, but infants with critical congenital heart disease. And they found in this graph on the left here that infants born at 37 weeks gestation had higher in-hospital mortality compared to a 39.5-week gestational age reference point, with an adjusted odds ratio of 1.3. They also found that these infants born at earlier term gestations of 37 and 38 weeks had longer postoperative lengths of stay, in this graph on the right, and higher complication rates, again compared to that 39.5-week gestational age reference point. So given what we've learned about the outcomes at these various term gestations and the delivery timing considerations, both from a fetal perspective and from a postnatal resource perspective, the ideal delivery timing for infants with single ventricle congenital heart disease remains a little bit elusive. So we wanted to better understand growth in late gestation for these infants with single ventricle heart disease to help inform decisions around delivery timing. We know these babies don't grow well, but do they actually stop growing? And we also wanted to see if there were other prenatal factors that may be associated with delivery at earlier term gestations, and then look at postnatal outcomes associated with these gestational ages as well. So I know many of you are familiar with NPC-QIC, but briefly for those who are not, the National Pediatric Cardiology Quality Improvement Collaborative is a nationwide network of 68 institutions in 32 states that seeks to reduce mortality and improve quality of life for infants with single ventricle congenital heart disease. Infants at participating NPC-QIC centers who have a diagnosis of single ventricle heart disease that requires stage 1 palliation are eligible for enrollment in the registry. And for our cohort, we included infants born with a gestational age of greater than or equal to 36 weeks. We then looked at birth weight and birth weight z-scores and compared them across gestational ages to normal values, similar to what others have done, and looked at the outcome measures postnatally that you see here. So we identified 1,290 infants in phase 2 of the NPC-QIC cohort with the breakdown by gestational age in weeks across the top there. And among several clinical characteristics associated with increased mortality and poor outcomes, such as a restrictive atrial septum or the need for ECMO postoperatively, we didn't find any significant clinical difference between these gestational age groups. From a cardiac diagnosis standpoint, the vast majority of these infants were infants with a single right ventricle, mostly hypoplastic left heart syndrome, but a few with double outlet right ventricle and severely hypoplastic left ventricles. And then the most common stage 1 palliation performed was a Norwood procedure with a Sano shunt, followed by a Norwood procedure with a BT shunt being the next most common. Looking at growth by gestational age, you can see for the whole cohort in this top gray box here, and then broken down into males and females down below. There was no difference between the males and the females from either a birth weight perspective or a birth weight z-score perspective at equivalent gestational ages, and both the boys and the girls followed the trend of the whole cohort with increasing mean birth weights with increasing gestational age, and z-scores that were below 0 at all points in late gestation. So here is a graphical representation. If you look over here at this graph on the right, looking at the birth weight z-scores, you can see that it looks similar to what other work has shown, such as the graphs from work by Dr. Puri's group. At this point in gestation, 36 weeks and beyond, the z-scores are all below 0. So these babies are smaller than expected compared to normal controls. But if you look over here at birth weight, the graph on the left, you can see that these infants are continuing to grow, that birth weight is increasing with increasing gestational age. It does, the rate of growth does slow down from about 38 to 40 weeks gestation, and particularly after 39 weeks, growth really begins to plateau, which you can also see corresponds to, on the z-scores graph on the right here, a somewhat precipitous drop-off in those z-scores as the difference in weight between babies with heart disease, single ventricle congenital heart disease, and normal infants becomes even wider. So while these infants with heart disease are smaller than healthy infants at this point in gestation, they are still continuing to grow, albeit at a slower rate, up until about 39 to 40 weeks when growth begins to plateau. We also looked at other factors we thought may be associated with delivery at earlier term gestations. The vast majority of our cohort had a prenatal diagnosis, particularly those delivered 36 to 39 weeks. There were 60% of the patients born 40 weeks or after had a prenatal diagnosis. And we hypothesized that a fetal cardiac intervention may lead to an earlier natural delivery, but this didn't bear out in our analysis. However, we had relatively few patients in the entire cohort who even had a fetal intervention in the first place. Infants born at earlier gestations did tend to be, earlier term gestations did tend to be born at their stage 1 palliation center. Of course, not all stage 1 centers have the ability to do deliveries, and we think some of this may reflect prenatal diagnosis, as you can only plan for an infant to be born at a children's hospital if you know there's an indication to do so. Looking at our postnatal outcomes, we had a little over 1,200 patients who had available mechanical ventilation data. And you can see here in the first row of the chart that with increasing gestational age, the length of postoperative mechanical ventilation decreases. Infants at younger gestational ages were no more likely to fail a trial of extubation, as judged by being reintubated within 48 hours of that initial trial. So while they took a little bit longer to be ready for extubation, of course, as assessed by their surgical center, and thus had more time on the ventilator postoperatively, once extubated or once they had that initial trial of extubation, they were no more likely, these younger infants, to be reintubated in somewhat short order compared to those infants born at older gestations. From a length of stay standpoint, we had about 1,000 infants that survived either to discharge or to stage 2 palliation if not discharged. In the bottom row of the table here, you can see that being born at a younger gestational age was not associated with staying inpatient until that stage 2 palliation. Infants that were discharged and born at earlier gestational ages tended to be a little bit older when they ultimately went home, which we think likely reflects their older age at that time of initial stage 1 palliation. You can see in the first row here. However, there was no statistically significant difference, looking at the middle row, that we noted in postoperative length of stay across the gestational ages. However, while the length of stay is statistically similar, clinical difference of 10 to 11 days between those infants born at 36 to 38 weeks and those born at 39 to 40 weeks may be quite important, given that this is already a long hospitalization, and placing continued stressors of that on the family and the continued morbidity that we know is associated with longer hospitalizations. And for our last outcome, looking at survival to stage 2, we had about 15% of our cohort that died, with most of those deaths occurring prior to stage 2 palliation, and an additional 4% of the cohort who were referred for transplant. Again, most of those referrals happening prior to stage 2. Weight and age were no different across the groups at the time of stage 2, but you can see here that infants born at later gestational ages, particularly after 38 to 39 weeks, were much more likely to be stage 2 candidates, which mirrors the trends we saw with length of stay and mechanical ventilation, with longer gestational ages resulting in improved outcomes. So overall, our data suggests that infants with single ventricle congenital heart disease have decreased growth velocity in late gestation, but that growth does continue, albeit at a slower but relatively steady rate up until about 39 weeks. And we have improved postnatal outcomes with longer gestations. Ultimately, the delivery timing of infants with single ventricle congenital heart disease is complex. There's a lot of moving parts to consider, but our data suggests that the fetal growth velocity should be examined in the context of other markers of maternal and fetal well-being, as while these babies aren't growing at the same rate as normal controls at this point in pregnancy, they are still growing, and with longer gestations, we do see improved postnatal outcomes. So with that, I'd like to thank my co-authors for their mentorship and guidance with this project, and I'm happy to take any questions.
Excellent. Thank you, Dr. Snyder. We will open it to questions. You can post your questions in the Q&A box. And just a reminder, please use the Q&A box and not the chat box. It's easier to keep track of the questions in just one space. We will also open a poll where you can vote on Dr. Snyder's abstract. As we've said, and just a reminder, this will be used to help determine the awards for the presentations. While we await some of these responses, I'll ask Dr. Snyder questions. We often get caught in a little bit of a battle between the maternal fetal medicine specialist and the cardiologist, with the cardiologist pushing for later delivery and the maternal fetal medicine provider pushing for a slightly earlier delivery just to prevent any risk of demise. How do you see this data weighing into that?
I think some of the discussion we had surrounding this work is who are important audiences to share it with. I think that cardiologists are the first that come to mind, but as you know, the maternal fetal medicine teams, I think, are just as important, because this will help give them guidance on what they may be able to expect as normals for these babies, rather than expecting normal for a healthy pregnancy, to guide some concerns they maybe that aren't as well established, I should say, with this single ventricle population.
Great. I think we have one other question in the Q&A box. It says, great presentation. I would not expect delivery just based on decreased growth. Do you have any data on fetal Dopplers in this population?
Oh, I completely agree. I think growth is one piece of the puzzle the maternal fetal medicine team uses when they're thinking about delivering these babies. And with this project, we were hoping to give them a little bit more insight potentially on how much weight to put or not put on that piece of the puzzle. We didn't look at fetal Dopplers in this work specifically, but I know others have.
Excellent. Thank you, Dr. Snyder. We will move to our next presenter. Our next abstract is from David Seeger. David is a fellow at Children's Wisconsin in Milwaukee, and his research is entitled Postnatal Imaging and Hospitalization of Infants with Fetal RV-LV Size Discrepancy. Take it away, David.
Thank you very much, Dr. Hill. And thank you for the opportunity to present my talk. So as mentioned, we looked at postnatal imaging and hospitalizations of patients with fetal RV-LV size discrepancy. My mentor for this project was Dr. Michelle Frommelt. So there's a little background information on ventricular size discrepancy, RV-LV size discrepancy. There's a number of different terms for it, but essentially what it speaks to and what we looked at was patients who had a disproportionately smaller left ventricle compared with their right ventricle. And this is a common indication for referral for a detailed fetal echocardiogram that the MFM will refer based on their findings on an anatomy scan. LV-RV size discrepancy may be suggestive of coarctation of the aorta, which is one of the specific questions that we have, although other conditions can cause a similar size discrepancy where the right ventricular appears disproportionately larger. A number of those are listed here in this table. It is not an exhaustive table, but other left-sided pathology, anomalous pulmonary venous return, genetic syndromes, atrial septal aneurysm, which is something we'll come back to later, CNS anomalies, interestingly, congenital diaphragmatic hernia, for example, not on this list, but is pertinent as well. And then oftentimes the normal, structurally normal heart, normal fetus will have what appears to be on fetal echocardiogram, discrepant ventricular sizes as well. So as mentioned, coarctation of the aorta was the thing that we were most interested on, and this can be difficult to diagnose prenatally for a number of reasons. One is the small nature of the aortic isthmus. Just a quick review of our fetal circulation is that the predominance of the blood is shunted across the ductus arteriosus, and that's distal to the aortic isthmus, and the antegrade blood flow off the left ventricle is predominantly to the head and neck vessels. So sometimes only 10–15% of blood flow will go across the aortic isthmus prenatally, and so it can appear small due to just the physiology. In addition, the presence of a normal large ductus arteriosus in that area can complicate getting great pictures of the aortic isthmus. As we know from our postnatal imaging, that a large ductus can make it difficult to diagnose coarctation even postnatally, which is one of the things that we'll get back to as well. There are some specific things that have been shared in the literature, measurements from the fetal echocardiogram that have been suggestive of coarctation of the aorta. Obviously, if you see a discrete shelf or discrete narrowing, and actually in 2D or in color, visualize evidence of a coarctation. There can be continuous forward flow in the isthmus, the z-score of less than -2, and then both aortic annulus to pulmonary annulus ratio, as well as a mitral annulus and tricuspid annulus ratios of less than 0.6 are all fetal findings that are suggestive of coarctation, depending on the data source or the publication. Published data says that those are anywhere from kind of 70 to 80% predictive value. Again, it depends on your data and how recent that is. Oops. So the postnatal management of these patients with fetal LV-RV size discrepancy is primarily dictated on concern for coarctation of the aorta, because as we know, that can be a serious fetal presentation of and can result in significantly impaired circulation and can result in pathology at an early age. And so that's something that's not one to be missed. At different centers, there is a wide variety of strategies, and even at our center, there's been a kind of a wide variety of strategies on the postnatal management of these patients. It can be anywhere from admitting them to the NICU, starting kind of prophylactic prostaglandins to keep the duct open, and then proceed with the postnatal transthoracic echocardiogram. Could be NICU, a postnatal, excuse me, this is a typo, should also be a TTE, another transthoracic without prostaglandins. You know, the timing of this is variable, or going to the newborn nursery and delaying the initial transthoracic echocardiogram. This is dependent on a number of things. It can be dependent on other intracardiac pathology seen on the fetal echocardiogram, or other concerns that the patient may have, whether or not they need to go to the NICU for other reasons. Here on the side of the screen is the fetal level of care at Children's Wisconsin, which kind of triages the timing of cardiac evaluation, the need for prostaglandins, the timing of the echocardiogram based on the fetal concerns. And I'll highlight a few specifically that most of these patients fall into is level of care 1, 2A, 2B. Some patients are level of care 3 as well, but those typically have other intracardiac pathology identified on the fetal echocardiogram. And so you can see, kind of focusing on the difference between 2A and 2B is when the initial cardiac evaluation is and when cardiac testing occurs. So patients that are level of care 2B, they're supposed to have an echo kind of within 4 hours of birth, as opposed to patients who are 2A, kind of the echo occurs after 24 hours. And we thought this was kind of an interesting thing to highlight because, as we'll look, patients with fetal LV-RV size discrepancy are often triaged into this 2A and 2B. And so what we really wanted to do was we wanted to optimize the postnatal care of these patients. And we kind of constructed a quality improvement project to evaluate the postnatal care to really meet 3 goals. One was to encourage maternal and infant bonding, whether that be for emotional needs. There's also a lot of new data suggesting that that's important to help with feeding. And that we thought could potentially be hindered in the NICU as opposed to a newborn nursery admission. We wanted to ensure timely diagnosis of any underlying structural cardiac defects that could have a hemodynamic impact, specifically coarctation again. We also wanted to minimize any healthcare costs. So what we really looked for was we wanted to assess the timing and frequency of postnatal echocardiograms and correlate them with fetal echocardiographic findings to determine what was the optimal way to care for this patient population. So we just did a retrospective QI cohort study looking at patients that had a fetal diagnosis of RV-LV size discrepancy from 2017 to 2019. And here we see that there were 17 patients that were born with a prenatal diagnosis of LV-RV size discrepancy. Just this demographic data showing that the initial fetal was typically at 29 weeks, although that's pretty variable. On average, these patients had 1.7 fetal echocardiograms and had 2.2 postnatal. Here we can see how they're delineated by their fetal level of concern, and that 2 were level of care 1, the majority were level of care 2A or 2B, and 3 patients were level of care 3. As noted, the level of care 3 patients all had additional fetal echocardiographic findings, which made us more worried, specifically mitral valve pathology, typically. The postnatal diagnosis of these patients, so 5 of these patients ended up having a coarctation, 8 ended up having aortic arch hypoplasia, which we define as a Z-score of less than -2, and 3 had what we determined was normal aortic arch anatomy. You'll note that there's only 16 patients that had a postnatal diagnosis. 1 patient died shortly after birth from severe pulmonary or persistent pulmonary hypertension of the newborn with congenital diaphragmatic hernia. And they did not have clear delineation of their arch anatomy. Although, again, it was never truly defined, it is common to have compression of the left ventricle from abdominal organs, such as stomach, liver, bowel, and setting of a diaphragmatic hernia, which can make the LV appear smaller. So we hypothesize that may be the case, although we'll repeat that an arch anatomy was not clearly defined. Looking at their fetal echocardiographic findings in this patient, so the patients that we identified as RV-LV size discrepancy typically had an aortic annulus to pulmonic annulus ratio of just about 0.6, slightly higher, and similar with tricuspid annulus to mitral valve and annulus of just about 0.6 as well. Their other fetal findings were notable for 5 patients having an atrial septal aneurysm, and of note, no patients with an atrial septal aneurysm or the patient who had a left superior vena cava had coarctation of the aorta. And you'll recall that these were other things that have been described in the literature as being suggestive or causing fetal RV-LV size discrepancy. And then, as mentioned, there was other intracardiac pathology. These were in our level of care 3 patients that had a ventricular septal defect and mitral valve dysplasia or hypoplasia. So looking at the postnatal diagnosis and the number of echocardiograms that these patients had, that was one of the key things we were looking at. So the 5 patients who had coarctation of the aorta averaged about 2.5 echocardiograms in the first week of life. Those who had aortic arch hypoplasia and so did not have a true coarctation also averaged more than 2 echocardiograms. And the 3 patients who had normal arch anatomy had about 1.6 on average echocardiograms. So 2 of them had 2 and the other patient had a single echocardiogram. So just to kind of delineate that, sorry, there's a lot of text on this slide, but just to kind of really tease this out. So 16 patients had an echocardiogram within 24 hours of birth of those 17 patients. And all of them required subsequent repeat imaging. And so that this initial echocardiogram within 24 hours was inadequate to fully assess their arch anatomy. We had 1 patient who had a single echocardiogram after 24 hours of life. This patient did not acquire additional imaging, and the imaging was felt adequate to fully characterize the arch anatomy. The 5 patients who underwent coarctation repair all required a second echocardiogram to confirm the diagnosis, at least another one, and were subsequently started on prostaglandin without any evidence of cardiogenic shock. So what that's saying is that all the patients had their initial echocardiogram within 24 hours of life. They were not started on prostaglandin at this time. The repeat echocardiogram was obtained the following day, which was either that day or the next day, which was suggestive of coarctation. And at that point, they were put on prostaglandin. So all were put on prostaglandins after 24 hours of life, and none of them had any evidence of cardiogenic shock. The other thing to note is that the 8 patients with aortic arch hypoplasia, none of them have required any surgical or catheter intervention. Oh, I'm very sorry. So we also wanted to look at costs of this, and that we felt that there were significant healthcare costs related to the NICU admission and the serial echocardiograms of these patients. There's pretty good data already in the literature that kind of describes this. Evers et al. Found that neonates with clinical concern for coarctation with essentially normal cardiac anatomy, although aortic arch hypoplasia would be included in that cohort as well, had an average NICU length of stay of over 3 days and a hospitalization cost of just about $30,000. On the other hand, uncomplicated newborn stays can range anywhere from $800 to $2,000. This excludes maternal cost of the hospitalization. This also would exclude the additional cost of an echocardiogram, estimated at around $1,000, but just kind of demonstrates the variability and how much more cost there is to the healthcare system to admit patients to the NICU as opposed to the newborn nursery. So what we took away from this was that we felt pretty comfortable saying that postnatal imaging in the first 24 hours of life in patients with RV-LV size discrepancy is inadequate to assess arch anatomy due to the presence of adductus arteriosus. And as such, we've changed some of our postnatal care of these patients to the point that we are delaying their initial transthoracic imaging until after 24 hours of age and deferring a NICU admission unless there are additional fetal concerns or other postnatal pathology is identified. These are my references, and I'd be happy to answer any questions. Thank you very much.
Excellent. Great presentation. I think we have time for maybe one question. There's one in the chat box or in the Q&A. The logistical differences between 2A with an echo at less than 12 hours and 2B at less than 4 hours are considerable. 2B patient may need an echo in the middle of the night, but 2A you could usually defer till daytime hours. If that early echo is rarely diagnostic, who does it?
So I think the question is asking who's doing our echocardiograms overnight.
I think it's supposed to be why do it.
Why do it?
Yes.
Yes, that is an excellent question and kind of what we took away from that as well. And the answer is don't do it. And so we have, in fact, in this patient population, stopped doing it. And so we're delaying those initial. And so these patients will typically now either be fetal level of care 1 or 2A, neither of which are requiring that overnight echocardiogram.
And do you still use the 2B designation for other patient diagnoses?
Yes, we still do use that for other things. So if they have, perhaps with RV-LV size discrepancy as well as other fetal concerns or other pathology identified, will be kind of an example of another reason that we would use the 2B, like a tetralogy of Fallot that we think will likely not be a shunt dependent, would still probably be a 2B. So kind of a pink tet would typically be a 2B patient. Truncus, I think, is another example of patients that will kind of fall into the 2B category.
Excellent. Thank you for your presentation.
All right. Thank you very much.
Our next speaker. Our next speaker is Allison Tabor. Allison is a fellow at the University of Minnesota, and she will be talking to us about cardiac output measurement comparison, electrical cardiometry versus pulmonary artery thermodilution.
Hi, I'm Allison Tabor. I'm actually currently a pediatric cardiac critical care fellow at Ann and Robert Lurie Children's Hospital of Chicago. This work was done when I was a pediatric critical care fellow at the University of Minnesota, hence the slide theme. Talking a little bit about the background for this study, thinking about cardiac output, knowing that this requires to determine cardiac output requires invasive measures. This is done sometimes in ICUs with a Swan-Ganz catheter, but I think we've found it's rarely done in pediatric populations. There's been some adult literature that showed that these may actually increase mortality and morbidity. And then another way to invasively measure cardiac output is in the cardiac cath lab with pulmonary artery thermodilution, which is considered, I'll put in quotes, the gold standard. You can also use the Fick equation to determine cardiac output. Given kind of that background information that this requires invasive techniques, may increase mortality, morbidity, there's been development of non-invasive technologies. One of those, and what I looked at, was electrical cardiometry. And these have been used to estimate cardiac output and associated parameters such as systemic vascular resistance. So this was a prospective study comparing cardiac output measurement that was obtained via pulmonary artery thermodilution in the cardiac cath lab versus the measurements obtained with electrical cardiometry with a device called the ICON by Osipka Medical. So talking a little bit about electrical cardiometry. The premise is there is an alternating current that is sent to the body through surface EKGs. You have a total of 4 surface ECG leads, 2 on the neck, 2 on the thorax. The current is sent out, demodulated, and received back by the icon. Bernstein-Osipka developed an equation based on the amount of demodulation and the change of conductivity in which they estimate cardiac output. There's another picture. And so you can see on this photo, their idea is that the main fluid component of the thorax is blood in the aorta. And so when cells are in diastole, they're more randomly aligned and will cause greater impedance. And when they're in systole, they're more aligned and will cause less impedance. And that's kind of the premise and what they developed their equation on. Next. Okay. So again, this was prospective, looking at 26 participants undergoing previously scheduled cardiac catheterization. All these participants were planned to have pulmonary artery thermodilution performed. And to have that performed, you need to basically have a structurally normal heart. And so that included and excluded a variety of patients. The mean age of our patient population was 13, mean weight 46 kilos, height 150 centimeters, BSA was 1.4. There were 15 females and 11 males. The majority of the patients had undergone a heart transplant and were there for hemodynamic monitoring and monitoring for rejection. And the single patient who did not have a heart transplant was undergoing hemodynamic evaluation in the setting of left ventricular non-compaction. And this patient did have a dilated aorta. The cardiac catheterization proceeded in the regular fashion. I was present at each of these and placed the device on the patient. And when pulmonary artery thermodilution was performed, the measurement of cardiac output from the non-invasive device was noted. 3 measurements of cardiac output from pulmonary artery thermodilution were done, and 3 from the Osipka. Those were averaged and compared to each other. And so looking at the results, we did a Bland-Altman analysis. This is used to assess a new testing modality compared to a gold standard. And looking at this graph, on the x-axis, we have the means. So that's the cardiac output measurement from the electrical cardiometry plus pulmonary artery thermodilution divided by 2. And then on the y-axis, you see the differences. So that's just the absolute value of the difference between the 2 measurements. And so if we were to see better agreement between these 2 modalities, you would see more points aligned along the 0 x-axis, but you can see there's quite a bit of variability comparing the means to the differences. The limits of agreement, which can be thought of the values that are within 2 standard deviations, were negative 1.4 liters to 4.1 liters per minute. The bias, which is the mean difference, was 1.35 liters per minute. We also calculated a Cohen's kappa, which was 0.47, and that's for inter-rater reliability. And to give a little more information, we decided prior to the study, based on other literature, that acceptable limits of agreement were from negative 0.5 liters per minute to 0.5 liters per minute. And so this was outside of the range that has been found in some other literature and therefore found not to agree. We did end up looking at a subset of participants with a BSA less than 1.5, just looking at the data, and they did have a better limits of agreement. It wouldn't be within what we were saying was clinically acceptable. And a smaller bias or mean difference. We then concluded that the cardiac output measurements utilizing electrical cardiometry with the ICON did not agree with measurements obtained via pulmonary artery thermodilution. This is consistent with one other study that compared pulmonary artery thermodilution to the OSIPCA, and they did not find good agreement. A majority of other studies have found better agreement between using the Fick equation and pulmonary artery, or excuse me, the Fick equation and the non-invasive technology. We propose that part of this could be with the patients with the higher BSA, increased distance for the current to traverse and could impact the results. Also, knowing that the ICON relies on blood flow through the aorta to measure cardiac output, our patient population, the overwhelming majority had undergone heart transplantation and thus aortic manipulation. And so wondering if that could cause any sort of discrepancy or contribute to the difference. I think what really needs to be done in the future, and I think people at University of Minnesota may be starting to undertake this work, is seeing if using this device actually affects clinical outcomes. You would hope that it would, and that a non-invasive technology wouldn't give you the increased mortality and morbidity of invasive means that we talked about in the beginning. But I think this is what's really needed to be done to see if we can use and trust these non-invasive technologies. Also, we do have, what kind of prompted this study for me was we use this device at this institution, and I don't know how much their buy-in there was for using this, and I don't know if this study exactly helped, but seeing if the exact difference between the measurements matters as much as using this to trend values as you do sometimes with something like NIRS monitoring. And that is the data and presentation, and thank you everyone for listening.
Great job. I'm going to stop sharing so that Terry can hopefully take over and get the poll question up. We do have one question in the question and answer box. It would seem like this would be most useful in the ICU if you could trend it like NIRS. Do you have data on that?
Hi, John Hokinson. I remember you from Madison. As I said at the beginning, or kind of at the end there, I think that would actually be quite useful. Just my own time I've used it, this is just my feeling and no data on that. I think it has seemed to correlate, and I always, as an ICU person, tend to love more data, but I think that is kind of what's really needed in the future.
It seemed like it worked better at lower cardiac output, so less than 4 seemed to correlate fairly well. Do you think using cardiac index, do you think it's a size thing, or do you think it's a true output difference?
I think that is hard to say. It could be interesting too to look at the index numbers and see if that gives you any difference. We did output based on some of the other studies that had also done the absolute output.
All right, excellent job. Thank you very much.
Thank you.
We will move to our next presentation. And actually our next 2 presentations are both by the same person. Kamel Shabani is a resident at University of Iowa. His first talk along the CATH theme is preclinical comparative assessment of a dedicated pediatric PLLA-based bioresorbable scaffold with a low-profile bare metal stent. Go ahead.
All right, that's a bit of a mouthful there.
Yes. Terry, are you back and running? Can you get his slides? Or would you like me to try?
Let's see what we.
No, it still has me locked up saying that Allison is a secret agent.
Let me see if I can get it.
Let me know when you guys want me to go ahead and get started.
Take it away. You should have mouse control.
Ah, perfect. Okay, well, thank you very much for the opportunity to present. I'm actually a first-year fellow at the University of Iowa in cardiology. Kind of overview of why exactly the study was performed. Really, the intent was to try to create a pediatric-specific bioresorbable stent. And the appeal of bioresorbable stents has long been understood. And in fact, people kind of started thinking about them in the early 90s. And specifically so in adults, but as we've progressed in pediatric interventional cardiology, I think people have come to understand more and more the utility of them, specifically in the pediatric populations. If you can avoid having to put a stent and then resize it multiple times, and potentially even go in and do a surgery to remove the old stent, replace it with a new one, that would be ideal. So having a bioresorbable stent allows for growth and also limits vasomotor function of the vessel that you are stenting. The crux of the problem really has been in creating a pediatric specific bioresorbable stent is you always have two factors at play. The first is the profile of the device that you want to create. You want to create something that's as low profile as possible, but one that can still withstand radial strengths that will be forced upon it by placing it in an aorta or a pulmonary artery. And that's not really an issue that's present in the adult world where they're placing their stents in the coronary arteries, but more so in the pediatric world. And in particular, really, there's been a disincentive for a lot of pharmaceutical companies to spend a lot of money on pediatric-specific bioresorbable stents or scaffolds, just because the sheer number that we put in is very small in comparison to the adult world. So the focus has mostly been on the more profitable adult bioresorbable stents. And so what we've resorted to as a pediatric cardiology world is really using off-label coronary stents from adults. A couple of examples include the bioresorbable vascular scaffold that was used in pulmonary artery disease. However, that resulted in restenosis. And there was another off-label use of a Biotronic adult stent for both pulmonary artery stenosis and coarctation. However, since then, Biotronic has gone out of business. And these are just two examples. There's a lot more off-label use of coronary stents, but just kind of to highlight the fact that most of our use is really not of pediatric-specific stents. Some pediatric-specific stents are in the works, and I just highlighted a couple. One is from Ohio, PediaStent, and another is from Texas, 480 Biomedical. And so the aim of this study was really to assess the characteristics of a dedicated polymer-based bioresorbable scaffold in central and peripheral arteries of weaned piglets. And when I say characteristics, I'm talking about three things really. I'm talking about efficacy of placement, meaning are we able to place it successfully in the aorta and branch pulmonary arteries? I'm talking about safety. And so we're talking here about adverse events and unscheduled deaths. And those were the two primary aims. And as a secondary aim, we wanted to look at short-term performance. And it's really important to highlight here that it was a very short term. So at most we did 90 days. But the primary goals were really safety and our ability to properly put these stents in. So the methods is we use 42 devices. 22 of them are BRS or bioresorbable scaffolds, and 20 of them were bare metal stents or BMS. They were implanted in 14 animals. The hope was to be able to implant each animal with 4 stents, 2 in the aorta and 2 in the branch pulmonary arteries. And the aorta would have a BRS and a BMS, and each of the branch pulmonary arteries would have a BMS and a BRS. So we'd always have a kind of a test and a control in the same animal in similar vessels. The BRS that we used was a PLLA-based pediatric scaffold, and that simply refers to the type of material that was used to create it. It's a poly-L-lactic acid stent. You can create bioresorbable scaffolds from various different components. PLLA is just the most commonly used. It was a 6x18 stent, and the comparison was a Cook Formula 6x20 millimeter stent. We collected data mostly at day 0 when we first implanted these stents, and then again at day 30 and 90. And 0 was baseline, 30 and 90 was our kind of acute and subacute. And then at day 3, we collected some data looking mostly at acute thrombosis in a couple of these piglets. And so the schematic kind of looks like this. At day 0, we had 14 animals which underwent baseline data collection that include intravascular ultrasound and angiography. At day 3, we sacrificed 2 of these piglets that underwent histological assessment. At day 30 and 90, we sacrificed 7 and the remaining 5 animals respectively, and they underwent histological assessment, histomorphometric assessment, IVUS, angiography, and some of the animals underwent scanning electron microscopy at day 30. So when we talk about histological assessment, I just wanted to show you guys what exactly it is that we use. This is called the Schwartz histological assessment scale, and it's basically we're looking at injury, inflammation, fibrin deposition, and endothelialization of these stents. And this is the table that we use to grade the different metrics. I'll point your attention here to inflammation. We'll talk about that shortly in a couple of slides, but that's one of the very interesting histological findings. Angiographically, we looked at percent diameter stenosis and late lumen loss. And I just put the formulas in here for you guys to be able to look at them, but essentially they're pretty self-explanatory. You're looking at percentage of stenosis from the time that you measured compared to baseline, or late lumen loss where you're looking at absolute numbers and not percentage. And histomorphometry, which is basically similar to histology, and what that means is you sacrifice the animals, you fix and stain the vessels that you want to look at, and then you look at them under a microscope, and you ask a computer to make measurements of the vessels themselves, measuring the various layers of a vessel, the intimal, the medial, or the adventitial layers, as well as the lumen itself. And we also looked at mean intimal thickness. And so we'll next, well, I guess lastly, with regards to IVUS, it's intravascular ultrasound. The direct measure is diameter, and we extrapolated area from that. So these are all the metrics that we looked at. So what about our results? So from a safety standpoint, remember, this was really a preclinical trial. And so we were really mostly interested in safety and are we able to successfully implant these bioresorbable scaffolds. From a safety standpoint, we had no unscheduled death, either in the bioresorbable scaffold or the bare metal stent group. We had no acute thrombus formation in either, again, the BRS or the BMS group. We did have a couple of major adverse events. We had 1 episode of ventricular fibrillation that required electroconversion, and we have 1 episode of main pulmonary artery perforation. Oddly enough, actually, both of these happened in the bare metal stent and not the bioresorbable scaffold. And so from a safety standpoint, the BRS showed that there was really no concerns with either unscheduled deaths or major and minor adverse events. There was also no issue in being able to place them. We were able to deploy all these bioresorbable scaffolds without any issue at all, both the BRS and the BMS. The only issue we ran into with the BMS was the perforation, but that was likely more pre-deployment. From a results standpoint, just drawing your attention to histology and particularly to the inflammation. So we're looking at the first set of rows here. We're looking at day 3, day 30, and day 90. I want to show you that at day 3, there didn't seem to be much of a significant difference as far as inflammation goes between using a scaffold and a stent. However, look at day 30, and you can see that there's quite a big difference that's now established where the stent inflammation has actually gone down, but the scaffold, the bioresorbable scaffold inflammation has continued to be elevated, and that's persistent at day 90 as well. And we'll talk in a second about why that's important. this is just a slide showing some examples of the histological results. I won't really dwell much on this, but I do want to point out that just looking at for example, this row right here, where you're looking at a scaffold in the pulmonary artery magnified once, compare that to the stent in the pulmonary artery magnified twice. And again, if you look at the 10 times magnification, you can see that there's more cellular deposition around the scaffold than there is around the stent. And that's a little more clear when you look at the 10 times magnification. And that's similar to what we see in the aorta as well, where you can see right underneath my cursor, more cellular deposition around the scaffold than around the stent. So what about angiography? Well, when we looked at percent diameter stenosis, unsurprisingly, we found that at 30 days, the percent diameter stenosis was significantly higher in the scaffold than it was in the stent, meaning that the vessels are more stenotic when we have the scaffold implanted compared to when we have the stent implanted. However, and this is consistent both in the aorta and the pulmonary artery. What was odd to us is that at 90 days, that actually flipped. And it looked like, based on angiographic data, that the scaffold now actually has less diameter stenosis than the stent, meaning almost like the vessel is now grown, or there is less stenosis in the vessels that have the scaffold compared to the ones that have the stent. And this was a little surprising to us because we didn't really expect any significant difference to be seen at 90 days. Remember, these bioresorbable scaffolds resorb over a period of about 18 or 20 or 24 months. And so to have something happen over a period of 90 days was just a little surprising to us. And a similar pattern was observed for aortic late lumen loss, as well as pulmonary artery lumen loss. When we looked at our intravascular ultrasound data, I'm just going to draw your attention to C and D down here. And this is just percent change. So our baseline is 0. And then when you look at 30 days, it looks like the scaffold is narrower, right? There is less area available in the scaffold than there is in the stent. And in the pulmonary artery at 90 days, they seem to kind of almost equilibrate. Whereas again, in the aorta, at 90 days, the scaffold is slightly smaller, but not significantly so. But when you look at 30 days, forgive me, but when you look at 90 days, it almost looks like, again, intravascular ultrasound is showing that the scaffolds actually have more lumen area at 90 days. Again, a little odd to us. When we finally looked at histomorphometric data, the data was a little more consistent with what we had expected, in that at 30 days, percent area stenosis is higher in the scaffold than it is for the stent. At 90 days, it's even more so. So what the histomorphometry data suggests is that the narrowing is actually more significant in the scaffold at 30 days, and it continues to be more significant and even more so at 90 days. And that's true for both aorta and pulmonary artery. And it was also, it showed a higher mean intimal thickness at 30 days and 90 days in the aorta and the pulmonary artery. So moving on to the discussion, really, again, the primary objective of the study, remember, it was a preclinical study. So we're looking at death and adverse events. And we showed that with this particular bioresorbable scaffold, we didn't observe any unscheduled deaths. We didn't see any adverse minor or major events. But secondary objectives, looking at short-term outcome, there seems to be a little bit of a kind of a conflicting data. And so which data did we end up believing? And we felt that the histomorphometric data was more consistent with what we expect. It's also more consistent with studies in adults of bioresorbable stents. You really don't see change by 90 days. You see change, we're talking about years until you can see the change, or at least 6 to 9 months. And we also felt that histomorphometric data is less subjective, and therefore it was a little more reliable because you're asking the computer to do the analysis as opposed to you trying to to look at the screen and get the measurements yourselves. We also didn't have a whole lot of, our population at 9 days was only 5 pigs. While we tried our best to limit the possibility of any outliers, we could still, 1 or 2 of those numbers being a little skewed would definitely skew the data. And so in conclusion, our clinical data demonstrated promising results as far as pediatric scaffold safety is concerned. We definitely need more data, to look at long-term outcomes. We're talking again, 9, 12, 18 months, and also hopefully a larger population to be able to parse out exactly why there was some discrepancy in the histomorphometric data compared to the other modalities. Thank you.
That was very fascinating. Thank you for that presentation. Don't have any questions just yet in the Q&A box, but I have one what is the thickness of the stent versus the scaffold? Are they
That's a great
significantly
question.
different?
Yeah, absolutely. The scaffold is thicker than the stent. And so, in part that could underlie why the luminal area is smaller in the immediate post-implantation. And the reason I highlighted the inflammation data was also that we have much more inflammation in the scaffold than we do in the stent, which is something that's been reported in the literature consistently, that bioresorbable scaffolds just induce much more inflammation, and inflammation drives neointimal hyperplasia. And so not only is the strut thicker, but you're actually inducing more neointimal hyperplasia in the vessels that have the bioresorbable scaffold. So in the short term, that's probably why we have, and we expect it to have, smaller lumen and more diameter stenosis in the bioresorbable scaffold as compared to the bare metal stent.
We have one other question. Are there ways in which you think the scaffold could be changed to improve the histomorphometric and other outcomes?
Ways where the scaffold could be changed to improve the outcomes?
Yep, to improve your findings.
I think to be able to answer that question, we need to look at outcomes of these bioresorbable scaffolds in the long run when they start to resorb. Because I think looking at them at 9 months or at 90 days or 3 months is really doing them a disfavor because they're still going to be much narrower. And in fact, the Absorb trial that looked at the bioresorbable stents in adults actually showed that even at 18 months, the percent diameter stenosis on or percent area stenosis on histomorphometry continued to be larger in the bioresorbable stent. However, the lumen got significantly bigger down the line. And so I think what that means is, because of neointimal hyperplasia, you're still going to have a thicker vessel wall when you have a bioresorbable stent, but ultimately, despite the thicker vessel wall, you're allowing that vessel to grow. And so the vessel now has a bigger lumen despite continuing to have a bigger vessel wall. And that's where the benefit of it comes. So I think to be able to, give it a fair chance, we'd have to run a similar study, but look at 12 months and 18 months, as opposed to just a preclinical short-term 30 days and 90-day assessment.
Great. We'll give you a quick second to catch your breath, but you'll be right back on.
Thank you.
His next presentation is a surgical presentation, a mini pig genetic model, sorry, not surgical, a heart failure transplant presentation, a mini pig genetic model for hypertrophic cardiomyopathy. Take it away.
All right, I'm good to go if you guys are. So I'm switching gears here a little bit, going from just a purely clinical to a purely basic science and wet lab talk. But this is talk this is a work that's currently ongoing at the University of Iowa. The PI for this work is Dr. Farhan Ahmed. And so I'm going to start out by, again, a brief history of why study a hypertrophic cardiomyopathy. And the research here is an attempt to understand the genomic mechanisms that drive HCM. There we go. All right. So I want you to keep your eyes on player 29, Miklos Feher. Unfortunately, Miklos passed away. They were not able to resuscitate him. And on autopsy, he was found to have hypertrophic cardiomyopathy. So to answer the question of why even bother, it's because consequences are absolutely devastating. And I'll show in a bit that it's actually a lot more common than we might have first anticipated. So hypertrophic cardiomyopathy is characterized by both hypertrophy plus or minus obstruction. People used to refer to it as HOCM. We've kind of shied away from that just because you can still have hypertrophy without an obstructive component per se. It's characterized by, there we go, pathophysiological changes that kind of underpin HCM. Include one myofibrillar disarray, and this is a slide just showing the upper panel how nicely organized myocytes exist in a normal heart and how they exist in a heart with HCM, completely disorganized. It's also characterized by fibrosis, and I'll show here in a second that The two panels, the top one is hematoxin eosin stain, where you're looking at myocytes. And the second one is a stain from the heart that has HCM. And you can see blue stain is collagen. Again, indicating more fibrosis in patients that have HCM. There's also a diastolic dysfunction component that I'll talk about a little bit more in a second. But those are the three characteristics of a heart with HCM. One of the things that I find very interesting, forgive me, I'm having some trouble with the slides here. Okay, perfect. One of the things I find most interesting about HCM, and honestly, one of the reasons that I decided to join this lab in particular, was just the fact that hypertrophy in HCM in humans is completely asymmetric, which is completely fascinating because every single cell in the heart has the same genetic abnormality, yet most of the time it's only the septum that hypertrophies, and we don't really understand why. And you can see that 70 to 90% of hypertrophy in humans is asymmetric and involves the septum in particular. Again, I said, it's probably more prevalent than we thought. We used to think it's 1 in 500, which on its own is tremendously prevalent, but more recent studies have shown that it's actually closer to 1 in 250. Mortality is up to 6%, 1 to 6% annually. And if you thought that this is something that only occurs in adults, then you're kind of mistaken. It's 10% of all HCM mortality actually occurs in patients less than 24 years of age. Miklos Feher, the individual whose video you watched, was actually 24 when he passed away. Inheritance is autosomal dominant, and we only really have 50% of all cases have an identifiable genetic cause. And of those 50%, I'll show you here in a second, that the majority of the genetic abnormalities occur in myosin heavy chain 7, myosin binding protein C3, and cardiac troponin T, TNNT2. Those three genes account for about 75% of all known genetic causes. So I'll talk very briefly about animal models just to say that we've really relied on rodent models, mice models, basically up until this point to understand HCM. And they've been tremendously helpful, but they have a number of limitations. One is hemodynamics, right? But the heart of a mouse beats at 500 to 600 times a minute compared to ours. And then it also, the size of the model itself limits our ability to do any advanced studies. There's also the problem that to create HCM in mice, you actually have to create a mutation in an isoform. So you're not actually creating a mutation in myosin heavy chain 7, but an isoform of that gene. Whereas what we tried to do in creating a novel pig model for HCM, excuse me, is one, use a model in where hemodynamics are similar, two, a model where you can actually use the same isoform in humans. In fact, I'll show you in a second that not only is it the same isoform, we use the same mutation that was initially identified as being causative of HCM in the early 90s at the Seidman lab in Boston. You're also able to use these models to do serial invasive studies like biopsies, taking them to the cath lab and doing hemodynamics. So the model that we created is a Yucatan mini pig model. Remember, this is a dominant mutation, so we only did a heterozygous mutation, and it was an R403 knock-in in myosin heavy chain 7. And this is the exact mutation that was identified in the early 90s at the Seidman lab. The first time it was identified that HCM is caused by a genetic mutation was an R403Q mutation. And we did that through homologous recombination and somatic cell nuclear transplant. So I'm going to talk briefly about, the overall pipeline that we have for these animals. We survive them to about 12 months of age, sacrifice them at 3, 9, and 12 months, and they undergo a myriad of testing throughout their life that includes EKGs, blood testing, echoes, MRIs, and taking them to the cath lab on several occasions. And I'm going to try to convince you that our pig model is actually a faithful representation of HCM. And remember, we talked about 3 characteristics that underpin HCM: the myofibrillar disarray, fibrosis, and diastolic dysfunction. And so I'm going to show you data from our own model of myofibrillar disarray. These are pictures from our own animals. You can see wild types, very nice organization of the myocytes compared to the disorganized and the mutant R403Q animals. In fact, there's a disarray score, and you can see significantly different disarrays, more disarray in the mutant in blue compared to the wild type in gray. Next up, we're going to talk about fibrosis, and I'm going to show you that indeed our wild type in the upper two panels compared to the mutants in the lower two panels, there's much less fibrosis in them. Again, this is just a larger picture comparing wild type to the left, the mutant to the right, and again, blue is collagen and fibrosis, and you can even quantify that here looking at the right, where at 3 months and 9 months, you can see significantly more collagen deposition in both the mutants and, in the mutants compared to the wild type. And what's interesting here to note really is I think that at 9 months, you can see more collagen deposition than you can at 3 months, which is kind of consistent with what we know happens in humans, where the older you get, the worse the HCM happens. And then lastly, I'm going to talk about the left ventricular diastolic dysfunction. And just as a brief reminder, when we have pressure volume loops, if you draw a line through end systole of various loops, you'll get a line, the slope of which represents your contractility. Whereas if you draw a line through all the end diastole loops, you'll get a line, the slope of which represents lusitropy or relaxation, right? So the steeper the slope is in end diastole, the more stiff the heart is. And the steeper the slope is in end systole, the more contractile the heart is. And so let's look at what happens when we take our pigs to the hemodynamics lab and get some measurements. Left side is wild type, right side is mutant, black is baseline, blue is we're adding dobutamine. If we look at the line that goes through end systole in the wild type compared to end systole in the mutants, you can see that mutants at baseline have more contractility. They also, interestingly, respond less to dobutamine. So you can see that there is a bigger difference in baseline to a second condition in the wild type compared to the mutants. And then lastly, if we look at end distally right here, you can see that the slope of that line in the mutants is steeper than it is in the wild type. So that tells us that there's actually more stiffness, more left ventricular end diastolic dysfunction, right? So there's more stiffness at baseline, there's more contractility, and there's less responsiveness to adrenergic stimuli. All of them consistent with what we know happens in HCM. A couple of other measurements we took. This is just a cardiac MRI to show you guys an example of a septal hypertrophy that occurs in this particular animal. This is a mutant compared to a wild type. You can clearly see the septum is hypertrophied and the mutant not so in the wild type. Next up, just showing you quickly some EKG data, looking at the axis. Blue is male, red is female, striated is our mutants, and the solid lines are our wild type. And you can see that the axis is more negative in the mutant compared to the wild type, consistent with what we'd expect in someone who has LVH. And this is true for both males and females. QRS duration was also longer in mutants compared to wild type. So again, in males and females. And then finally, one of the measurements you're interested in doing is a TP to TE time. So it's basically the time from peak T wave to the time of end T wave. You kind of split the T wave in two and you measure the latter half. And the reason we wanted to look at that is because in adults, longer TP TE measurements are actually associated with increased risk of sudden cardiac death. And indeed, you can see in our animals as well, we have longer TP TE in both males and females. So now that I've hopefully convinced you that we've created an animal model of hypertrophic cardiomyopathy that faithfully represents the phenotype that we see, how exactly did we use this model to interrogate the genomic mechanisms? Well, in short, we did RNA-seq. We started with RNA-seq. And really quick, I'll just show you that the areas that we studied are at necropsy. We collected 4 different areas, all from the left ventricle. Base apex of the septum, base apex of the left ventricular free wall, as well as a biopsy that were collected at different time points. And I'll spare you the details for the sake of brevity of the numbers of what came from where, and I'll just jump really quick to what came out of this RNA-seq data. So we got all those 4 different necropsies and biopsy, and we did RNA-seq. And the first question we asked is a very simple, put all the information in Excel, look at what's most significantly up and down regulated. And what we saw, and again, this is just a very basic analysis, we saw there were repeat genes coming out through the different areas that we were looking at. One of the most interesting to us was SCN3B. And SCN3B is interesting to us because SCN3B is actually a beta subunit of a voltage-gated sodium channel. The sodium channel that's actually responsible for phase 1 in myocyte contractility, sodium entry into the cell. Well, this is the beta subunit of that. And it's associated with atrial fibrillation, ventricular fibrillation, and Brugada syndrome. And so this was intriguing to us because, you know, could this explain in part why we have a lot more sudden cardiac death in our animals and also in humans. So we validated this data by doing qPCR, and you can see very clearly qPCR shows that R403Q or the mutant pigs have significantly higher SCN3B levels of expression. Next, we wanted to do a little more sophisticated analysis, so we used a software called IPA, Ingenuity Pathway Analysis, that looks at the movement of all your genes, so thousands of up and down regulated transcripts, and it tries to give you an assessment based on those of canonical pathways that are either being up and down regulated. And what we found was some of the most significantly down-regulated pathways included apelin and PPAR alpha. So we looked a little more into this, and apelin is actually a pathway that inhibits cardiac fibroblasts. And it actually works to inhibit fibrosis in the heart. And remember, this is significantly down-regulated, right? It makes sense. PPAR alpha was another pathway of interest to us. And when we looked into it, we found that besides being one of the main regulators of oxidation, it actually inhibits hypertrophy, inflammation, and fibrosis. And again, this is being significantly down-regulated. And in fact, a lit review on PPAR alpha shows that there are mouse models and also in humans, data that supports that PPAR alpha abnormalities are present in both heart failure and hypertrophy. And so the question here that we're now at right now is really, are these changes causing the phenotype, or are they just driven by the disease itself? And we're still in the process of trying to parse that out. Future directions, I think, is exploring SCN3B. We're very interested in that particular transcript and gene, and looking at PPAR alpha and apelin. We also have some data to suggest that there might be some sex differences in the pigs that we have, so we're exploring that. And then lastly, an area of interest to me in particular is trying to understand regional expression differences. Why is it that the septum always hypertrophies, but the left ventricular free wall is kind of a hit and miss? These are my acknowledgements, and I'm happy to answer any questions.
That was another great presentation. Thank you so much for that. We can have our poll, and if anyone wants to post questions in the Q&A. We'll give it another minute, but if there aren't any questions, I think we will move ahead to try and stay as close to schedule as we can. All right, I think we'll move on to the next presentation. Thank you very much, Kamal.
Thank you.
Our final presenter for this session is Defna Magneta. Defna is a fellow at Ann and Robert H. Lurie Children's Hospital of Chicago, and her project is entitled Impact of Public Insurance on Waitlist and Post-Transplant Mortality in Young Heart Transplant Candidates, a UNOS Registry Analysis.
Thank you very much. So this was actually the project that I did for my advanced fourth-year fellowship for heart failure and transplantation, but I stayed on at Lurie as one of the faculty this fall. So I have no disclosures. So pediatric heart transplantation has high waitlist mortality, but in general, excellent post-heart transplant outcomes. And previous studies have shown that socioeconomic status has been demonstrated to affect pediatric heart transplant outcomes. Particularly low socioeconomic position is associated with inferior post-heart transplant survival. And then other studies have also shown that race and socioeconomic position are also interrelated. In adult literature, we know that public insurance has been increasingly funding adult heart transplantation and is actually associated with inferior post-transplant survival. So I sought to look at the impact of public insurance specifically on pediatric and young adult heart transplant outcomes, which had not yet been investigated. All right, so the purpose of my study was to describe the utilization of public insurance over time in pediatric and in young adult heart transplant candidates, to compare characteristics of candidates who had private versus public insurance, and ultimately to assess the impact of having public insurance on waitlist and post-transplant survival. So I used the UNOS, or the OPTN database, in order to perform this analysis, and included isolated heart transplant candidates under the age of 26 that were listed over the 15-year period between 2003 and 2018. I compared demographics and listing characteristics between those with public versus private insurance. And then I assessed waitlist mortality using the cumulative incidence competing risk method, which accounts for the competing outcome of heart transplantation. I looked for factors associated with increased waitlist mortality using univariate and multivariate analysis. And then for post-transplant survival, I looked at graft survival, meaning the endpoint being death or retransplantation, up to 10 years using the Kaplan-Meier technique, and compared between those with and without public insurance using the log rank test. Variables associated with graft loss at various time points were compared using logistic regression. So for the first aim, you can see here that for pediatric patients under 18 years of age, public insurance is predominant, over 50%. And in contrast, in young adult heart transplant candidates, private insurance is more common. And then looking over time, over the 15-year period, public insurance became more common among pediatric candidates, which is the graph here at the right. And then in contrast, young adult heart transplant candidates started to have more private insurance after 2010, which corresponds with implementation of the Affordable Care Act. Now comparing the characteristics at listing for those with private versus public insurance, you can see a few key differences. Specifically that those with public insurance tended to be younger with a mean age of 6 years versus 10 years, and also more likely to be listed status 1A. When you look at heart failure therapies, they were generally similar between the two groups, except for ECMO, which was slightly more common in the private insurance group. Waitlist time was similar between the groups. And public insurance was much more common in patients who were identified as Black or Hispanic. Looking at patterns in insurance coverage as well, for those who achieved heart transplantation, insurance at listing and at transplant tended to be similar. So 90% or greater stayed on the same type of insurance throughout the waitlist period. There was variability when you broke it down by UNOS regions, so that only 4 out of the 11 UNOS regions had predominantly public insurance represented, whereas the rest were more often private insured. Now looking at outcomes related to having public insurance, you can see here that waitlist mortality was increased in those with public insurance in the univariate analysis. However, when accounting for several covariates, this was no longer significant, indicating that public insurance in and of itself was not associated with increased waitlist mortality. Looking at graft survival, we saw something a little bit different. There was increased post-transplant graft failure in those who had public insurance compared to those who did not have public insurance. And if you look, breaking it down by time, really the difference occurs in the later follow-up periods. So at 1 year post-transplant, there was no difference in survival between those with something.
Bear with us, Daphne. I think we lost you for a minute and lost your presentation too.
All right.
take it away.
So interestingly, this impact of public insurance on post-transplant survival was different depending on the candidate's race. So if you see here, this is looking at graft survival over time broken down by racial group, but also by whether or not there was public insurance, with those with public insurance being the dotted lines. And you can see that only in the group patients who were white and had public insurance versus not was there a significant difference between the graft outcomes versus in patients who were Hispanic or Black, whether or not they had public insurance had no impact on graft outcomes. I will note though, however, that as you see transplant recipients who are Black do have inferior survival regardless of insurance type, and this has been demonstrated in many other pediatric studies. There's also regional variation to the impact of public insurance. So as you see here, if you break it down by UNOS region, there are 3 regions that actually have significantly different outcomes for those with and without public insurance, which may indicate that these differences, that there are targeted applications to improve some of these differences, as it doesn't apply to the entire United States. So in summary, public insurance is increasingly utilized in pediatric heart transplantation, but it's less common in young adults. Candidates with public insurance are more likely to be young, Black or Hispanic, and to be listed status 1A for transplant. And candidates with public insurance do have equivalent waitlist survival when you account for several covariates. However, graft survival is worse in heart transplant recipients with public insurance, with a 27% increased odds of graft failure by 5 and 10 years post-transplant. Public insurance actually only impacts graft survival in white heart transplant recipients. However, we again demonstrate that Black recipients have substantially worse graft survival regardless of insurance status. And also interestingly, there's substantial regional variation in graft outcomes depending on insurance status.
That's an excellent presentation with
Oh,
really.
sorry, I had 2 more slides, but it's kind of stuck, so I'm trying to move it along. I don't know if, there we go. Or go back one, here we go. So the limitations of the study are mostly related to the study design. So it is a retrospective database study. So there's always the possibility for missing data, for imputation errors. Fortunately, missing data was rare in this study. And there's also a lack of granularity. So when we see some associations like this, we always wonder what are the underlying causes. There's so many unmeasured confounding variables, such as household income, education status, which were not captured in the database. There's also time period bias. So this was, I elected to do this over a long period of time in order to have larger patient numbers for long-term graft follow-up, because I had the sense that the differences would occur over a longer period. But as a result, there are certain things that are not really captured that might be influencing changes. For example, the implementation of the Affordable Care Act in March 2010. There is the sense that the impact for this was greatest in adult patients, since programs such as CHIP had already reduced uninsured rates for children significantly in the 90s. However, a specific study looking at the impact of the ACA could be performed in this population. And then, So future directions, as always, this study raised more questions probably than it answered, but the biggest questions are specifically what are the factors that drive inferior graft survival in patients with public insurance? I mentioned some of those things which could not be captured due to the lack of granularity, but could potentially be looked at single center or multi-center studies. Are there any inherent biases that contribute to inferior outcomes? Is implicit bias playing a role here? Is there any systemic bias that's putting patients with public insurance at a disadvantage? And also, why does public insurance impact people differently? Why are there differences depending on the patient's race? And why are there differences depending on the UNOS region? So I think the reasons for these changes are likely multifactorial and point to areas in which I hope that we can anticipate and prevent suboptimal outcomes for our patients. Thank you very much.
Excellent. That was a lot of really eye-opening data, so thank you. One question I think I probably know the answer to, but I'll ask anyway. Given your data on the difference between ECMO and VAD utilization in public and private insurance groups, and the data you showed on the outcomes post-transplant, I wonder if there are differences pre-listing. Is there any way to get data on that? Is there any data source for that?
So not with the OPTN database, as that starts with listing, but again, I think that that could definitely be looked at with, single center, multi-center studies. I'm not sure if other databases like FIS have information like that, that could then be combined with different hospital-based databases to kind of learn about that. But I think there is a lot that's not captured here from before listing that would probably also give us a little bit of insight into the path that these patients take.
And then one more question before we take a break. What thoughts do you have regarding what we can do to improve gaps in the outcomes for these patients? And do you think there's potential to learn from the regions where we don't see gaps?
Yeah, I think that that's actually one of the pieces of data I found most exciting was the fact that this does not happen equally across UNOS regions. So I think that my hope is that this sort of just gives us an indication that there are ways that we can improve, and then even turning it back and looking at our own patients. So from our group here at Lurie, we're starting to now look at our own patient population and those with public insurance and what sort of barriers they have to basically successful post-transplant care, because we see that the changes happen over the long term. And so what I wonder is if it's basically things with medications, with all of the visits, catheterizations, transportation that becomes just too much of a burden on these families. So we're turning it back to kind of look at it from a quality improvement perspective.
Excellent. Thank you for the presentations. That was a great session. We will take a break now. I think we're a little bit behind schedule, so we'll extend our schedule. We'll restart at 20 after, so 3:20 Eastern, 20 Central, and well, in just a little bit late. Please stay tuned for our highlighted posters that'll play in just a minute. Welcome back, everyone. Before this slide disappears, I'll just mention next year's meeting. We are planning an in-person meeting at this point. It will be hosted by the University of Iowa. Scheduled date is September 9th to 10th. So please block that off on your calendars and join us in Iowa next year. We will move to our final session of today. We have 6 more great presentations. This session is on outcomes, and our first presenter is Alex Bryant. Alex is a medical student at the University of Wisconsin, and the presentation is entitled Evaluation and Treatment of Suspected Myocarditis in the Pediatric Patient, a Survey of Current Practice.
Wonderful, thank you. Thank you, Dr. Hill, and thank you to everyone for the opportunity to present today. I'm going to talk about an ongoing project related to myocarditis that I'm working on. You can see down here with Dr. John Hoganson and Dr. Scott Hagen. And as you know, myocarditis in the pediatric population is a rare but highly morbid condition, making this diagnosis an important topic for future research. As you can see, up to 19.2% mortality, so it's a very important topic to be discussing. In addition to the high acuity of the disease, there are also very few formalized protocols and poor data to support an appropriate treatment algorithm beyond supportive care. It was because of this lack of data and lack of definitive recommendations that I wanted to look at current practices of cardiologists and intensivists across the country. We devised an anonymous survey, which was sent to the AAP section on cardiology and cardiac surgery, PediHeart.net, and the PEDS CCM listservs. Many of you listening today may have actually completed it for me, so thank you. Due to the nature of the listserv distribution, of course, we aren't able to know exactly how many people completed the survey from those who received it or viewed it, of course, and there's also overlap amongst these groups. Analysis was then completed and is ongoing. So I wanted to start by providing a quick sense of who took the survey. We had a total of 128 providers completed, 84% of whom were cardiologists, and 87% of whom were attendings with several years worth of experience. Most respondents were from academic centers. And those who completed the survey came from a variety of practice sizes, measured by cardiac surgical volume and as well as ICU size and the presence or absence of a dedicated cardiac ICU space. One demographic that I do not have on the slide, but I want to mention is the presence or absence of a formal myocarditis treatment protocol. Only about 30% of respondents worked at institutions with a formal protocol. Notably, most everyone was able to provide medical management of myocarditis, but about half of providers were from institutions with the ability to provide more definitive care in the form of VAD or ventricular assist device or transplant. To describe availability of given therapies a little bit further, this chart here shows the number of respondents who had access to each increased level of therapy, as well as those who were not able to provide that therapy and how far that given therapy was for a patient. As you can see, I was interested I looked at this data because I was interested in understanding access to care. And as you can see, many of those who weren't able to provide medical management, and 40% of them would need to send their patient further than 25 miles away to receive that care. This, of course, poses further risks to the patient in terms of morbidity and mortality. For those without access to advanced care, such as VAD and transplant, about half had access within that 25-mile radius. Moving on to diagnostics, we asked about a number of labs that were run in the initial workup, and interestingly, viral studies were done by about 93% of respondents, all or most of the time, yet only change management for 4% of the time. And we didn't ask this, but it leads to the question of what other types of studies are being run inappropriately, and kind of stewardship of resources and things like that. I was also interested in understanding whether or not the historical standard of cardiac biopsy was still being used. And you can see here that it is, but very rarely. On average, only 4% of centers or of respondents from centers were performing biopsy for a more definitive diagnosis after echo, which I don't have on here because almost essentially everybody used an echo initially. And larger centers provide or perform biopsies more often, up to 8% of the time. And that was one difference between ICU size that was statistically significant. Otherwise, as I said, after echocardiogram, for the initial evaluation, cardiac MRI is used most often to definitively diagnose myocarditis, which did not significantly vary among ICU size or those having a dedicated CICU or protocol. I was very interested in the use of IVIG, considering the lack of definitive data supporting its use in pediatrics, yet the high prevalence of use. And as you can see in this study, we understood that 55% of respondents do use IVIG all or most of the time. Initially, it looked like smaller centers might use it less often than larger or medium-sized centers, and those with a protocol, a formal protocol, used it much more often than centers without one, though we were not able to find statistical significance among those trends. When looking at other immunomodulators, the standard for immune-directed therapy historically was always initially steroids, which are now largely out of favor, as you can see in the chart, and IVIG has replaced their use, being used by most up to 80% of the time between those who use them frequently and sometimes. Other more specific directed therapies are seldom used, such as antivirals or interferon, which is very, very rarely used. So we are keeping it brief. I will wrap up with a comment about just a few of the findings once again. As far as available management, most are able to provide basic medical care to those with suspected myocarditis, but advanced care such as VAD or transplant is limited and unavailable for up to 46% of respondents. Of that group, 36% of whom would have to send their patients further than 25 miles to receive VAD or transplant care. After echo, cardiac MRI is used most often to definitively diagnose myocarditis, and biopsy is rarely used, though it is still used slightly more frequently in the larger centers than smaller ones. And after supportive therapy, IVIG is used by 55% of respondents all or most of the time. And though not statistically significant, trends indicate that IVIG was used less frequently by respondents in small ICUs and more often in those with a formal myocarditis protocol. Finally, I wanted to address a few limitations to the study. Small sample size obviously being one of them. We only had 128 respondents. Additionally, these results really reflect practices by cardiologists, though we intended to gather data from intensivists as well, and that part of the project is ongoing. Selection bias, of course, is also present, considering the listserv distribution and survey style nature of the research. That concludes my presentation. I want to thank Dr. Xiao Zhang for helping me with a statistical analysis, as well as the variety of survey fields that we were able to use to get this out, and of course, many of you who completed the survey. So thank you for your time, and I will take questions now.
Thank you for that presentation. As a reminder to the audience, we'll take questions in the Q&A box. If you want to post a question to the speaker, you can do that at any time during the presentation. As another reminder, please use the poll to rate the presentation. This will be used to help determine awards after the meeting is finished. As one question, for the 36% that had to send their patients more than 25 miles, did you ask how far they would have to send them, or was that the sort of highest category, was greater than 25 miles?
No, we did ask how far, and the majority, it was within 25 to 50, but it was still further than 25 miles. And so care is not impossible to come by, of course, but just further than, in town, essentially.
Yeah, I'm just thinking of some of the more Western areas have very limited pediatric cardiology access, and so it could be hundreds of miles.
Of course, yeah, there were quite a few who responded with an indication that they would have to send their patient greater than 100 miles. We did less than 25, 25 to 50, 50 to 100, and greater than 100.
Great. Thank you very much.
Thank you.
We'll move to our next presentation. Our next presenter is Erin Clem. Erin is a fellow at the Children's Hospital and Medical Center, Omaha. And Erin's presentation is Cardiac Complications in Children with SARS-CoV-2 Associated Multi-System Inflammatory Syndrome, MISC. Go ahead, Erin.
Everyone, thanks for having me here today, and thank you, Dr. Hill, for the introduction. Again, my name is Erin Clem, and I'm a second-year pediatric cardiology fellow here. Today, I'll be presenting our center's experience with multi-system inflammatory syndrome in children, or MISC. To provide a brief background, during the COVID-19 pandemic, a novel disease has emerged that affects children, now called MISC. It typically occurs 2 to 4 weeks after infection with SARS-CoV-2 virus, and it has variable disease presentation with features overlapping with Kawasaki disease and toxic shock syndrome. Notably, there's been a very high proportion of cases among Black and Hispanic population, and I'll touch on that more later in our state. And the disease presentation can be quite severe, although as time goes on, our understanding of the spectrum of disease is evolving. In the state of Nebraska, as of Sunday, we've had just over 38,000 COVID-19 cases. Of these, 5,400 have been in those aged 0 to 19 years old. We've had 53 pediatric hospitalizations and fortunately 0 deaths. In our center, we have collected demographic, clinical, laboratory, and echocardiographic data on 13 patients who've been diagnosed with MISC at our institution between March and September of this year. I compiled the key elements of the data into this large table here, and I'd like to start off by focusing your attention to the left side. We had a 69% of our patients were male, which I think is fairly close to the nationwide experience reported by the CDC. More strikingly, we've had 77% of our patients have been Hispanic, 15% Black, 8% Asian, and very notably 0% white, and I'll talk more about that later. Our patient ages have ranged from 2 to 18 years old, with a mean of 11. Most patients had both PCR and serology testing for SARS-CoV-2. The results of these tests were variable. Some of our patients were positive for both PCR and antibody. Some were positive only for PCR or only for antibody. And in one patient who tested negative for both, this patient nonetheless met CDC case definition criteria due to suspected COVID-19 exposure, as well as the nature of her disease presentation. We also collected data on the peak lab values for cardiac enzymes, including troponin and proBNP, as well as inflammatory markers, including ferritin, CRP, and D-dimer. For troponin, we had a range from normal all the way to 79.4, with a median value of 0.52. ProBNP also ranged quite a bit from normal all the way to 19,100, with a median value of 1,140. Our ferritin median was 352, CRP 19.3, and lastly, D-dimer 5,643. So across the board, we found a significantly wide range of values for all of these things. Next, we looked at the echocardiographic results for these patients, especially systolic dysfunction, coronary artery dilation, and pericardial effusion. Of the 13 patients in our cohort, 11 of them had an echocardiogram. The 2 who did not have any elevation of their proBNP, troponin, or an abnormal ECG. And of the 11 patients who did have an echo, 9 of them were abnormal. On the table here, you can see the zeros and ones, 0 being no and 1 being yes. Some patients had multiple cardiac manifestations, including 2 patients who had all 3. 6 of our patients, or just under half, did have some degree of systolic dysfunction. 1 of them was severe and required emergent atrial septostomy and VA ECMO for 7 days. 2 patients had moderate dysfunction and 3 mild. I think it's worth noting, by the time of discharge, all patients had normalized ventricular function. 7 patients, or just over half, had some degree of coronary artery dilation. This was generally mild, with a maximum Z-score in 1 patient of positive 3.7. And we had documented normalization of Z-scores in 6 patients. The 7th patient has not yet had outpatient follow-up, but at the time of discharge did have mild left main coronary artery dilation. 5 patients, or about 38%, had pericardial effusion, 1 of which was moderate and 4 that were small. Lastly, we looked at the hospital and ICU length of stay for these patients. We found, again, a wide range. The median hospital length of stay was 7 days, ranging from 2 to 25 days. And the median ICU length of stay was 6.5 days, with a range of 1 to 21 days. And 6 of our patients, or just about half, required ICU admission. Just to briefly touch on the clinical course for these patients, 4, or about a third of the patients did require endotracheal intubation. Another 4 required inotropic or vasoactive support. And 2 patients, or 15%, did require VA ECMO. 1 of these patients had developed severe vasoplegia with normal LV function, and that patient required ECMO for 3 days. The second patient actually had severe LV dysfunction and was on ECMO for 7 days. 12 of the 13 patients have been documented to have made a full recovery, at least as best as we were able to tell from available labs and echo. The 1 patient who has not made a full recovery, at least that we know of, again, was that patient who had a mildly dilated left main coronary artery at the time of discharge. But otherwise, our patients have done very well and made a very impressive recovery. Very briefly, the medical treatment for these patients. Almost all patients were treated with IVIG, typically 2 doses, and 6 of the patients, or about half, received high-dose IV methylprednisolone. 3 patients, or about a quarter, received anakinra, and 12 patients, or about 92%, had enoxaparin. Additionally, patients who had coronary artery dilation were treated with aspirin as if they had Kawasaki disease, which was discontinued at the time of coronary artery normalization. I think it's really noteworthy in our hospital how disparate the racial and ethnic percentages of our patients compare with the statewide population. Nebraska is 88% white, 11% Hispanic, 5% Black, and about 3% Asian. However, we had 0 white patients, 77% were Hispanic, 15% were Black, and 1.2% were Asian. So I think to some degree this mirrors the experience nationwide, where Black and Hispanic patients are disproportionately affected. And I do want to also state it's not just a matter of Black and Hispanic patients being infected with COVID-19 more. There certainly seems to be a predisposition for those patients who are infected with SARS-CoV-2 to go on to develop MIS-C. So there may be some important genetic relationship here. At our hospital, we had, our approach was for any patient who was suspected to have MIS-C and who had abnormal troponin, proBNP, or ECG, they received a cardiology consult and echocardiogram. We had 2 heart failure transplant cardiologists who became the designated consultants for both inpatient and outpatient care, and that, I think, increased our consistency and experience. We, of course, collaborated with infectious disease, immunology, and hematology colleagues. And going forward, we've arranged outpatient follow-up for all patients who had any cardiac involvement. In conclusion, MIS-C is a rare but potentially life-threatening complication of SARS-CoV-2 infection. It disproportionately affects Hispanic and Black children, and that has certainly been our experience in Nebraska. Mild coronary artery dilation, systolic dysfunction, and pericardial effusion were all common, but nearly all had resolved by the day of discharge. And again, just to state, cardiac complications resolved in all but 1 patient who has not yet had outpatient follow-up. These patients will be followed serially over the next year for recurrent inflammation, changes to the coronary arteries, and changes to systolic function. I'd like to thank my faculty mentors on this project, Drs. Alice Sato, Jean Balwig, and Angie Yetman for their support. And if there are any questions, I would be happy to answer them.
Thank you for that presentation. I think there's obviously so much we don't know about COVID-19, and I think your study certainly helps us understand some things that we need to investigate further. Particularly striking, as you say, is the racial and ethnic differences and the laboratory differences that we see between patients. Just quite striking how different those are. We have a couple questions in the Q&A box. A couple people have inquired, are you utilizing cardiac MRI in these patients?
A good question. We have not routinely utilized cardiac MRI in these patients. I do know of at least one patient who had a cardiac MRI, but it's not been a consistent approach.
Okay. And then another question, how do you plan to follow these patients longer term? That may be a tough question for you as you're probably not seeing them outpatient, but. Yeah,
I think as you stated, there's a lot we don't know about MISC and kind of the long-term implications. You know, even if we have an echo that shows things have normalized, there's still maybe a question, could there still be some myocardial injury or abnormality? And do they have risk for recurrent coronary artery enlargement down the road, as Kawasaki patients may have? And so we're trying to keep closer eyes on them, even if things seem to have normalized or done very well for almost all of these patients. So I think the exact duration of follow-up is to be determined. And again, we certainly at least want to see these patients at least once as an outpatient to make sure everything is back to normal and they're asymptomatic. But beyond that, I don't know if I can comment in too much detail.
Yeah, I think we've taken the approach of we're going to follow them until we know more, and hopefully we'll find more information about what long-term risks and problems there are with MISC. So we'll keep an eye on them until we know more. That was an outstanding presentation. Thank you very much.
Thank you very much.
We'll move to our next speaker. It's Jana Ochoa, who is a medical student from Medical College of Wisconsin. Her talk is entitled Modified DALYS Averted Equation to Calculate Cost Effectiveness of Humanitarian Congenital Heart Disease Surgery in Peru. Take it away when you're ready.
Thank you for that introduction, and thank you to the Midwest Pediatric Cardiology Society for giving me this opportunity. So I'd like to start with a little bit of background. So congenital heart defects are the most common birth defect worldwide, and consequently, this results in countries that have limited surgical access being disproportionately burdened, as this graph indicates. And so this disproportionate burden results in mortality and morbidity being increased in these countries that have limited access. And that quantity can actually be quantified by utilizing disability-adjusted life years, which is also known as DALYs. DALYs is a global health concept, and it's defined as the years of healthy life lost to disability and early death. So this figure below kind of helps make that a little bit more easily understood by showing the healthy life in gray, and then periods of disability, whether that be disease or some other factor. And then in this little figure, we have someone who is affected by something that affects them for the remaining portion of their life and then also causes early death. So both that years of life lost to disability and those years lost to early death would be both components that would make a disability adjusted life year or a DALY. And so another concept in global health is DALYs averted. And so when surgical care or medical care is increased, then there's a decrease in that burden that we were quantifying earlier. And so now you can quantify how much impact your surgical intervention is causing on these patients to have an increase in life that they would have otherwise lost. And so DALY averted is the number of healthy years that are saved by intervention. In global health, DALYs averted can then be calculated And then you can use that actually to calculate the cost effectiveness of your trip or your intervention by then comparing those dailies adverted to the gross national income per capita of the country that you are intervening in. And so our country of interest for this talk is Peru. In Peru, there's 6,000 children that are born with CHD annually. And then about 3,000 of those children will need surgical intervention by the time that they're 3 years old. And then the cardiac community of Peru has a capacity to perform about 1,000 surgical cases a year. And so unfortunately, there's quite a big burden in Peru of children that are not getting treated that require help. In Lima, which is the capital of Peru, this is the only city where patients can go to get open heart surgery. And so Lima services the entire country. And Lima also, well, Peru has multiple health systems. They have their public system and they have their private. And the public is free for all the citizens, whereas the private requires payment. And so the poorest patients of Peru have to go to the public option, which isn't always necessarily the best. And so at the Instituto Nacional de Salud del Niño, or INSN, which is a public children's hospital in Lima, they have a 450 bed capacity. And they currently have 3 cardiothoracic surgeons, some intensivists and nurses, and 5 pediatric ICU beds. And they see nearly 1,000 new cases CHD every year. And then they are able to do about 200 of those cases. And so once again, there's quite a big burden there where patients are not being able to be treated. So at the Medical College of Wisconsin and Children's Hospital of Wisconsin, we partnered together with INSN to really support their advancement of their pediatric cardiothoracic surgery. And so we did so by going on 2 trips. Our first one was in 2018, and we did 6 cases, and then our second was in 2019, and we did 10. And in this photo, you can see our cardiothoracic surgeon, Dr. Mitchell, on the left, and the Peruvian doctor on the right. And so the purpose of this study is to look at our 2019 trip to Peru and calculate the cost effectiveness of our intervention. And so to do that, we're going to calculate the dailies adverted. And to do so, we looked at the literature and we saw it was historically used as an equation. And we put our heads together and we created a modified dailies adverted equation. And so this was the work of a cardiothoracic surgeon putting his input into this equation, and also an actuarial scientist from Northwestern Mutual. And so some of the components that we included in our equation were natural history, disability weight, SDS% mortality adjusted life expectancy, and the age at time of surgery. So we'll go through those in a moment. So natural history is defined as the patient's lifespan without any intervention. And so we went to the literature to find these values for each of the different diagnoses that were in our cohort. And then another component of our equation was disability weights. A disability weight is a diagnosis-specific amount of time that the patient will spend in disability after surgical intervention. Because even with surgical treatment, these patients might have decompensation or require further surgical treatment, and all that time they spend in that state is considered disability. And so we have to calculate, and we have to include that in our calculations so we're not overestimating our intervention's impact. And so we took our disability weights from 2 different studies. One was the Dutch study, which was the disability weights for diseases in the Netherlands. And this was a national study done in the Netherlands. They used a combination of surgeries or surveys for patients, hospital records and looking through hospital lengths of stay, and then expert opinion to determine a percentage of time that patients would spend in disability after their interventions for different diagnoses. And these values were certified as, by the World Health Organization. Another piece of literature we used was the cost effectiveness of humanitarian pediatric cardiac surgery programs in low and middle income countries. This was an international multi-center study from the US that looked at cases done by a humanitarian pediatric cardiothoracic surgery foundation. And they did cases all over the world, in places like China and Iraq and Iran, Libya, Pakistan, Russia. And they used a similar method of using expert opinion to come up with disability weights. And they just kind of filled in some of those diagnoses that the Dutch weight study did not include. And so here's our equation that we came up with. The first portion of the equation is the numbers of healthy years the patient would have lived prior to surgery. And so we took the smaller value, whether that was the age at time of surgery or the years of healthy living that the patient already had that would have been in their natural history. And then the next component was the number of healthy years a patient is expected to live after surgery. And in this section is where we've used the life expectancy that was corrected by STS survival proportion, and then also the disability weight. And then the final piece was the number of healthy years the patient would have lived regardless of intervention, and we had to subtract that out because this was a portion of their life that was healthy that we could not claim to because they would have had it regardless of our intervention. And then another portion of our methods was the cost of the trip. And so we needed to calculate the cost to find the cost effectiveness. And so pieces that went into that were our travel expenses, which included airfare, transportation, meals, lodging as well. And then we also had our disposable surgical supplies that we brought to Peru. And then after every case, I would make sure we had each team member record everything that they were using so we could calculate that very accurately. And then our team's time based on their salary per day, that was another cost. So even though the disposable surgical supplies were entirely donated for our trip, and of course our team's time was also donated, it was still technically a cost from a more global health perspective as far as resources go. So we included that in our costs. And then calculating cost effectiveness, we just took the total amount of cost for the trip and then divided it by the total number of dailies averted. And then we took the cost effectiveness value that we got from that and compared it to the gross national income per capita in Peru. So here's our results. For demographics, we had 10 children that we were able to treat during our 2019 trip. 4 of them were female. Our ages ranged from less than 1 to almost 18. And then the mean age was just about 10. And then the total dailies averted were 489.7 years of life that was healthy that we gave to our children in total. And then the average per child was 49 dailies averted, so 49 years that we gave back to these kids each. The total cost was $148,000. The majority of that was the cost of the time for our team. And then the cost of the items was the second piece, and then the travel. So our cost effectiveness was $302.8 per daily averted, or $302 for every year of life that we gave back to these kids. And then the gross national income per capita of Peru was $6,740 US dollars in 2019. So in conclusion, we were cost effective because our cost effectiveness value was less than the gross national income per capita of Peru. And so in our conclusions, our next steps are that we're going to continue our partnership with Peru and continue to help advance them through education by going down and doing the cases with them. And then we're also going to continue to apply our modified dailies averted equation to these future trips to make sure that we're being good stewards with our resources. And we really do encourage other organizations to use this equation as well to use it as a good tool. Any questions?
That was excellent. Thank you. One factor that didn't come out or wasn't in it is the benefit of education of the local healthcare providers. Do you think there's a way to put that into numbers? for the future lives they may save with the training and learning they get?
Absolutely. That is definitely a huge component of our trip, and we certainly hope we have a really lasting impact on the surgeons there. We do have future plans to try and calculate that effect just by looking at the number of cases and what type of cases they're doing and the outcomes of their cases. We do have goals to continue that partnership in that aspect and see how we can impact the community.
Great. And then we have another question in the Q&A. It says, I don't have a sense of what a cost per daily is for the interventions we do here in the US. Do you have any kind of reference for what it costs here?
I do not have a specific value, but I would anticipate it might be a little higher just based on the kind of amount of money we spend here in the US on our healthcare system.
Yes, I would imagine so. That was excellent work. Thank you very much, Jenna.
Thank you.
Our next presenter is Jessie Boyett Anderson, who is a resident at the University of Wisconsin in Madison. And Jessie's talk is titled Management of Isolated Bicuspid Aortic Valve, Current Practice Survey.
Thank you, Dr. Hill. I'm delighted to be with you all virtually to share with you the results of a study that some of you may have participated in. Given the prevalence of bicuspid aortic valve affecting between 0.5 and 2% of people nationally, and the absence of pediatric guidelines, my mentor, Dr. John Hokinson, and I decided to survey cardiac clinicians regarding their current management strategies for isolated bicuspid aortic valve. We have no disclosures to make. While bicuspid aortic valve, for many of you who are earlier in your training like me, we typically associate it with disorders of connective tissue, but it can occur in an isolated form. And we do follow up our patients with a bicuspid aortic valve on a regular basis because of the risk of progressive aortic stenosis, regurgitation, and dilatation, as well as the risk of dissection. Up until February of this year, there were no guidelines regarding the follow-up interval or imaging for pediatric patients with bicuspid aortic valve. In February of this year, new guidelines did come out, appropriate use criteria for imaging. And I want to point out one thing about these guidelines before we move on, and that is that for pediatric patients, there is no recommended interval for imaging for patients who have severe disease, because in all of these cases, intervention is anticipated. And we'll come back to that with some of the data that I'll share with you later. There was one study that we looked at prior to conducting our research that assessed one institution's pattern of follow-up for these patients. This was Yamaguchi et al. In 2017, looking at Intermountain Healthcare. And they determined that those patients who were younger or who had more severe disease were followed up at shorter intervals. We determined that we would do a survey. Unfortunately, we did our survey between March and April of this year, which was right when everyone's email inboxes were filling with a plethora of emails regarding the pandemic that we're all dealing with right now. We sent this survey out to members of the AAP section on cardiology and cardiac surgery, as well as PediHeartNet members. We sent a couple of reminder emails with the understanding that many of them would get lost in the shuffle. And we really wanted to assess 4 different questions. The first one was, at what interval do you follow up patients of different ages who have different degrees of aortic stenosis, insufficiency, and dilation? The second one was, at what point in time do you decide that it's appropriate to have either a surgical or a catheter-based intervention in one of these children? The third question was, do you use medication to manage these patients? And if so, which kind? And the last question was echocardiographic screening of relatives. Do you recommend it? And if so, for which relatives? I'll talk through the results of all 4 of these questions, but really I want to focus on the first one. Before we move further, I want to give you some of the definitions that we used in our study. We had very clear definitions for the various degrees of aortic dilation based on Z-score. However, we only defined severe disease for aortic stenosis and aortic regurgitation. In terms of individuals who responded to our survey, we had 106 responses. Most of them were from pediatric cardiologists, most of them were physicians, and they had been in practice for an average of 18 years with a wide range. Individuals who responded to the survey came from all over the United States, with a large proportion from the Midwest. If some of you were among those respondents, thank you. And we saw representation from individuals who worked at a wide range of facilities, having surgical volume ranging from 0 to more than 300 per year. So these are the graphs that I want to focus the most on. I'm going to spend a lot of time on these next 3 slides. However, I'm also going to come back to this data at the end of my presentation. So if you don't catch everything, know that you'll see this data again. So the main question we were interested in is, how frequently do you follow up your patients if they have an isolated aortic valve? And we asked this question for patients of various ages. You can see this up in the right-hand corner of your screen for newborns, 1-year-olds, 6-year-olds, 12-year-olds, and 18-year-olds. And we asked it separately for aortic stenosis, aortic regurgitation, and aortic dilation. So on the y-axis, you can see the number of months between follow-ups for that interval. And on the x-axis, you can see the degree of disease, mild, moderate, and severe. In all of the 3 slides that I'll show you as we move forward in the next 3 slides, there is a shorter duration of follow-up for younger patients, so shown down here at the bottom, and a shorter degree of follow-up or a closer degree of follow-up for patients with more severe disease, mirroring the results of that single center study that I shared with you earlier. Here you can see that for aortic regurgitation, the results were the same. You can see that there is also a wide degree of variability in responses, so the standard error bars. There was quite a bit of variation in how long people would wait to follow up on these patients. And finally, for aortic dilation, you can see the same pattern, right? So there's closer follow-up for those with more severe disease, closer follow-up for those who are younger. Something else to point out on this slide as well is that if you look at the responses for 6- and 12-year-old children, these are pretty much overlap, and they overlapped in the last 2 slides as well, suggesting that during the period of childhood, we're following up with these patients on pretty much similar intervals, regardless of how old they are. So next, moving on to the next question is, when do you intervene on these children? And so we asked this question again for the 3 degrees of severity for each of the 3 problems, stenosis, regurgitation, and dilation, and for each of the 5 age points. As you can see from this graph, no one wanted to intervene in a patient if they had mild or moderate disease. And then when you got to the point of severe disease, there was not uniform agreement that this was the threshold for intervention. So just looking at this qualitative assessment of disease did not give a uniform assessment. And that's one of the points that I'll come back to as well on our last few slides. So then we asked, so if we're not using this qualitative measurement to determine when we're going to intervene, is there some sort of threshold at which we would intervene regardless of symptoms in a child? And so we asked this for surgical or catheter-based intervention in an asymptomatic child. We asked people to indicate what echo mean gradient for aortic stenosis they would intervene at. And you can see that echo mean gradient listed here on the right. There is a statistically significant variation in this number by age. We also asked if they would not intervene at all, regardless of the threshold, if the patient was asymptomatic. And over here on the left, you can see these numbers. About 6 to 9% of people said they would not intervene regardless of threshold if the patient was asymptomatic. And then we also asked, well, so let's say you have an asymptomatic patient and you're seeing increasing echo mean gradients across that aortic valve. Are you going to restrict them from exercise if they don't have any symptoms? You'll note that I have fewer ages listed on this slide, because at the newborn period and the 1-year-old period, it's really not feasible to restrict exercise or activity. Their exercise is feeding and learning how to crawl and walk and all of those other normal developmental things that you can't really restrict. And you'll see here that there is, in this case as well, a significant difference by age according to whether or not people would intervene. This was assessed by repeated measures ANOVA and was significant at the level of p is less than 0.001. And then for the echo mean gradient, there is also a statistical significance to the variation in this number as well at p of 0.004. Then moving on to the third question was, so you have a patient with aortic regurgitation or dilation, do you use medication to manage them? And we asked this using a Likert scale where people could indicate if they would never do that, all the way up to always doing that. For both aortic regurgitation and aortic dilation, 87% of clinicians used medication some of the time, at least some of the time. And then we asked further, well, okay, you're going to use medication, so which medications will you choose? There's a lot of theoretical ideas about which medications will be best for which condition, but there's not a whole lot of good concrete data to sort of bear out those theories. So when we asked, it was interesting to me to see that there was a difference in which medications would be chosen. For aortic regurgitation, there was a preference for ACE inhibitors, whereas for aortic dilation, there was a preference for ARBs and beta blockers. And the last question we asked was, let's say you have a patient who has bicuspid aortic valve, are you going to recommend echocardiographic screening of their relatives? We do know that there's a high incidence of bicuspid aortic valve and other heart lesions in the first degree relatives of patients with a bicuspid aortic valve. Interestingly, there hasn't been a lot of good research on the cost effectiveness of echocardiographic screening in those relatives. And so there were only 82% of clinicians who said that they would recommend screening the relatives of a patient with bicuspid aortic valve. And looking at this pedigree, you can see that most of the people who were recommended to be screened are first degree relatives, parents, siblings, and children, with many fewer individuals recommending screening for grandparents or aunts and uncles. So this is going back to my first question and comparing the data that I showed you at the very beginning with that table that I showed you, the appropriate use criteria. So the colored bars that you can see on this graph represent the ranges of intervals recommended for follow-up by those appropriate use criteria. So you can see months on the y-axis. Pink shows the guidelines recommended in the appropriate use criteria for mild disease in the newborn, 1 year, childhood, and adult period. The blue bar shows the range of intervals for follow-up at the newborn, 1 year, childhood, and adult ages. And then the black lines represent the data from our study. So this slide shows the data for aortic stenosis and shows that for mild aortic stenosis, which is the black line with the circles, we follow up at an interval during the newborn and 1 year period that's significantly longer than recommended for in the new appropriate use criteria, but then shorter than is recommended by the appropriate use criteria once we get to the adult range. And you can see the similar findings for the moderate and severe degree of aortic stenosis. And then moving on, you can look at that same data plotted for aortic regurgitation, which shows that our current practice does not completely line up with the guidelines that have been recently put out. Also, you'll notice a striking absence in this graph, and that is the absence of a recommended imaging follow-up for individuals with severe disease, because there isn't one, based on that indication that I shared at the beginning that in the guidelines, it's assumed that patients with severe disease will have some sort of intervention. However, as I showed you in a previous slide, that's not actually the case based on what we do clinically in practice. So just in summary, we're following up at shorter intervals for younger patients and those with more severe disease. This is in line with previous findings. The follow-up intervals for our younger patients are longer than those recommended in the new appropriate use criteria. Intervention is not universally recommended for patients with severe disease. Medical management is common, and there are different medications that are recommended for or preferred for aortic regurgitation versus dilation. And finally, echocardiographic screening is usually recommended for first-degree relatives, but not universally. There are some limitations to my study. I don't seem to be able to advance my slide. Those limitations include the fact that we sent this out as an email survey, And I can't tell you what the difference is between those people who responded to the survey and those people who didn't. So some selection bias. Our sample size, while 106 people is a fabulous number, is rather small compared to the number of people who actually practice cardiology. We did have some imprecise definitions that I shared with you a little bit earlier that we could have clarified a little bit earlier. And we also didn't address mixed disease. So thank you. So the disease that we addressed was only the isolated regurgitation, stenosis, or dilation. I'd like to thank all the people who filled out the survey for me with the different organizations that we sent it to, and also the support staff at the American Family Children's Hospital where I work, who helped both with logistics of survey distribution and statistics afterwards. And I'm happy to take questions at this time.
It's fascinating data. Thank you. I was not aware of the appropriate use criteria. How are those written? Are those minimal time guidelines, so they should be seen at least every X number of years, or are they maximal guidelines?
They they're a range. So it's a range of, see them between 1 and 3 months, or 3 to 6 months, or 2 to 5 years. So you get both your min and your max. And they didn't come out until February of this year. So we were well on our way to completing this study before we found out that they were coming out and thought it was quite fortuitous.
Yeah, it's quite interesting to compare the two. We have another minute for polling and any questions in the Q&A box. All right, no further questions. We will move to our next presentation. It is by Hugh Ta. Dr. Ta is a fellow here at Cincinnati Children's Hospital, and his presentation is entitled Center Variation of Remaining Inpatient from Stage 1 to Stage 2 Palliation, a report from the NPC QIC.
I'd like to thank the committee for the opportunity to discuss our research looking at center variation of remaining inpatient from the interstage period from the stage 1 to stage 2 palliation. In terms of background, the frequency of patients with functional univentricular hearts who undergo single ventricle palliation who remain inpatient in the interstage period is unknown. Our aim was to use the NPC QIC phase 2 database to evaluate the frequency of patients who remain inpatient in the interstage period, and to compare this frequency between centers. Between 2016 and 2019, 1,600 patients were enrolled in the NPC QIC phase 2 database, and we included those patients for our analysis. We excluded patients who were deemed by their institution not to be candidates for stage 2 palliation, or who ultimately underwent biventricular repair. Using the total number of patients entered into the database per year as a surrogate for surgical volume, we categorize centers into small, medium, or large centers, with the cutoffs being less than 5 patients per year, 5 to 9 patients per year, more than 10 patients per year. After applying these exclusion criteria, we had a total overall cohort of 1,453 patients. Of that, 160 patients, or 11%, remained inpatient in the interstage period, with the remainder being discharged after their stage 1 palliation. Our overall cohort in inpatient groups. The median age and median weight at stage 1 palliation was similar between the outpatient and inpatient cohorts. The primary cardiac diagnosis in the cohort overall was hypoplastic left heart syndrome, comprising 75% of the overall cohort. 11% of patients in the overall cohort had a major genetic syndrome associated, and these rates were similar between the outpatient and inpatient groups. With respect to intubation preoperatively, 23% of the overall cohort was intubated preoperatively, and there was a statistically significant difference between the two groups, with 22% in the outpatient cohort versus 35% in the inpatient cohort. With respect to the type of stage 1 palliation that was performed, the Norwood with RV to PA conduit was performed most frequently at 56% of the overall cohort, followed by the Norwood with VT shunt, and approximately 8% of patients had a hybrid procedure. Shifting to our postoperative characteristics, we looked at postoperative ECMO, postoperative complications, a postoperative cardiac arrest, the need for 1 or more postoperative catheterizations, and being reintubated within 48 hours after their initial postoperative extubation. For postoperative ECMO, 18% of the cohort overall required ECMO postoperatively, and there was a statistically significant difference between the outpatient and inpatient groups, with 17% in the outpatient cohort versus 29% in the inpatient cohort. For postoperative complications, this happened in 72% of the overall cohort, and again, there was a statistically significant difference between the two groups, with again 70% in the outpatient group versus 89% in the inpatient cohort. For postoperative cardiac arrest, this happened in 13% of the overall cohort, and the rates were not statistically different between the outpatient and inpatient groups, with 13% for the outpatient cohort versus 19% for the inpatient cohort. For patients requiring one or more postoperative catheterizations, this happened in about 30% of the cohort overall, and there was statistically significant difference between the outpatient and inpatient groups, happening 25% of the time in the outpatient cohort versus 65% of the time for the inpatient cohort. For reintubation within 48 hours after the initial postoperative extubation, this happened in 14% of the cohort overall, and there was statistically significant difference between the two groups, with 12% for the outpatient cohort versus 26% for the inpatient cohort. With respect to our outcomes, we looked at intubation time for more than 14 days postoperatively, and this happened in about 18% of the cohort overall. And there was a statistically significant difference between the outpatient and inpatient groups at about 16% for the outpatient cohort versus 38% for the inpatient cohort. Looking at mortality, this occurred in about 14.5% in the cohort overall, and this rate was similar between our outpatient and inpatient cohorts. When comparing the variation of inpatient status between center sizes, we found that 17.5% of patients from small centers remained inpatient in the interstage period, compared to 9% from medium-sized centers, compared to about 12% from our large centers. We then looked at inpatient status by variation by individual sites. And so this bar chart here depicts this graphically. Along the x-axis, each individual bar represents an individual site. Along the y-axis represents the total number of patients that were entered into the database. The blue portions of the bar denotes the outpatient cohort, and the red portion of the bar denotes the inpatient. We noted that even amongst amongst centers of similar sizes, there appeared to be variation in the frequency of inpatient status. And so our question was whether this was due to patient-specific or center-specific factors, and could either of those factors be used to predict inpatient status? And so to answer this question, we created two different models, one where center size was a random effect, and one where center size was a fixed effect. After accounting for center size, we found that center size was no longer associated with inpatient status. And using the second model where center size was a fixed effect, we then found these patient-specific factors that were associated with inpatient status in the interstage period. If a patient had a normal with sono or a hybrid procedure, they had lower odds of remaining inpatient into the interstage period. Similarly, if they were intubated preoperatively prior to their stage 1, they also had lower odds of remaining inpatient. Conversely, if a patient had a preoperative adverse event, if they required one or more postoperative catheterizations, or they had a postoperative complication, they had higher odds of remaining inpatient in the interstage period. We then performed a secondary analysis to compare the mortality rate between the inpatient and outpatient cohorts. And for this analysis, we excluded more patients. We excluded patients who underwent a hybrid procedure, those who had a length of stay less than 28 days, those who were intubated for more than 14 days, or those who had their stage 2 palliation at more than 240 days of age. To adjust for the multiple confounders that could affect mortality rate, we then employed two different case control matching profiles. In the first match, we used the neonate score to categorize patients into low, medium, or high risk groups and match them based off their risk profile. In the second match, we matched patients based off of a priori selected factors, with those factors being the severity of tricuspid regurgitation, the degree of ventricular systolic dysfunction, prematurity, which is defined as a gestational age less than 37 weeks, birth weight, which is defined as a birth weight less than 2,500 grams, and the need for postoperative ECMO. To briefly review the neonate score, this was published in November 2019, and it's a weighted risk adjustment score to look at your risk for an interstage event being defined as transplant or death. And the score was based off of the type of NOR that a patient had, the need for ECMO postoperatively, if a patient was prescribed opiates at discharge, if they were not prescribed digoxin at discharge, if they had evidence of arch obstruction, if they had moderate or severe tricuspid regurgitation, or if they required supplemental oxygen and also had moderate or severe tricuspid regurgitation. In this study, they found that if a patient had a score greater than 17, they are at high risk of having an interstage event. And in their study, they had a greater than 75% accuracy in predicting the incidence of transplant or mortality. After matching based off of neonate score, we developed this Kaplan-Meier curve. The blue line denotes the outpatient cohort, whereas the red line denotes the inpatient cohort. This inpatient group, the total cohort consisted of 288 patients derived from 49 centers, 7 small, 12 medium, and 25 large, with 72 inpatients being matched to 216 outpatients. The median age of stage 2 palliation for this overall cohort was 139 days, and the inpatient group tended to have their stage 2 palliation performed sooner at a median age of 113 days compared to a median age of 150 days for the outpatient group. For the match based off of the a priori factors, this resulted in a smaller cohort. 68 inpatients were matched to 68 outpatients, giving a total cohort of 138 patients from 41 centers, 4 small, 14 medium, and 23 large. The median age for stage 2 palliation for the cohort overall was 124 days, and similarly, the inpatient cohort tended to have their stage 2 palliation performed sooner at a median age of 111 days versus 139 days for the outpatient cohort. In summary, we found that the frequency of remaining inpatient for the overall cohort was approximately 11%. The overall mortality for the entire cohort was 14%. Inpatient status was associated with center size in univariate analysis, but not multivariate analysis. And patient-specific factors that were associated with inpatient status was your weight at stage 1, your stage 1 type, if you had a preoperative adverse event, if you were intubated preoperatively, if you were required cath postoperatively, or if you had a postoperative complication. For our next steps, we plan to use our institutional costs and utilization patterns to help analyze differences in inpatient versus outpatient management in the interstage period. And with that, I'd like to thank my co-authors and mentors for the help and guidance with this project. And with that, I'm happy to take any questions.
Great job, Hugh. We do have one question in the chat box or in the Q&A. It says you focused on patient-specific factors, but it looks like there are a small number of centers, 4 to 5, that were much more likely to keep a patient in until stage 2 palliation. It didn't look like center size mattered. Did you assess any other center-specific variables?
For our analysis, really, we just used the surrogate of surgical volume just because of, I think, the data that is available within the NPC QIC phase 2 database. But your point of looking at those individual centers, I think it would be helpful to maybe pull those centers and do a smaller analysis to see if within those centers, is that a practice variation because of the site itself, or are there patient-specific factors?
Yeah, and I would say for the way that the NPC QIC has worked, when variation like this is identified, it often leads to further investigations and evaluations of practice variation. And so I think there's more to come on that. We'll give the poll a couple more seconds. All right, and we'll start moving towards our next and final presentation. Our last speaker is Hannah Van Gelder. She is a resident at Children's Wisconsin in Milwaukee, and her project is entitled Investigating Susceptibility to Pulmonary Arteriovenous Malformations Prior to Fontan Palliation in Heterotaxy. Close us out, Hannah.
All right, thanks, Dr. Hill. Hello, everybody. Thank you for sticking around so that I could present our project, Investigating Susceptibility to Pulmonary Arteriovenous Malformations Prior to Fontan Palliation. Oops, sorry. I have no disclosures. Pulmonary arteriovenous malformations, or pulmonary AVMs, are a common complication after palliation for single ventricle congenital heart disease. Case series report that patients with heterotaxy and interrupted IVC increase oxygen saturations after Fontan discharge. The increase in oxygen saturations is attributed to pulmonary AVM resolution or remodeling. Patient susceptibility to pulmonary AVMs prior to Fontan palliation, though, is not well understood. Lack of specific diagnostic tests contribute to limited understanding of pulmonary AVMs and understanding of susceptibility to pulmonary AVMs. There are a couple of modalities we use to assess and diagnose pulmonary AVMs. One is echocardiographic bubble study, and then with cardiac catheterization, we use angiography or oximetry. Bubble studies are sensitive, but have an unclear specificity for pulmonary AVMs. Angiography is largely subjective, and pulmonary vein saturations are not very sensitive and are dependent on the location of the sample. As there is no gold standard for diagnosing pulmonary AVMs, there is no clinical consensus on pulmonary AVM screening or diagnosis. Our objective of this study was to identify whether subgroups of single ventricle patients have increased susceptibility to pulmonary AVMs prior to Fontan palliation. First, we set out to determine the prevalence of pulmonary AVM diagnosis pre-Fontan. And second, we compared oxygen saturations pre and post-Fontan under the premise that pulmonary AVMs cause hypoxia and gradual increase in oxygen saturations after Fontan was indicative of pulmonary AVM resolution. So, we conducted a retrospective chart review of patients seen at Children's Wisconsin between 1999 and 2019. We included patients with single ventricle physiology and Fontan palliation. Next, we selected patients with a diagnosis of heterotaxy and then further divided that group into intact IVC and interrupted IVC verified by echo and cath reports. And then we created a control group of non-heterotaxy hypoplastic left heart patients that was matched by surgical date to the heterotaxy group. Then we investigated for a physician-documented diagnosis of pulmonary AVMs prior to Fontan palliation. A diagnosis of pulmonary AVMs was determined utilizing the best testing modalities available, so echo, bubble studies, cardiac catheterization, or clinical diagnosis documented in a clinic note. Next, we collected oxygen saturations pre-Fontan and a Fontan discharge, and then different time points following Fontan discharge, so 3, 6, and 12 months. We investigated 62 patients with heterotaxy, 48 with intact IVC, and 14 with interrupted IVC, and 62 patients with hypoplastic left heart. In the chart, the top p-value is a 2-group comparison, and the bottom p-value is a 3-group comparison. In looking at patient demographics, we found that heterotaxy with interrupted IVC were more likely to have their Kawashima at a later age than heterotaxy with intact IVC and hypoplastic left heart had their Glenn, which was expected. However, we were surprised to find that there was no significant age difference at Fontan between the 3 groups. And then heterotaxy with interrupted IVC was less likely to have a fenestrated Fontan than the other groups. Next, we looked at pulmonary AVM diagnosis, which is shown in a table similar to the previous slide. Heterotaxy with interrupted IVC were more likely to have a documented diagnosis of pulmonary AVMs pre-Fontan in their chart than compared to heterotaxy with intact IVC and hypoplastic left heart. And heterotaxy and interrupted IVC were more likely to have a bubble study done than the other 2 groups. Most pulmonary AVMs were diagnosed based on bubble study, but not all of them. Then we investigated oxygen saturations at different time points for the 3 groups. Pre-Fontan, there was no statistical difference in oxygen saturation between the 3 groups. This is despite the increased pulmonary venous return for patients with heterotaxy and interrupted IVC following Kawashima. They have a relative hypoxia pre-Fontan, which is possibly indicative of a greater pulmonary AVM burden. At Fontan discharge, patients with heterotaxy and interrupted IVC did not increase oxygen saturations compared to the HLHS group, which is also shown with the heterotaxy with intact IVC group having lower saturations than the HLHS group at Fontan discharge as well. At 3 months following Fontan discharge, however, there was no significance in oxygen saturations between the 3 groups, which then also continued into 6 months post-Fontan and 12 months post-Fontan. Because it appears that each group improves their oxygen saturation following discharge, we then looked at within group changes in oxygen saturation. Looking at oxygen saturations within groups, we found that heterotaxy with intact IVC showed improvements in oxygen saturations from pre-Fontan to Fontan discharge. The improvements in oxygen saturations also continued from Fontan discharge to 3 months, Fontan discharge to 6 months, and Fontan discharge to 12 months. In comparison, patients with heterotaxy and interrupted IVC did not have improvements in oxygen saturations at Fontan discharge. However, patients with heterotaxy and interrupted IVC improved oxygen saturations from Fontan discharge to 3 months, and this also continued at 6 and 12 months. Lastly, in the hypoplastic left heart group, we see that oxygen saturations improved from pre-Fontan to Fontan discharge. However, unlike the heterotaxy group, there was no improvement from Fontan discharge to 3 months. But like the heterotaxy group, they did improve from 6 and 12 months on. From our data, we were able to draw some conclusions. First, although true pulmonary AVM prevalence is not known, patients with heterotaxy and interrupted IVC are more likely to be diagnosed with pulmonary AVMs and have bubble study testing pre-Fontan. And despite variable pulmonary AVM diagnoses, oxygen saturations increase after Fontan discharge for all groups of patients that we studied. The increase in oxygen saturation could be due to pulmonary AVM resolution, AP collateral formation, or a combination of both. And lastly, an objective, systematic approach to pulmonary AVM diagnosis and follow-up is needed to identify patient susceptibility to pulmonary AVMs better understand post-Fontan changes in oxygen saturations. Thank you for your time and attention, and I'm available for questions.
Great presentation, Hannah. While we get the poll up and anyone can post a question in the Q&A, I have a question. What do you think's the chicken and what do you think's the egg? Do you think we're more likely to do a bubble study in a patient with an interrupted IVC and that's why they have a higher rate of pulmonary AVMs? Or do you think because they have a higher rate of pulmonary AVMs, we're more likely to do the bubble study?
Yeah, we were kind of chatting about that too. We don't have obviously clear-cut answer, otherwise we would be able to make that conclusion. However, I think it's a little bit of both. So, I think now we're looking more at bubble studies to kind of get a better idea of the pulmonary AVMs, but I think it started off a little bit reverse.
Yeah, I really like your idea of having a standardized approach in all patients so that we can really know who needs to be evaluated rather than who shows up. I don't see any other questions, but while we wait for that, I'll give everyone a few reminders. Next year's meeting is scheduled for September 9th and 10th. Please mark that in your calendars. We are planning a full in-person meeting in Iowa next year. You can view the posters online at the mwpcs.org. We have the highlighted posters already up. We heard from our web designer that she was having some delays in getting all the posters up, but she said they should be there by the end of the weekend. So you can view all the posters, and then we will be getting some information with the oral abstracts up following that. So all information will be up there. And then we would just encourage everyone to please consider joining the MWPCS. Yearly fees are kept very reasonable at $50. The money helps support the annual meeting and our trainees with awards and travel awards for the meeting. So please consider joining. With that, I think we'll give a round of applause virtually to all of our presenters. I think they did an excellent job. We will be deciding on award winners, and we'll let the audience know by email who our award winners are after that's been decided. So keep an eye out on your mailbox. With that one, everyone stay safe and thank you for joining us. Hope to see you next year.